So now I'm audible. Good afternoon, everyone. Thanks, Dr. Arvind Dev, for inviting me as a faculty, and I welcome all the delegates for this wonderful event. I welcome Dr. Kiran Shah for co-chairing with me. And today's first session and first topic, I welcome Dr. Basuraj to take over the session from here.
Thank you, Dr. Srihari. As you can see, that I am the opening batsman of this Basveshwara Hall, but the opening batsman is hurt with the thing which badly he wants when he wants to speak. So for the same needful, I am actually indebted and grateful for my friend Dr. Vishwanath, who very wholeheartedly has taken up this responsibility in a very short notice. Dr. Vishwanath is basically a young endocrinologist. This is about me, and I think we'll also introduce about the doctor who is going to do the real things. So Dr. Vishwanath is young endocrinologist with very great clinical acumen. With most of the senior endocrinologists knows about his clinical acumen, and he is currently working as a junior endocrinologist at St. John's Medical College Hospital, Bangalore. Over to you, Dr. Vishwanath.
Thank you, sir. Thank you for the kind introduction. So without wasting time, I'll just start sharing my PowerPoint presentation. I hope it's visible to everyone.
Yes, Vishwa.
So the topic that was given was modulation of glucolipotoxicity. So it is known that in a healthy individual, there is a constant turnover in the beta cell mass with an equal balance between apoptosis and as well as neogenesis that's occurring in the pancreatic islets as well. So as and when there is obesity, there is beta cell hyperplasia with the ongoing apoptosis. There is an increase in the beta cell mass as well. But in case of type 2 diabetes, what happens is that there is reduced neogenesis that is occurring with an increased apoptosis leading to atrophy of the beta cells. That is when diabetes manifests, where 70 to 80% is lost. Again, with an in the background of overnutrition, sedentary lifestyles, and genetic predisposition, what we can see is that in the endocrine pancreas, there is reduced beta cell function as well as mass. In case of impaired glucose tolerance or obesity, where it was compensated, it goes into decompensated state in diabetes. Again, in the adipocytes, what we see is there is increase in adipocyte size with an increase in lipolysis, local inflammation, and free fatty acid release that is occurring. In the liver, insulin resistance, that's because of ectopic fat, increased hepatic plasma glucose levels, production, as well as reduced glycogen synthesis and mitochondrial dysfunction that is occurring. The same in muscle, ectopic fat, as well as reduced glucose disposal that's occurring in the muscle, along with reduced glycogen synthesis and mitochondrial dysfunction that's occurring in type 2 diabetic patients. So these are the three important organs, that is liver, adipocytes, and muscle, that show insulin resistance in type 2 diabetes, apart from beta cells in the pancreas. So moving on to mechanisms of glucotoxicity. So in the face of increased glucose, that's in hyperglycemia, there is glycolysis that's happening. So there is increased flux of this glucose 6 phosphate or glucose that's going into sorbitol pathway. So ending up in the main enzyme responsible is aldoketoreductase reductase enzyme here. So other flux pathway is glucosamine 6 pathway, where there is N-acetyl glucosamine glycosylation of the protein products. And the other pathway wherein there is increased glycerol 3 phosphate leading to increase in DHA, and there is activation of protein kinase C and downstream signaling pathways, which will increase the inflammatory pathways like nuclear factor kappa beta. So the other flux pathways increase in the methyl glyoxal, that is increase advanced glycated end products leading to protein adducts. And again, ultimately leading to increased RAGE and RAGE ligands excess as well. So apart from all these four pathways, the unification pathway, which says that glucose flux in the mitochondria will lead to excess reactive, uncontrolled reactive oxygen species generation, that will lead to damaging of the DNA double-stranded DNA. So once there is damage to the double-stranded DNA, there is increased expression of poly-ADP ribosyl phosphorylase enzyme, and this enzyme is known to inhibit the glyceraldehyde phosphate dehydrogenase enzyme, which is downstream enzyme regulating the glycolytic pathway. So once this enzyme is blocked, there is accumulation of all the byproducts in the glycolytic pathway, wherein all the byproducts again feed the complication pathways, that is sorbitol pathway, glucose 6-phosphate pathway, DAG-PKC pathway, or increase in advanced glycated end products. So this is about glucotoxicity, a mechanism of complications. Moving on to lipotoxicity, in face of obesity, there is increased non-esterified fatty acid concentration in the circulation that will ultimately lead to defective insulin signaling, increased active lipogenesis in the liver, and dysfunctional GLUT4 receptor signaling, that is translocation to the plasma membrane is decreased. Again, apart from that, there is dysfunctional lipid storage capacity as well, and this lipid endocrine organ is dysfunctional in obesity. So chronic exposure of pancreatic beta cells to free fatty acids elicits multiple mechanisms of toxicity, predominantly because of accumulation of malonyl-CoA and long-chain fatty acid CoA. So there is increased fatty acid oxidation and esterification because of availability of the free fatty acids. There is accelerated ceramide synthesis because of free fatty acid availability, and this ceramide is again known to inhibit the insulin signaling pathway by the uncoupling of the insulin receptor substrates. And again, the fatty acid also leads to apoptosis and activation of endoplasmic reticular stress. So this image shows that with an increase in saturation from polyunsaturated to unsaturated and saturated, there is increased toxicity by the fatty acids. And similarly, with an increase in the number of chains of the fatty acids, that is from short to long chain fatty acids, we can see an increase in the toxicity. So there's a catch here wherein the free fatty acids in an acute setting will lead to glucose stimulated insulin secretion, whereas the same thing in the chronic phase, that will lead to a toxicity. So coming to action of free fatty acids in the acute setting, wherein we can see that once there is increase in free fatty acids, that's converted to long chain acyl CoA, which is transported to the mitochondria by CPT1, carnitine palmitoyl transferase 1, which undergoes thereby undergoing beta oxidation. There is generation of increased ATP. So this increased ATP to ADP ratio will inhibit the potassium channels. So once there is inhibition of potassium channels, there is increased flux of calcium into the cytoplasm through voltage gated calcium channels. So therein by this there is mediation of the efflux of the insulin by fusion of the vesicles to the plasma membrane. So apart from this efflux of the calcium of the insulin, free fatty acids also act on the GPR40 receptor, activating the phospholipase C, and again has a role in calcium extrusion from the endoplasmic reticular stores as well. So ultimately will leading to insulin secretion. So this is the action of free fatty acids in an acute setting. So when it comes to the chronic setting, there is constant elevation of free fatty acids. Thereby there is reduced intra-endoplasmic reticular calcium stores. And again, there is increased reactive oxygen species, ultimately leading to severe endoplasmic reticular stress. So this would ultimately lead to apoptosis and dysfunction of the endoplasmic reticulum, the cell as a final pathway. So apart from that, there is increased oxidative stress and ultimately leading to mitochondrial dysfunction as well. So now glucotoxicity and lipotoxicity have been discussed independently. Now the interlink between the gluco and lipotoxicity. So whenever there is, in this case, this is a muscle fiber, the glucose enters into the muscle fiber, it's trapped into by the hexokinase to glucose 6-phosphate. So now the fate of this glucose 6-phosphate can be either a glycogen synthesis or an oxidation of the glucose. But however, in the phase of long chain fatty acid excess, there is inhibition of this pyruvate dehydrogenase complex, thereby inhibiting the oxidation of the glucose, leading to accumulation of the precursor molecules. Apart from that, even the long chain fatty acids has also been shown to inhibit the glycogen synthesis as well, leading to accumulation of glucose, causing glucotoxicity. So lipotoxicity in turn causes inhibits glucose metabolism or disposal. So again, in this image, we can see that the free fatty acids circulate in conjunction with albumin in the circulation. They enter into the cytoplasmic compartment. Again, they have to cross the outer and inner mitochondrial membrane to reach the oxidation complex. So that is taken care by the carnitine acetyl transferase 1 and 2. So after the entering into the mitochondria, there is beta oxidation of this fatty acyl CoA and generation of acetyl CoA. So this fate of acetyl CoA has three. One, then it can get converted to citrate and again efflux into the cytoplasm, wherein it can get converted into malonyl CoA, which is again an allosteric inhibitor of this CPT1 enzyme. Apart from that, the other pathway is the TCA cycle, that is Krebs cycle pathway, and the ketone body generation. In the face of excess fatty acids, the TCA cycle is inhibited. That is again the oxidation of glucose is inhibited. Again, the role of glucose on long chain fatty acid metabolism in the face of excess glucose, wherein it enters into the cytoplasm, converts into pyruvate, pyruvate enters the mitochondria. Again, by the PDH complex generates acetyl-CoA. So this acetyl-CoA can be going into the Krebs cycle to give carbon dioxide, water, and ATP, or convert to citrate. So once this citrate enters the cytoplasm, again gets converted to malonyl-CoA. So as I said, this malonyl-CoA excess is an allosteric inhibitor of CPT1. So this CPT1 is a gatekeeper enzyme which transfers the long chain fatty acyl CoA from the cytoplasm to the mitochondria for beta oxidation. So this pathway is inhibited by excess glucose toxicity. So with this excess glucose toxicity and lipotoxicity, that is the excess fatty acid acyl CoA has numerous actions in the insulin signaling pathway. So it inhibits the insulin receptor substrate 1 and PI3 kinase pathway as well. The fatty acyl CoA inhibits the hexokinase 2, and again it inhibits the translocation of GLUT4 transporters to the plasma membrane as well. As I said, it again inhibits the pyruvate dehydrogenase complex, and again it can inhibit glycogen synthase, inhibiting the storage of the glycogen. Again, the excess fatty acids will lead to increased triglycerides, ceramides, DAG PKC pathways activated, Janus kinase 1, reactive oxygen species, and endoplasmic reticular stress, all ultimately leading to cellular dysfunction and contributing to insulin resistance in the liver and endothelium as well. So the type 2 diabetes is an altered state of lipoprotein metabolism, wherein there is overproduction of VLDL, and the defect in insulin suppression of VLDL production actually correlates with the amount of fat that is deposited in the liver. So again, this is a major contributory mechanism which underlies the increase in serum triglycerides that we see in patients with insulin-resistant diabetic patients. So the hepatic fatty acid excess actually comes from the number of derivatives. One is from the dietary chylomicron remnants, or from the non-esterified fatty acids that are released from the adipose tissue, or from postprandial lipolysis of the chylomicrons, and it can be a de novo lipogenesis as well. So in the normal person, this planktonic lipolysis contributes only 5 to 10% to the hepatic free fatty acid, whereas this 5 to 10% increases to 30% in men and women with visceral obesity. And an impaired ability of insulin resistant subjects to store the carbohydrate as glycogen in muscle could be a contributing factor to de novo lipogenesis that occurs in the liver. Apart from that, the adipocyte morphology is also different among patients with type 2 diabetes, especially with the omental and mesenteric adipocyte deposition, where they have a higher rate of lipolysis. They are more responsive to catecholamine stimulated lipolysis, express higher levels of 11 beta HSD type 1 enzyme, and they are less responsive to suppressive effects of insulin. And they are known to liberate excessive amounts of non-esterified fatty acids directly into the portal circulation. So the size also matters for the adipocyte, and the larger adipocyte size, they are more resistant to insulin stimulated glucose uptake and to the suppressive effect of insulin on the lipolysis. And the larger subcutaneous adipocytes, they may predict the development of type 2 diabetes and resistance as well. Whereas the smaller fat cells may be more efficient at the fatty acid uptake. In type 2 diabetics patients, predominantly omental fat deposition and large fat adipocytes play a major role. So now coming on to the main topic, that's targeting glucotoxicity and lipotoxicity. So but the basic funda is that any form of treatment that can bring down the glucose levels would be able to improve the glucotoxicity and lipotoxicity as well. So apart from that, even the diet and exercise, studies have shown that the dietary fiber intake prevents obesity related liver lipotoxicity by modulating SREBP1, that is a steroid regulatory element binding protein pathway. However, the diet and exercise requires a long-term adherence as well, which is difficult for patients. So focusing on, apart from metformin, the queen of all anti-diabetic drugs, the focus is on other drugs like GLP-1 agonist, which has a role beyond glycemic control. It protects the cells against hyperglycemia-induced endoplasmic reticular stress. And it's able to prevent reactive oxygen species-induced endothelial cell senescence via the PKA activation pathway. And again, it prevents hyperglycemia-induced RAGE expression and cardiomyocyte apoptosis in the studies. So again, the reduction of plasma glucose levels in diabetic patients is always associated with some degree of improvement of the insulin action and secretion, regardless of the treatment, like I said. And SGLT2 inhibitors are the one other drugs which have a special importance in this category. Apart from improving the glycemic control, they also reduce the glucotoxicity. The main action is by glucose excretion, and glucotoxicity reduction is by inhibition of oxidative stress and advanced glycated end products and receptor for advanced glycated end product signaling as well. And it is also shown to that the increased N-acetyl glucose glycosylation of the proteins that is seen in O-glucanac pathway that can be prevented by this SGLT2 inhibition. So SGLT2 inhibitors act on the SGLT2 in the kidney, causing glucosuria. The reduced glucose levels leads to enhanced insulin sensitivity in the fat and muscle, that is the target organs, and in the liver as well, that is decreased hepatic glucose production. And in the pancreas, there is increased insulin sensitivity. So treatment with SGLT2 inhibitors that will lead to precipitous fall in plasma glucose concentration. That will lead cells to switch to lipid oxidation to generate energy in the form of ATP. And the increase in this lipid oxidation will lead to reduction in the toxic intracellular lipid metabolites like the fatty acyl-CoA, diacylglycerol, and ceramides. That will lead to a mechanism of reversal of lipotoxicity that can be seen in SGLT2 inhibition. So here in this diagram, apart from the GLP-1, SGLT2, metformin, the classic drugs, there are other newer drugs that have been tried in the studies to inhibit the complication pathways of the glucotoxicity. One is the PARP inhibitors, that's olaparib is one of the drug in that class. Apart from that, the aldose inhibitor, that's epalristat, that's been used for diabetic neuropathy. It's available now, but the efficiency is still unknown. And the advanced glycated end product breakers, one of the drug in this group is alagibrim. Apart from that, there are drugs that is trying to block the NADPH oxidases as well. So coming to reactive oxygen species and the glucotoxicity. So with the beta cells being exposed to hyperglycemic conditions, they generate excess reactive oxygen species through the mitochondria that will lead to increased oxidative stress and cellular damage. So these NADPH oxidases are the ones that are involved in the reactive oxygen species generation in the mitochondria, leading to double-stranded DNA breakdown and PARP activation. So these oxidases belong to the NOx family of proteins, and they transfer electrons across biological membranes. The biological function is to generate reactive oxygen species. So now there is a balance in their function. However, in the phase of hyperglycemia, there is NOx overactivation that will lead to beta cell failure in a patient with diabetes. So now targeting this NADPH oxidases would be one of the pathway to modulate the glucotoxicity complications. Coming to the microRNA, wherein this is an era of microRNAs. So they have tried the microRNAs and the modulation of glucotoxicity. So these are small non-coding RNAs that negatively regulate gene expression at the post-transcriptional level. So one of the microRNA, miRNA 190, the downregulation of this miRNA is an important mediator of glucotoxicity-induced beta cell failure. So they've tried that the overexpression of miRNA 190 exerts protective effects against the glucotoxicity-induced beta cell damage by attenuating the NOx2 mediated reactive oxygen species. And they deliver this mRNA 190 by nanoparticles, and they have seen that there is amelioration of diabetic symptoms, and that could be a potential therapeutic target for type 2 diabetes. Apart from that, there is another microRNA 574-3P that inhibits glucose toxicity induced pancreatic beta cell dysfunction by suppressing the protein arginine methyl transferase 1. So this PRMT1 is modulates epigenetic changes. It also mediates insulin signaling and controls glucose metabolism and insulin secretion. So by targeting this pathway, that could be having a therapeutic and diagnostic significance for patients with type 2 diabetes as well. Coming to targeting of lipotoxicity, the classical drugs thiazolidinediones, it is known to lower fasting and postprandial glucose concentration as well as the circulating free fatty acid concentrations. So this action is through PPR gamma. This PPR gamma is essential for normal adipocyte differentiation and proliferation, as well as uptake of fatty acids and storage in the lipid droplets. And the thiazolidinediones, they increase the number of small adipocytes and the subcutaneous adipose tissue as well. And there is redistribution of fat from the abdominal omental compartment to subcutaneous tissue, and their insulin sensitizing actions either directly through fatty acid steal hypothesis or indirectly by means of altered adipokine release. It will modulate the insulin sensitivity outside the adipose tissue as well. So this fatty acid steal hypothesis, thiazolidine promotes the fatty acid uptake and storage in the adipose tissue, increase adipose tissue mass, and spare other insulin sensitive tissues like liver and skeletal muscle and the pancreatic beta cell from the deleterious effects of these triglycerides as well as fatty acids. So they can improve beta cell function, inhibit apoptosis, and maintain beta cell proliferation. So in the P1 study, it was shown that in a patient with well-defined NASH, it revealed that pioglitazone significantly improved steatosis and inflammation when compared to the placebo arm. So this here we can see that there are different targets to treat lipotoxicity, wherein the activators, wherein the adiponectin receptor activators or agonists, they are activated through the AMP kinase and PGC1 alpha, will lead to mitochondrial biogenesis and thereby bringing down the lipotoxicity. Similarly, like I said, PPAR agonist to the PPAR alpha and PPAR gamma, there is a reduction in lipotoxicity. And by the use of polyphenols and flavonoids, which are known to have anti-inflammatory, antioxidant, and anti-lipolytic gene targets for them, can also have also been studied. And also with the targeting of GLP-1 receptors and liver X receptors, that will lead to ATP binding cassette protein A1 activation that will lead to exflux of the cholesterol from the cell. So this is about activation, and when it comes to inhibition, there are studies showing neutralizing antibodies targeting. Last slide, sir.
Yeah.
Statins can be used to inhibit cholesterol synthesis, and again SRBP1 inhibition and fatty acid uptake inhibition by TGF-beta inhibition as well. So this is a list of drugs that have been tried and the pathways that have been tried to bring down the lipotoxicity. So concluding, lipotoxicity and glucotoxicity provide common ground for the combined defects in the insulin release and action, which is characteristic of type 2 diabetes. Excess glucose and excess free fatty acids both may aggravate the progression of type 2 diabetes.
From some studies on our part as well, so it's around 8.6%. We don't have exact numbers.
That's an excellent talk, Dr. Vishwanath. Thank you. At the last minute, filling it for Basuraj. Yes, he had a severe fever and cough. I can understand how the situation will be at the crucial point. Thank you so much.
Thank you, sir.
Over to Dr. Kiran for further proceeding.
Sir, kindly unmute, sir.
Yeah. Excellent talk, Dr. Vishwanath. Taking us through the glucotoxicity and lipotoxicity, both of them contributing to the demise of beta cells in type 2 diabetes, and the various drugs associated, how we can modulate it. Also the novel therapies, which are possibly difficult to get through with respect to our patient, but at least the basic science is there. Moving on, we have Dr. Mayur Agrawal. He is MD Medicine, DM Endocrinology from SGPGI and DNB Endocrinology. He's MRCP. He's trained in adult and pediatric endocrinology at SGPGI. He's ranked 1 in professional examination, awarded gold medicine in medicine. He's having research work on Sheehan syndrome and Addison's disease. And he's authored many chapters and first closed loop insulin pump in MP Madhya Pradesh, I guess. And he's a founder and director of Hormone India and is a national faculty for Marrow Daily Rounds. Over to you, Dr. Mayur Agrawal, to take us through the brain and the liver control of glucose metabolism.
Thank you very much, sir. Thank you for the kind introduction, and thank you, organizer, for giving me this opportunity. Just let me share my screen. Just a minute. Yeah, I hope it is visible. Yes. So the topic given to me is brain and liver control of the glucose metabolism. I'll be particular to this only topic because it's a very vast topic and we have many inputs from various things. So I cannot cover everything within 15 minutes. And let's start with the question. What do you recall when you hear the word diabetes? First thing that comes into your mind is obviously the blood sugar and insulin, following which you can think about the medicine. So after this talk, I want you to get two more words, that is liver and brain. So this is also very important. That is what I'm going to say in my this talk. Okay, so initially it was just the islet centric approach. That means everything was pancreas, insulin, but now it is the brain centric approach too for the diabetes. So this everybody of you must have heard or seen at least omnes octet, that is 8 parts in the pathophysiology of the diabetes. So we have brain, we have pancreas, muscle, then kidney, liver, and also the adipocyte. So what I'm going to discuss is the left side of the this, that is the brain and the liver in the pathophysiology of the diabetes. So is brain actually involved in the glucose metabolism? Let's see the evidence what we have for this. So the first evidence is in 1984, we had this Claude Bernard who had first evidence that when there was lesion in the fourth ventricle, it altered the glucose metabolism. That time, actually, pancreas was not much like insulin, all those things were not much. So it was told like the brain actually controlled the sugar. Later on, just a minute. So later on, even further animal experiment showed that glucose, when injected in the third ventricle of the rodent, that decreased the blood glucose, okay, by decreasing the hepatic glucose production. So these were first few animal studies which showed that yes, there is brain involved in the glucose metabolism. How does the brain get input? It get input from the various things like the taste. As soon as you intake the food, there is changes in the brain which causes changes in the blood, right? Blood glucose. Then there is this intestinal mucosa which causes changes, that receptor on the intestine that causes the changes. Then hepatoportal receptors are there. Then hormones that I'm coming to later on, like not only the insulin, glucagon, leptin, and all those things. And then we have this insulin independent mechanism. Actually, brain does not have direct the uptake of glucose in the brain is insulin independent. The blood brain barrier that has this GLUT1 receptor which has glucose uptake independent of the insulin. Still in the brain we have this insulin receptor, and how all those work, that I'm going to discuss. So both insulin dependent and independent mechanism that changes everything, right? The central thing changes the peripheral mechanism. So this is an overall out, if you see the broad thing. So input to the CNS is from the glucose, fatty acid, amino acid. I think I lost my slide. Just a minute. Yeah. Yes. Can you see again? Yeah. So we have input from the CNS, the glucose, the fatty acid, amino acid, cholecystokinin, GLP-1, GIP, ghrelin, all those. So that afferent along with the insulin, glucagon, leptin, all those, and the afferents from the sympathetic nervous system. That all inputs goes to the brain, mainly the hypothalamus. From there we have output. We know that there are two parts in the ANS, that's the sympathetic and the parasympathetic. Sympathetic increases the catecholamines and increases the cortisol. So that's from the adrenal. Then this acts also on the pancreas, decreases the insulin, increases the glucagon. So that both mechanism through the sympathetic and the parasympathetic acting in opposite action. And also we have effect on the muscle, on the liver, on the adipocyte, on the pancreas, on the adrenal. So basically brain gives stimulus, either stimulus I would say, or the inputs both increase and decrease to the different peripheral organs, and thereby control this glucose homeostasis. And not to forget, very important, through the ACTH and the cortisol axis, that also I'm going to discuss. Now coming to this heart rate variability. So this is actually a marker of sympathetic and the parasympathetic activity, and we have studies which shows that if the heart rate variability is poor, the obesity, there's association with the obesity and the diabetes, also with the anthropometric indices like the visceral adipose tissue, waist hip ratio, waist circumference, body fat percentage. So this heart rate variability has actually correlation with all these parameters. So that means the brain actually controls the obesity, diabetes, metabolism. Okay. And now even we have data that weight loss either through the surgery or by diet improves the heart rate variability. Coming to the HP axis, that's the hypothalamus pituitary axis. We know that the hypothalamus controls the pituitary through the CRH, which releases the ACTH, which increases the cortisol and all those things. So we have seen all those, the Cushing, when patient go into remission, everything, the diabetes part, the hypertension part controls. Even when the patient are taking exogenous steroid, there is this insulin resistance and obesity. Not only this, there is something in the periphery also, the cortisol axis, that is the 11 beta HSD, that's 11 beta hydroxy steroid dehydrogenase 1, that actually inactivates the, this converts the cortisone into cortisol. That means there is peripheral activation as well as inactivation through the 11 beta HSD2, which converts the cortisol into cortisol. So these two, activation and deactivation, also occurs in the periphery. So this axis is at the central as well as the periphery. And glucocorticoid, we know that not only the glucose homeostasis, it actually controls the lipid protein also, right? So all those metabolism are also controlled by this cortisol. Okay, so when the cortisol is increased, there is impaired incretin secretion, there is insulin resistance, protein degradation, and the glucose uptake is decreased at the muscle level, but increased at the hepatic level. Okay, so gluconeogenesis is increased, insulin resistance is there, visceral obesity increases, dyslipidemia is there, then glucagon is increased and the insulin is decreased. So all this actually pushes towards the hyperglycemia. Okay, and we know all those Cushing's disease patients have all these features, and they even go in remission when the disease is controlled. Okay, now coming to another, how the brain controls, not only this, the brain has also input from the various organs from the food, and it then controls the food intake and the energy expenditure. So it takes input from the glucose, insulin, amylin, pancreatic polypeptide, leptin, GLP-1, CCK, cholecystokinin, polypeptide YY, interleukin 6. So all this actually give inputs to the hypothalamus, paraventricular nucleus, to the arcuate nucleus, and they, through the nucleus tractus solitarius, that's the nucleus of the vagus, they actually control the intake and the energy expenditure. So it's a like a orchestration of various things going on. It's not like one process. It's a multi-input, multi-output process going on through the brain and controlling the metabolism. Is liver involved in the glucose metabolism? Yes, everybody of us know the basic thing. Everybody knows that there is hepatic glucose production through the glucogenolysis, that is the lysis of the glycogen already stored in the hepatic. It increases the glucose through the gluconeogenesis, that's the new glucose molecule is produced, and through this it actually increases, both this mechanism increases the hepatic glucose production, that it is caused the hyperglycemia. Okay, now this something into the more molecular level I'll tell you. So if you see here in the fed state, this is in the fed state, if there is glucose or the glucagon is there, or if the insulin is active, so what will happen, this insulin will activate the AKT pathway and will inhibit the FOXO, that's the forkhead O. Okay, O1. So this will be inhibited, and that will decrease the gluconeogenesis. Similarly, this glucagon receptor also inhibits the glycolysis. Glucose also inhibits this pathway. If you see in the fasting state, what will happen? There is increase in the non-esterified fatty acid, also increase in the glycerol. Basically, that fatty acid is broken down, right? So we get this triglyceride broken down into the glycerol and the non-esterified fatty acid. So this fatty acid, through the beta oxidation, increases the acetyl-CoA, which is a co-stimulator, allosteric stimulator of the pyruvate kinase. So this pyruvate kinase get activated, which converts the pyruvate to OA, that's oxaloacetate, and which converts into, that help into the gluconeogenesis. And this glycerol is converted into the DAP. Okay, that is dihydroacetone phosphate. This again is used for the gluconeogenesis. From the Cori cycle, we get lactate, and this is converted into pyruvate. This is actually used in the same cycle. So this everything is regarding the gluconeogenesis and the glycolysis. Now coming to the glycogen metabolism of liver. So in the fed state, when there is glucose and liver, this insulin will be acted on the insulin receptor through the insulin receptor substrate 1. It will actually increase glycogen synthesis. So this will inhibit the this GSK3, which inhibits this. So this inhibition, that means if this is there, this actually get increased. So glycogen synthetase is increased if there is glucose or if there is insulin through the pathway. If in the fasting state, when these are not there, the glucagon is more and the epinephrine is more, this will act on their receptor, corresponding receptor. It will increase the adenyl cyclase, which will increase the protein kinase A, which will further increase the glycogen phosphorylase and will decrease the glycogen storage. So that's happening in the fasting state. This insulin and glucose thing is happening in the fed state. And we know that during hypoglycemia also this glucagon increases, epinephrine increases. Okay. And this is again the overall pathway I'm trying to coordinate with this. The liver, if you see here, there is one pathway of glycolysis, one pathway of lipogenesis. Here you have this glucokinase, then we have this pyruvate kinase, liver pyruvate kinase. We have ACC, that is acetyl-CoA carboxylase. We have FAS, that's the fatty acid synthetase. So these are main enzymes which actually regulate or the rate limiting steps of this cycle. So if you see here, when there is insulin, it acts on the liver X receptor, which actually acts on the sterol regulatory protein, binding protein, and this have this glucose through the xylulose 5-phosphate also act on the cholesterol regulatory element binding protein. So through this coordinates and this translates this enzyme, and further this controls the glycolysis and lipogenesis. So this is how the liver is acted upon via the enzyme, and it controls the glycolysis or the glucose and the lipid metabolism. So basically there is crosstalk between the liver and the brain. So in the initial side, I have shown you the brain thing, then the liver thing. Also brain have this through this growth hormone and all those also regulates the glucose metabolism. So there are multiple mechanisms going on together. Okay, so this brain and the liver also crosstalks between each other. So here you can see liver through this mediolateral column of the spinal cord act on the hypothalamus, again that arcuate nucleus and the paraventricular nucleus through the nucleus tractus solitarius. Again this has the input is given to the liver from the pancreas through the insulin. And though it's a brain, there is some saturable, transportable GLUT1 and all those, it actually get input from there also. It get input from the liver also. It gives the output to liver again. So it's working in a feedback mechanisms. Okay. So sympathetic innervation, that is from the celiac and the superior mesenteric ganglia, and that get the preganglionic fiber from the T7 to T12 that acts on this different gives to the sympathetic innervation, which cause the increase in the hepatic glucose output. Parasympathetic through the vagus nerve that have the this nucleus directly in the brain, through that decreases the output. So we have this central action of the insulin on the hypothalamus that causes the excitation of the paraventricular nucleus of the hypothalamus, that acts on the vagus neurons, vagus nuclei, that increases the parasympathetic outflow to the liver, that decreases the hepatic glucose production or the hepatic glucose output. So this is how the cycle works. So in the end note, I know the topic is very complex. In the end note, I'll say there's crosstalk between the organs or the system, I would say, via the hormones and the mediators to make a perfect balance. So it's not a single process going on. It's many processes with many inputs and many outputs. So it's really, really complex. So thank you for the patient hearing. Any question is welcome.
Thank you so much, Dr. Mayur. I completely agree with you that the talk, brain and liver crosstalk, or the mechanism was very complex, but I think you made it very simple, given the fact that you are actually drawing the various mechanism or the pathways. Otherwise, believe me, even I would have found it a bit difficult to go through what was happening out there. But to be very honest, you made the complex talk very, very simple, and I congratulate you for that.
Thank you, sir.
Purposefully, I selected this topic for Mayur because I know it was a very challenging topic. Like the one person who can do justice for this topic was Mayur. That is
actually saying what is happening. That is something which is more important otherwise. I mean,
yeah.
Actually, it is otherwise difficult.
Yeah. No, that was a very well deliberated. Means it's a tough topic. The way you presented with writings and all was very excellent. That made us understand easily, actually.
Yeah, actually, I
Always a
teach teach first postgraduate to crack super specialty. So
Yeah.
all those and everything I have to remember.
No, that is the reason you have done so well, because you are into the teaching. So that's why you're writing on the board and teaching.
Thank you. Thank you for giving me this opportunity. Thank you.
Yeah. Thank you, Mayur. Thank you. Go to Kiran. Sherry. Yeah.
Thank you, Dr. Over to the next speaker. It's an honor to introduce Dr. Vinod Mittal. He will be talking on non-alcoholic fatty liver disease in diabetes, a silent syndrome. A brief introduction about Dr. Vinod. He is a senior consultant and diabetologist and head of Center of Diabetes and Metabolics, New Delhi, Heart and Lung Institute. He is the director, Delhi Diabetes Care Center, New Delhi. He is a past chairman and secretary, RSSCI Delhi chapter. He is a regional faculty, graduation and post-graduation from Maulana Azad Medical College, New Delhi. He is a fellow of American College of Physicians, RSSCI, Diabetes India, ICT. He is a master class in diabetes management. He has many other, he is a speaker at many international and national conferences. He is a principal investigator in several research projects and trials and has several publications in peer-reviewed journals. So with this introduction, I warmly welcome Dr. Vinod Mittal. Over to you, sir.
Remind the time. Just remind. Unmute ಮಾಡ್ಕೊಂಡು ಹೇಳಿ.
Yeah. Thank you, Dr. Kulkarni, and it's my proud privilege to share my knowledge on NAFLD and diabetes, a silent killer, and I convey my thanks to my dear close friend Dr. Aravinda for that. And just give me a few seconds. I'll just share my screen. Yeah, is it there? Visible now? Hello?
Yes, sir. Yes, sir.
It's okay?
Yeah. You can start.
Yeah. So good afternoon, everyone. And it's my proud privilege to share my knowledge on NAFLD in diabetes, a silent killer. Overall, NAFLD is generally a neglected problem, unrecognized, but it's a very important and very serious, problem, which if we, handle and, diagnose early, and if we treat it early, we can totally reverse the process. And this NAFLD is not only a, risk factor for chronic liver disease. It is also a risk factor for coronary artery disease, or CVD. So most important point is early diagnosis and aggressive management the day we come to know. And this will not only prevent chronic liver disease, but also cardiovascular diseases. Because NAFLD is also one of the, marker or risk factor, it's a part of insulin resistance syndrome, that is metabolic syndrome, which includes obesity, dyslipidemia, and then, triglyceridemia, hypertension, etc. Now, there have been studies, from India and abroad, and number of studies have shown that almost, 1,000 patients in India, they were screened, and out of which almost, 400 and 550 ladies were there. And it was found, it was across 101 cities, that approximately 56.5% of these people, they had NAFLD. And it was higher in northern states of India than the western states. So that's another important, point, that NAFLD may not be having the same prevalence in all the states. Now, other is the lower one, 19 observational studies, almost 3 lakh patients. And again, out of which, adults, 30% were having NAFLD. So approximately 1/3 of the adult population anywhere approximately has NAFLD. And these NAFLD patients, ultimately future risk of having diabetes is also very high. And this depends on the severity of NAFLD. Milder the NAFLD, lesser the risk. Higher the risk of or higher the grade of NAFLD, more the risk for future diabetes. So basically, world over, 30% of adults, have NAFLD, and hypertension, diabetes, it may be 2/3 or maybe, even 3/4, 70-75% of obese people, diabetic people, and hypertensive people can have NAFLD. And there's a very close link between diabetes and NAFLD, and both these diseases, they increase each other. They try to precipitate, each other, and so that becomes a deadly duo. The basically pathophysiology is that, in fatty liver, there's a, the first hit and the second hit theory. The first hit is whenever we take high calorie or calorie dense diet, there's increased, glucose levels, insulin resistance, there's increased glucose uptake by the liver, and this glucose gets converted into triglycerides, and then triglycerides gets released in the blood as free fatty acids, and these free fatty acids create insulin resistance, not only like in the muscles and adipose tissue, although in the pancreas. And when these free fatty acids are taken up by the pancreas, even 1 gram of these free fatty acids, if taken up by the pancreas, they destroy beta cells. So 1 gram of this fat, it is taken by a pancreas. So in pancreas, there's a dual pathology going on. One is a direct damage to beta cells, and other is insulin resistance. So this keeps on occurring, this high dense calorie diet. And then initially there is, metabolic syndrome, and followed by, bright liver on ultrasound, and ultimately all frank signs of chronic liver disease, cirrhosis. And ultimately, this is a big spectrum. Ultimately, cirrhotic patients can develop hepatocellular carcinoma. Now, basically, it's a complex relationship going on in the liver and muscles, fat, and the pancreas. Now, basically, there is not only an abnormal accumulation, there is also a quality, so abnormal quality and abnormal accumulation of fat inside the liver is the key driver, which leads to this steatosis, inflammation, necrosis, and ultimately damage. So there's a twin cycle hypothesis, which I've just enumerated, that, whenever there is increased calorie dense diet, positive calorie balance, there's increased liver fat, and this liver fat comes out, increased VLDL, free fatty acids, they're taken up by even the pancreas, muscles, and adipose tissue. There's increase in insulin resistance, direct damage to beta cells in the pancreas, leading to hyperglycemia. And then, the liver cycle. So liver and pancreatic cycles are going parallel. And if we have a good control in the initial stage, take my words, we can totally reverse this process. So there's a complex interplay going on between liver, adipose tissue, and muscles, and ultimately leading to all other features of metabolic syndrome, diabetes, hypertension, and ultimately, it affects the cardiovascular system also. So this is again, so basically NAFLD is a continuum. It is not one static. It is a continuum, and this leading to, diabetes and other features of metabolic syndrome, and ultimately cardiovascular disease. Because of paucity of time, I won't be going to detail of this slide, but I think the message is very clear. So diabetes, NAFLD, when both occur, it's a deadly duo. And, NAFLD, one side, it increases the chances of going into NASH and, cirrhosis of liver, then hepatocellular carcinoma, but it has a direct effect on cardiovascular disease also, and also through diabetes and hypertension. So basically, key mechanisms remain acid, ELF score, etc. So basically, FIB-4 score is the most important, and it requires age, AST, ALT, and platelets to be there. And there is a formula here we can see, and depending on this, we calculate the ratio. If it is less than 1.3, it is mild. If it is 1.3 to 2.67, it is moderate, and more than 2.67 is a high risk, case. So there we have to be more aggressive. It's like HbA1c, mild, smaller, less increase is mild. So, we have to be aggressive as per the risk score. So there are other risk scores also, but here I will talk about APRI, which is basically, say AST platelet ratio index. So basically, HG, OT is taken, the patients, then upper normal limit is taken, a ratio divided by platelet count into 100. If this ratio is more than 1, that again is a risk for NAFLD. So this is very easy, we don't need to calculate, a complicated formula. It's basically, we need SGPT and, basically platelet count. That's it, nothing else. So overall, as I mentioned, magnetic resonance elastography is the best, but, I think, this is, even other clinical parameters. Now, in times to come, take my words. Today, we are talking of NAFLD. Tomorrow, we would start talking of MAFLD. It's a metabolic, dysfunction associated liver disease, because NAFLD means non-alcoholic, but there's so many other causes also. And we have to have an objective parameter, but in MAFLD, it's more of a clinical. So once we, show stenosis, maybe on ultrasound, and then, I'll just show you in my next slide, MAFLD, then, basically, a stenosis on ultrasound with any of the following factors. That is either type 2 diabetes or hypertension, obesity. So these are, in case if they are there, or 2 of the metabolic syndrome features. We all know there are 5 metabolic, features of a metabolic syndrome. If any 2 are present, then it is NAFLD. So it's better to label this disease as a MAFLD, because other metabolic diseases are present, and would be very easy to diagnose clinically. We may not go for high-end, investigations, because ultimately the treatment remains lifestyle modifications, and weight reduction. So MAFLD, but the only thing is the parameter 4 becomes little, low is 1.45. It was 1.3 when it was NAFLD. So slightly more than 1.45 to 3.26, and then, high 3.26. Now, management is, again, if there's a simple and pure NAFLD, then, weight reduction and, lifestyle modifications. And if they're associated other diseases like, say, diabetes, then, pioglitazone, metformin. But now we have evidence with GLP-1, SGLT2, and even DPP-4 inhibitors. If there's blood pressure, then obviously ACE inhibitors, dyslipidemia, again statin. So basic, the management is management of the comorbid conditions, but primarily it is weight reduction and lifestyle modifications. Now, so potential therapeutic agents, I've already mentioned, metformin, thiazolidine. Thiazolidine is, among anti-diabetic, the only agent which even reverse fibrosis. The trials have shown the biopsy-proven reversal. Other agents have shown, like GLP-1 and SGLT2, a decrease in hepatic steatosis, decrease triglyceride levels on, CT scan or MRI. But biopsy-proven cases, as of today, we don't know. Then, the latest is we have that agent available, obeticholic acid, which is basically an FXR receptor agonist. It's a farnesoid receptor agonist, which is an anti-fibrotic and anti-inflammatory agent. So that point has to be understood. So to handle NAFLD, what we need is we have to have an effect on lipid metabolism, inflammation, as well as fibrosis, all 3 together. It's not just one. So, we have to have multiple agents, and, the trials are already going on to have more and more agents which can reverse fibrosis and inflammation. Now, we have, among these, we can see there's so many agents going on. Saroglitazar has already been approved by DCGI also, although it has not been approved as yet by FDA because trials are already going on. There are a couple of, trials like evidences 1, 2, 3, and 4, and they have shown that there is some, improvement in like hepatic steatosis, inflammation, etc. Although we need more, large long-term trial data to prove this. So there is decrease in AST, ALT, and there are decrease in other parameters. So with the saroglitazar and, basically fat content also, we can see there's a reduction. So overall, saroglitazar is a PPAR alpha and gamma, dual PPAR alpha gamma agonist. So that is why it is having a lipid lowering as well as a glucose lowering effect. And there are changes in other, CK18 and markers of fibrosis with sarcocletazar. Then we have obeticholic acid. It's already available. Mainly it has been used for biliary, primary biliary cirrhosis. The cases who are not responding to basically chenodeoxycholic acid. It is 100 times more potent as chenodeoxycholic acid, which is an FXR ligand. So this is a molecule, which is available and maybe the molecule of future, but still, we need more data and more trials to, show that. So basically, overall guidelines also show, yes, there are, you can see here, these are number of, like International Association, for Liver Diseases, EASL, like EASD, European Association for Study of Liver. So they are, international organizations, but like we can see here, glitazones and vitamin E. We have these agents, but as of today, again, it is mentioned that it is reserved for controlled studies. We can use off-label, but they're not recommended to be used in all the patients who are non-diabetic that way. So, dear friends, the take-home message is very clear. NAFLD is very common, 1/3 of the normal adult population, because obesity is the main key driver. High energy, high calorie dense diet is the norm today. And 2/3 or maybe 75% of people who are already obese or having type 2 diabetes or hypertension have this problem. It is not a mild thing. It is a serious thing. It's a silent killer. And we already know today the commonest cause for chronic liver disease and cirrhosis is NAFLD, not alcoholic liver disease. And the second is, it is an independent risk factor for the development of coronary artery disease or CVD. So that point also, in a way, if patient comes to us, some, like NAFLD or small grade, increased fatty liver, we don't go for, test and other things. We just straight away, tell the patient to go for lifestyle modifications and try to rule out CVD, diabetes, and hypertension. Those are the things, screening for those disorders should also be done. So it is an overlooked complication, silent killer, but reversible. In the initial stages, it is totally 100% reversible. So early diagnosis, timely intervention, and yes, MAFLD would be a better term to label this, because we can clinically then define and we can start treatment, because otherwise there would be delay, in the treatment. So weight reduction is the only answer today. Low calorie, especially low fructose diet, intensive modifications of other cardiometabolic risk factors like diabetes, dysglycemia, or hypertension, or dyslipidemia. So pharmacotherapy today is basically lifestyle modifications, weight reduction, low fructose diet, and then, treating the underlying disease. So with this, I conclude my talk and I convey my thanks to all of you.
Thank you, speakers. It was a really wonderful session.
Any questions is there, Sri Hari? You can take it. You can see in the chat box. Anything is there? Thank you, sir. Thank you so much for your wonderful deliberation. I would thank Dr. Sri Hari Kulkarni, Dr. Kiran Shah, Dr. Baswaraj, Dr. Mayur Agarwal, Dr. Vinod Mittal for a wonderful deliberations and being a part of our conference. Thank you so much.
Thank you.
Over to Dr. Shweta.
Thank you, sir. Thank you, speakers. It was really a wonderful talk. Our session 1 went on with lots of baggage with knowledge. And let's start our session 2. It is on diabetes and obesity. Let me introduce the rapporteur, Dr. Amit Saraf, MD, FRCP, London, Edinburgh, Glasgow, Director, Department of Internal Medicine, Jupiter Hospital, Mumbai, a famous diabetologist from Thane. And I would like to introduce the chairpersons, Dr. Prabhat, famous diabetologist, Professor of Medicine, SN Medical College, Agra, MD Gold Medalist, FRCP Edinburgh, a famous diabetologist from Agra, and Dr. Saurabh Srivatsav, MD, FRCP, Head of the Department of Medicine and Chief Medical Superintendent of Government Institute of Medical Science. He is a famous diabetologist from Noida. So over to you.
Thank you. Thank you so much. It's always a pleasure to be on any platform hosted by my friend Arvinda. It's one of a wonderful feeling to be here on the ADC 2022. It's always a part. I wish I could have been there in actually for tomorrow for the session, but unfortunately couldn't. So Arvinda, sorry about that, but it's a pleasure to be here, and thank you so much for inviting me. So I believe from the basic science symposium, we move on to the diabetes and obesity symposium. It's a beautiful symposium because we have beauty in the form of Dr. Neeta Deshpande and full of knowledge from Dr. Neeta Deshpande, the others, everybody put together. So Arvinda, how is it going to be? I would be introducing Neeta or the chairpersons. How do I?
Yeah, no problem. We can, chairperson will take over anytime. No problem.
Okay, sure. So over to the chairpersons. Thank you. Thank you so much.
Thank you, sir. Good afternoon, Dr. Arvinda Saus and Dr. Misra Boss and Dr. Saurabh, my colleagues. So we are moving to the next session, that is obesity and the diabetes. We know the both diseases are very pandemic right now. So for this, we have learned 3 speakers in this session. Especially, I welcome first speaker, Dr. Neeta Deshpande. She doesn't know any introduction, but just a formal. She's a MD FRCP, PG Endo from the London. She's a famous diabetologist and bariatric physician from the Belgaum. She's also professor and HOD MM Dental College, Belgaum. She has so many publications to her credit. She's also past chairman of Karnataka RSSDI, like our Professor Arvinda. And now moving to handover session to Ma'am Dr. Neeta Deshpande. She is speaking on the body weight regulation, complexity and chronicity of obesity. Please, ma'am.
Thank you so much, Chairperson. At the outset, I would like to thank Dr. Arvinda for inviting me to this prestigious conference, and I'm so happy to be here. And he has given me a topic which I'm going to try and make simple. I know it's very complex, but it is a very necessary part of our counseling to patients. And you'll wonder why pathophysiology or body weight regulation is part of counseling, but in diabetes, in obesity, it is. So let me start by sharing my slides. Yes. So I'm going to be talking about the pathophysiology and how body weight is regulated and how it is so complex. And that is also the reason why obesity is a chronic disease. And as I said earlier, unless we know this, we will not be able to counsel our patients about the realistic expectations from obesity treatment, which is very, very important because patients may have very unrealistic goals and we need to bring them down to earth with the help of this particular pathophysiology. I do not have any disclosures for this talk. So we all know that we live in a very obesogenic environment, and environmental influences on body weight and a complex interplay between that and the gut-brain axis is what I'm going to talk about. We know that food consumption and food production practices have changed in the last few decades to make up this obesogenic environment. And hence, every individual has different factors at play that can actually be responsible for that person's obesity. And to that end, these are the factors you should be looking at. So it's not just increased intake and decreased expenditure. Each of those has different causes. So whether you're dealing with a slow metabolism or an increased energy intake or reduced activity, each of these important parameters have got reasons, and the reasons differ and vary amongst individuals. So when you're talking about pathophysiology, you also need to understand that these influences or these factors need to be taken into account in order to customize treatment for obesity, because any of these or many of these factors which you see on the screen now could be responsible for that person's obesity and need to be addressed as such for your obesity treatment to be very, very effective. So obviously, obesity pathophysiology has got a lot of physiological contributors in the form of visceral fat and an imbalance in the neuroendocrine regulation, which I'm going to come to shortly, of eating behavior, energy, metabolism, body fat mass, etc., are all responsible for increased caloric intake and reduced expenditure. This is an equation that all of you have seen in the past. If you just look at the intake and expenditure, it looks simple. You match the intake to the expenditure, weight remains same. You make an imbalance between intake expenditure and you should get either an increased weight or a decreased weight. But is that so simple? Well, it's not. The reason being that when you look at the intake side, you have two very important factors there called hunger and satiety. And hunger and satiety are tightly controlled by a homeostatic mechanism, which is the gut-brain axis. So you have something in the periphery, you have something in the brain, they interact with each other and they increase or decrease hunger or satiety, and that is responsible for the intake side of it. The expenditure side, on the other hand, is also regulated, but there is something called metabolic rate, which is going to define how much calories the person is going to expend. Unfortunately for us, when you look at the next slide, you realize that the resting metabolic rate is largely out of control from our hands, from manipulation. The only thing that you can manipulate, as you can see, is the upper 1/3, and that is physical activity. So the lower 2/3 is largely not in our hands. So physical activity is the only thing you can control. What do we learn from this? What you learn from this is that in the active phase of weight loss, physical activity has very little role to play because you can control only 1/3 of it. You can control intake to a larger extent than you can control physical activity causing weight loss in the early phase of obesity treatment, that is the weight loss period. And that is why you will find in all the studies that diet is more important than exercise during the weight loss period. However, the resting metabolic rate, which slows down after you have lost weight, that can be offset a little bit by increasing physical activity, and hence physical activity becomes, that is structured physical activity, becomes more important during the weight maintenance period. And that is why you need to know this pathophysiology, and it becomes a counseling point for your patients. These are the peripheral hormones, the gastroenteropancreatic hormones that regulate food intake. So here you have ghrelin, and then ghrelin is, it's like, dunya ek taraf and joru ka bhai ek taraf. So it is like ghrelin ek taraf, everything else is dusri taraf. So ghrelin is the hunger hormone, and everything else that you see here are the satiety hormones. So this is an important thing to understand, that you are dealing with a whole lot of satiety hormones. Anything can go wrong here, and we know that it does, and that is why pharmacotherapy is targeted towards this. So ghrelin, the hunger hormone, is the one that plays havoc even later on after a patient has lost weight. And these are produced from different parts of the gastrointestinal tract, the pancreas, and they regulate or talk to your brain to increase or decrease hunger. So this is how the networks are, very simply put, and they all merge towards the hypothalamus. And I'm going to show you how they merge towards the hypothalamus to regulate the appetite and the satiety centers. So this, apart from the gastrointestinal tract, you also have adipose tissue, you have leptin, and they also take part in the body weight regulation. You can see here that ghrelin comes from the stomach. You have CCK, GLP-1, etc. coming from the rest of the gut. And then you have leptin over here, adipose tissue, muscle, you have insulin. All these are working towards a network that then talks to the brain, and that is the one that is going to institute the homeostatic control of feeding, energy expenditure, and hormones. Now, this is the central nervous system where the food intake and body weight are regulated. So when you eat, please remember that it is a function or an interplay between all these factors that makes you eat. So you have the sensory factors, that is the taste, smell, appearance, and texture of food. This is the hedonic input. Something looks nice, something smells nice, you wish to eat it, you like it, you start eating it. Cognitive factors are there, such as a conscious control, you're on diet, you don't want to eat, so then you don't eat. Then you have the CNS signals, they all come towards CNS. So then I talked to you about the satiety and the hunger signals, and then the CNS integration of all this. So all of this integrate together and then you eat. But this is an important slide because this is integrating everything together. That is the gut, the adipose tissue, leptin, and the brain, and the axis and the network thereof. So you can see here that you have adiposity signals, you have satiety peptides coming in from the gut, you have hunger signals in the form of ghrelin coming from the stomach, and then you have vagal afferents over here. And all of these are then going to talk to the hypothalamus, mainly the arcuate nucleus. The POMC card area is what we want. The NP by AGRP is the bad area. So this is the good and this is the bad. And you can see here that all the green that you see, increase appetite, and all the mustard that you see, they reduce appetite. So it's very simply put and it is color coded. And you can see very well here that all these peripheral signals come and converge on the hypothalamus at the arcuate nucleus. They will affect the POMC card area or the NP by AGRP area, stimulation or suppression. And this ultimately leads to satiety or hunger. Now, this is a nicely controlled homeostatic mechanism. But remember, there is one thing that can override this entire gut-brain axis. And what is that? That is the hedonic effect of food. What is the hedonic effect of food? The hedonic effect of food is pleasure eating. Basically, very simply put, you are full, your satiety signals are up, your stomach is full, it has talked to the brain tells you that you're full, and then comes a gulab jamun or then comes a kulfi, because I like kulfi. So this thing comes up. You can ignore all the homeostatic mechanisms and you can still eat even if you're full, and that is the hedonic input. And there comes the obesogenic environment, the societal pressure, and that is one of the main causes for the obesity epidemic, as you can see here. Then come the gut microbes. Today we know there is a lot of evidence to tell us that gut microbes affect gut permeability. There's inflammation. Inflammation, leads to alteration of the gut microbiota, and this can cause obesity, it can cause type 2 diabetes. So metabolic inflammation, insulin resistance, and glucose intolerance can result from a bad altered gut microbiome and inflammation. And high fatty foods, processed foods, and increased caloric intake can change your gut microbiota towards inflammation and obesity. So it is one of the major problems that you have. Then comes the last part of my talk, and the last part of my talk is how do these pathophysiological regulators affect weight maintenance. Weight maintenance is extremely challenging because the body perceives dieting, starvation as starvation, and it always tries to pull the patient back to the old weight. And that is because of when you diet, it is perceived as a famine, and there are compensatory biological changes that occur which try to pull the patient back to an original weight and make the patient relapse. And why does this happen? When you lose weight, the compensatory biology changes are in the form of increased ghrelin, which is the hunger hormone, reduced satiety hormones, reduced energy expenditure, which is, as I told you, because of the metabolic rate going down, and the brain response cues, the hedonic pleasure increases. And because of all this, after weight loss, the weight regain is a huge possibility, is the huge challenge because of the compensatory biological changes. Recent research has shown that this metabolic adaptation, this is called metabolic adaptation. This metabolic adaptation can persist for prolonged periods of time, more than even 10 years. So once you've lost weight, the metabolic adaptation that occurs continues, and hence relapse from obesity treatment is a possibility all the time because the metabolic adaptation does not go away. And that is why weight maintenance is challenging, and that is why obesity is a chronic disease. And that is why it needs follow-up, it needs constant tweaking in the form of trying to mitigate the metabolic adaptation. Pharmacotherapy can do that. Metabolic adaptation can be brought down to a certain extent, and the patient tries hard to maintain that weight. So to summarize, obesity can spread over social networks. Environmental factors set the framework for individual obesity. As I showed you in my very first slide, slow metabolism, increased intake, reduced expenditure has many causes, and this is visualized. Genetic factors are important in obesity. Available food is driving the epidemic, the obesogenic environment. Energy expenditure may play some role. Body weight is a regulated system, but you can override that with hedonic inputs. Gut signals affect feeding. I've already told you that. And the gut microbiome is becoming increasingly important. So my take-home messages are obesity needs to be recognized as a chronic disease and not merely a cosmetic issue. It is complex and multifactorial, influenced by genetics, epigenetics, and obesogenic environmental factors. And if you understand pathophysiology well, your management is going to be that much better. Weight regain after weight loss remains the most important problem in obesity management. So I shall stop here, and I will be happy to take questions now or later on. Thank you all very much for a patient hearing, and Dr. Arvinda, thank you once again for having me here.
Thank you, Dr. Nita, for excellent deliberation. It was wonderful to have the pathophysiology of obesity in such a simple words. It was very good. Now I invite, should we take, Dr. Arvinda, should we take questions over here or should we finish the session?
No, you can take at the end also, no problem.
Okay, sir. Okay, sir. So I invite our next speaker. Can we share the screen? Can we see the CV of next speaker? Now I invite Dr. M.V. Ram Mohan. He is MDDM, consultant and endocrinologist, diabetes endocrine clinic, over to Nellore. He is Apollo. He is also working in Apollo Specialty Hospital, Nellore. He is having SHAR ISRO Hospital, Nellore. He is working over there. He is MBBS from Visakhapatnam and MD from Narayana Medical College, Nellore. He is from Andhra Medical College, Visakhapatnam. Over to Dr. V. Ramohan. He will be talking on weight management in adults, guidelines to clinical practice.
Thank you so much. Hope my slides are visible. I'm audible to everybody.
Sir, yes, sir.
Thank you, Arvinda sir, for this wonderful initiative, and hearty congratulations for you on International ADC Summit. And it's indeed a pleasure and honor to be part here. And today's my topic is weight management in adults from guidelines to clinical practice. So this is a small talk, and we know that in India, approximate obesity prevalence is around 23%. It is on the paper only, but we see more and more obese people everywhere. So India tops a 10 rank in poverty one side and tops 5 ranks in obesity. That means how paradox is in India that obesity is increasing day by day. And also, so what are the causes of obesity? We have genes, as told by earlier professor. We have behavior, environment, medicines, culture, and hormones. This is like a vicious cycle which causes the obesity. And just a minute. Yeah. So the mainly the balance shifts. There is a balance between food intake and physical activity. When the balance shifts, we get to tend to obese. It is not a single factor; it's a multifactorial. Mainly overeating, low energy expenditure, and physical inactivity. All these interplay lead to obesity. And why we want to have a treatment for obesity, or why we want to lose our obesity? Mainly, the thing is that there is so much of clinical evidence showing that if we tend to lose our 3 to maybe 5 to 15% of your weight, there is a the complications are coming down. Mainly diabetic prevention, HbA1c reduction, hypertension, dyslipidemia, NAFLD, osteoarthritis, pain syndromes, PCOS, and fertility. All these things tend to cured by themselves if you lose weight. So coming to the management of obesity, we have to individualize the treatment plans, mainly nutrition, physical activity, behavior therapy, pharmacotherapy, and bariatric surgery. These are the guidelines. But when you come to clinical practice, the most important thing is about nutrition. So the lack of education or lack of spending of time with the patient is leading to more and more fallacies and more myths about nutrition in our diabetic patients or non-diabetic obese patients. Mainly, we tend to write in our prescription 1800 calorie diet. And who cares to see that, and who understands better? Nobody knows what is 1800 calorie diet or 2300 calorie diet or 2500 calorie diet. That means that the way we tend to treat our patients should be changed in our clinics. And we need to spend time. You need to have dietitians. You need to have some persons to well trained to explain about the different caloric values of your food items and what are the things to be restricted and how to calculate nutrition value. Because in South India, we eat more carbs. There are plenty of hundreds and hundreds of varieties of food items available, and it is individually very difficult to calculate all these things and tell to our patients. So this is the most difficult part in the clinic when it comes to practice nutrition. So carbohydrates restriction, food diaries, and low calorie diet programs. These are very easy to talk in seminars, but very difficult when you face a patient and he will be having hundreds of questions to you, asking you about what not to eat, what to eat. So then this comes a very problem in your clinic. So then come to physical activity. Same thing, we tell to patient, you do some physical activity. Patient has hundreds of questions. What is the prescription of exercise you are giving, and what are the different type of exercise you should tell to your patient, and what are the uses of them, and also mainly limit the TV and computer time. I tell to my patients, sir, how much is your TV time? She says around 40 minutes per day. You stand for 40 minutes and you see the TV. So whole time when you want to see your TV, you should be standing only, not sitting or sleeping. So or lying on the bed. Like that, small tips to understand. So in clinically, you should be in a communicative way so that to your patient understand better what is the importance of minimal physical activities every day. And this around 150 minutes of intense activity or 300 minutes of walk and weak endurance activity per week is enough. Then behavioral therapy. This is the most difficult thing to treat in any patient. So develop a strong support, eliminate bias or stigma, address stress management, sleep optimization. Other psychological support is also needed, because mainly patients have so much of habits and behaviors which are very difficult to treat and difficult to come out from. The diabetic patients comes to you who is 100 kgs of weight, says that, sir, without eating a candy or without eating a sweet, I can't sleep every day. So this is my behavior, this is my habit. So it becomes very difficult for you to bring him out of that behavior. Then comes the pharmacotherapy. Use of pharmacotherapy as a part of comprehensive program. Mainly the pharmacotherapy of obesity is very limited. My next speaker will be explaining you more about that, and it is very difficult. And because there are no drugs to reduce weight as available. For example, if you want to reduce your blood sugar, there are 100, maybe 30 to 40 drugs available in the market. If you want to reduce your weight, there are very less number of drugs available in the market. Then comes the bariatric surgery is the last option, where if you send maybe if you advise 100 patients, only 1 or 2 goes for bariatric surgery. Then guidelines of so this is how you have to relate from guidelines to your clinical practice, mainly depending on the BMI. So first point is you start with diet and exercise behavior, then comes the pharmacotherapy, then surgery. So in Indian BMI, compare it to international BMI parameters, you have to start your treatment as early as possible. BMI between 23 to 25 only. Start diet and exercise behavior more than 25 to 27. If you have comorbidities, start with pharmacotherapy. If BMI is more than maybe 32.5 with comorbidities, go for surgery. So mainly the initiation is lifestyle therapy. Then comes the, if failure of lifestyle therapy, then go for weight regain on lifestyle therapy, go for medications. Then presence of weight related complications, you have to explain your patients about the need for the weight related therapies available. And we know that the drugs available in our market are mainly orlistat, which we write to most of our patients. And then lorcaserin was there till 2 years back. We used to write for maybe it was late entry to Indian market, and it regained popularity for about 6 to 9 months, and it disappeared again due to side effects. Iphenteramine, naltrexone, we generally don't use them. Then comes the liraglutide, which is there we use an anti-diabetic drugs, and we never use it as a weight reduction drug. 3 mg is available in USA but not in India. So what are the limitations of existing drugs? So orlistat, mainly up to 30% of users have oily stools, fecal urgency, oily spotting, GERD, then fecal incontinence, maybe decreased fat soluble vitamin ingestion, also risk of cholelithiasis and urinary oxalates, kidney stones, which are rarely complaint of this. And GLP-1 agonists may cause nausea, vomiting, and also injectable therapy is also available, and they are expensive. So treatment part, guidelines part, we know that telling or treating a patient is easy, but when you clinically see the patient, when you talk to the patient about obesity, this is the most difficult part. And for example, I have 2 to 3 cases available. For example, case 1, we have 30-year-old male, BMI of 32, weight of 105 kgs. So there are no comorbidities. So, but has a family history of diabetes and hypertension. He asks you how to prevent my diabetes in future or hypertension in future. Mainly, what next? Then you have dietary. You have to explain about diet, exercise, and behavioral therapy. Then you can add a pharmacotherapy. For example, you can add in this patient orlistat to lose the weight. Coming to the next case, we have a 45-year-old female with BMI of 29. She has a pre-diabetes now on investigation. So what pharmacotherapy you have to prevent your diabetes? She asks you. So do I have any drugs to prevent diabetes in future? I'm pre-diabetic now. I don't want to become over diabetes. So you can go with metformin in these patients. You can use newer GLP-1 agonists also in these patients, so that you can prevent diabetes with weight loss, but like an off-label therapy. And you have a 47-year-old patient with BMI of 32, known case of diabetes for 3 years duration, and glimepiride with metformin. Still fasting postprandial HbA1c are very high. So what is the next plan? So as usual, we go with diet, exercise, and behavior. Then we should add a second line agent. So what is the best second line agent among anti-diabetic drugs which will cause weight reduction? We have SGLT2 inhibitors, GLP-1 agonists. Is remission possible with these drugs? So this lady is 3 years old duration with uncontrolled sugars. You start with GLP-1 agonists. Is remission possible? That is the question. So the answer is, if she complies well with GLP-1 agonists, if she loses maybe around 10% of her body weight, there is a fair chances of her being going to remission from diabetes. So yesterday we got a joint EASD ADA management of hyperglycemia and type 2 diabetes newer guidelines. It's a comment statement. It says that estimated obesity is very, very high. So they called for a global action plan on obesity in World Health Assembly in May 2022. Projected US level of obesity is around 50%, and morbid obesity is 25%. In India, it also similarly, I think maybe around 40 to 20% comes to 40% in India. And so we have new drugs coming here. We have use of maybe new drugs where it is published in RCT, where I can't see my. Yeah, so we have RCTs like weight management in diabetes. We have newer drugs like semaglutide and tirzepatide showing very good control of weight and with good HbA1c reduction in this. And mainly, if you see that weight management with metabolic surgery also, there is a good chances of, if you can compare here medical therapy, Rowe and bypass surgery, you can see that the metabolic milieu or metabolic the diabetic patient going to remission is very high in these chances. So achievement and maintenance of weight management goals is very important. Set individualized weight management goals and generalized lifestyle advice, medical nutrition therapy, eating pattern, physical activities, spending time with the patients is very important. And also intensive evidence-based structured weight management programs are very important. And consider medication for weight loss, consider metabolic surgery. When choosing glucose lowering therapies, you go for therapies like GLP-1 agonist therapies or SGLT2 inhibitors, which cause weight loss. So this says that importance of 24-hour physical behavior for type 2 diabetes, mainly sitting, take a break every 30 minutes, then sweating, like doing exercise, then stepping, then comes strengthening exercise, then comes sleeps, good sleep. All these things combinedly will keep you fit and prevent from obesity. So what is, in my opinion, future of obesity is SGLT2 inhibitors, GLP-1 agonists like semaglutide, which are oral available in India now. We are seeing very good results in obesity. Then subcutaneous once a weekly. Then tirzepatide, in future it is going to come to India. Then also one more cagrilintide, which is an amylyl analog. In future it is also coming to India. So all these treatments, all these guidelines make up mainly small part of our treatment plan, but the most difficult thing is making your patient understand clinically the need for obesity treatment and explaining him about the need for you to go for exercise, change your dietary habits, which are there from so many years together in our families. All these things needs a structured and supportive care is needed in our patients. Thank you.
I think a good talk by Dr. Ram Mohan, a very well taken lecture. Can I ask the chairperson to take it forward, please?
Dr. Prabhat.
Dr. Saurabh and Dr. Prabhat can take it.
So, our next speaker is Dr. Sabir Rashid. He is Director and Chief Consultant, Dr. Rashid Diabetes Center, Trivandrum, Chairman of Managing Trustee, Travancore Diabetes Research Foundation, formerly Lecturer of Department of Medicine at Medical College, Trivandrum. He is ex-consultant Indian Institute of Diabetes, Trivandrum. He is a regular speaker of many regional and national forums. He is organizing chairman of the National Diabetes Conference, Diabetes Today. He will be speaking on newer trends of obesity management. So over to you, Dr. Rashid, for your talk on newer trends in obesity management.
Yeah. Thank you.
Yes, you are audible.
Thank you. One second.
First of all, thanks, Sabir, by being part of our conference, because I know you had messaged me that you are having a viral fever with sore throat. So thanks, still you managed. Thank you so much.
Yeah. So thank you, respected chairs, for those kind words. Sorry, I'm down with, as Dr. Aravind told, I'm down with fever and severe respiratory infection. So my voice may not be clear as said, so pardon me. So at the outset, let me thank my dear friend Dr. Aravinda for making me a part of this great academic event. I also congratulate Aravinda and his entire team, ADC, for organizing such a wonderful event. So going straight to our topic. It's something regarding newer trends in obesity management. I think my close friend, Dr. Emma Mohan, has just mentioned some newer medications for obesity management. So in another few minutes, we will quickly update something regarding the updated medications of obesity management. So obesity, once we consider this as the disease of the civilized society, but actually, is it really a disease? Definitely. In June 2013, the American Medical Association declared obesity as a disease in its resolution 420, stating that the obesity is a disease state with multiple pathophysiological aspects requiring a range of interventions in treatment and prevention. So prevalence of obesity, globally, we know that obesity is just growing like anything. So it has tripled since 1975. In India, 15 to 50% of the urban population and almost 8 to 38% of the rural population suffers from obesity. And obesity is more commonly seen in females compared to males and is increasing in both children and adolescents. Coming to the prevalence of obesity in our country, the state of Punjab, followed by our own state Kerala, has the highest prevalence of obesity, almost 30% in females and 22% in males. So what's the actual definition of an adult? Adult is a person. It can be defined as a person who has stopped growing at its ends and is now growing in the middle. So how can we tackle this global issue, obesity? We have multiple traditional weight loss therapies, starting from nutritional therapy, physical activity, behavioral therapy, pharmacotherapy, bariatric surgery, etc., etc. All these have to be individualized accordingly. And our topic, our point of discussion today is something regarding the pharmacotherapy. So definitely, as per Time Magazine, the best way to combat obesity is to build up your biceps in order to push yourself away from the dining table. So definitely, diet and exercise is a major cornerstone in the management of obesity. So all these something like food items are available. So with definitely diet restriction is a major point in achieving obesity management. So if you go with this sort of laddu, halwa, etc., it's not the mummy returns. It's actually going to be the its returns is tummy returns. So coming to the pharmacotherapy, which is our topic of discussion. So we know that going through the timeline, we have multiple medications starting from thyroid hormone preparations in the early 1900s, dinitrophenols, amphetamines, phentermines, etc., etc. Then came the market like sibutramine, rimonabant, orlistat, etc., etc. But what happens to all these molecules? Most of them were banned due to their potent side effects. Just going through one by one, fenfluramine and phentermine combination known as fen-phen has been withdrawn from the market due to its potency in inducing valvular heart disease and pulmonary hypertension. And coming to rimonabant by the name Accamplia by Sanofi, actually it blocks the cellular receptor in the endocannabinoid system of the brain, believed to have significant role in the appetite drive. Actually, earlier it was approved by EMA, European Medicine Agency, in 2006, but in 2008, EMA recommended the suspension of Accamplia due to its potency in inducing severe depression and suicidal tendency. And mind you, FDA never approved rimonabant till now. And these adverse events linked to rimonabant and its ultimate suspension have resulted in the termination of the clinical development of other three cannabinoid receptor antagonists named Merck's taranabant, Pfizer's sotinabant, and BMS. One more molecule was there in the pipeline, but Merck, Pfizer, and BMS have withdrawn the research of all these three molecules. And coming to sibutramine, by the name Meridia by Abbott. It's a centrally acting serotonin norepinephrine reuptake inhibitor. But in 2010, FDA and EMA voted against this in view of its potency to increase the risk of approved anti-obesity medications, cardiac, fecal incontinence, etc., etc. Again, the prescribing information shows orlistat has to be taken 120 milligram thrice daily, at least with main meals, and it's contraindicated for pregnancy and lactation and those with chronic malabsorption symptoms of cholestasis. Again, caution have to be note that concerns about link between orlistat and colon cancer is being investigated. And again, in 2010, FDA approved a revised label for orlistat to include cases of severe liver injury with the use of this medication. And coming to lorcaserin, then by the name Belvic by Arena Pharmaceuticals, it's a selective serotonin receptor agonist. And after repeated rejections by FDA in view of its less efficacy and potent side effects, because concerns about the tumor growth was there, finally it got approved in May 2012. but the FDA has requested for a post-approval trial to assess the long-term cardiovascular effects of lorcaserin. And it's also available in India by the name Effens by Sen Pharmaceuticals. Coming to the few combinations like topiramate and phentermine combination by the name Cusamia by Vivus Pharmaceuticals. This combination topiramate anticonvulsant combined with phentermine appetite suppressant was found effective in weight loss management. Approved by FDA in 2012, but not by EMA, as it was related with, again, with suicidal thoughts and birth defects like their previous molecules. And another interesting molecule is naltrexone and bupropion by the name Foundrain. A combination of naltrexone, 32 milligram, and bupropion, 360 milligram, was approved by FDA as an anti-obesity drug in 2010. But again, concerns were there, including hepatotoxicity, suicidal behavior, and the propensity of bupropion to elicit depressive episodes. Again, so now coming to liraglutide by the name Saxenda by Novo Nordisk. This GLP-1 analog, we all know that liraglutide is a GLP-1 analog, which we are using in our day-to-day clinical practice as an anti-diabetic agent, but in higher dose like 3 milligram, usual dose is up to 0.6 to 1.8 milligram daily. So as at a higher dose of 3 milligram, got FDA approval by the name Saxenda for weight loss management. And it's very interesting information. Wegovy, the game changer in obesity management. High dose, almost 2.4 milligram injectable semaglutide. Semaglutide, I think Dr. Emma Mohan has described regarding the semaglutide as anti-obesity agent, has to be taken once weekly. So high dose semaglutide 2.4 milligram once weekly has got approval as an anti-obesity agent in 2021, and New York Times declared it as a game changer in obesity management, and BBC announced it as a new era in treating obesity. So, which are the anti-obesity drugs in the pipeline or future anti-obesity molecules? So many molecules like cyclistide, lorcaserin, tisofensine, empatic, or so many. I'm not going to the details of all these molecules, but just few of this molecule. Just a word about them. It's a combination of sonisamide and bupropion by the name Empatic by Oregon Therapeutics. A sonisamide, as we know, it's a new generation anti-epileptic. When compared with bupropion, a typical antidepressant is found effective in weight loss therapy. But again, the side effects are out there, includes cognitive impairment, suicidal tendency, etc., etc. So almost all the anti-obesity drugs, or majority of the anti-obesity drugs, one of the side effects might be suicidal tendency or depressive episodes, etc. So we have to be very careful. Again, cyclistide by Takeda and Alizane, it's almost similar to like pancreas. It's a pancreas lipase inhibitor, almost similar to orlistat, which is already there in the market. Tisofensine, another interesting molecule in the pipeline by Neurosearch, is a triple reuptake inhibitor, serotonin, noradrenaline, dopamine reuptake inhibitor, originally investigated for the treatment of Alzheimer's and Parkinsonism. But as the results were supportive for weight loss, it was included as an anti-obesity drug, or the research is going on for as an anti-obesity drug. It has completed phase 2 trial, and the results were reported in the Lancet and showed significant weight loss over a period of 6 months. And another interesting point is tisofensine shares pharmacological properties with sibutramine and has potential to increase heart rate, blood pressure, and also to induce psychiatric disorders. So safety issue has to be taken into consideration. Eslopitant, another very interesting molecule by Pfizer. It's just under trial in animals. It's a neurokinin receptor antagonist. Initially investigated for IBS and for emesis induced by chemotherapy. Studies suggest that it can reduce the appetite for sucrose. But that's something very interesting. It can reduce the appetite for sucrose and hence decrease the consumption of sweetened foods and drinks. Just under trial in animals. Another molecule and the pipeline is beloranib by Safjan Pharmaceuticals. Beloranib, which actually it's an analog of the natural chemical compound fumagillin, and it's a methionine aminopeptidase 2 inhibitor. Initially, it was designed or it was developed for the treatment of cancer, but clinical focus shifted to anti-obesity therapeutics once potential effects of this methionine aminopeptide were realized. And in December 2015, but unfortunately, the phase 3 trials of beloranib has been discontinued by Safjan Pharmaceutical after a second patient death obstacles and thereby getting obstacles for getting FDA approval for the drug. So the development of beloranib by Safjan Pharmaceutical has been discontinued. Setmelanotide, MC3 by Rhythm Pharmaceutical. It's a selective melanocortin 4 receptor agonist. currently being evaluated. It's also being evaluated for rare genetic disorders of obesity such as Prader-Willi syndrome, Bardet-Biedl syndrome, Malmström syndrome, etc., etc. It's approved by FDA in 2020 and EMA in 2021. So it's rather than anti-obesity drug, it's evaluated for rare genetic disorders such as Prader-Willi and Bardet-Biedl syndrome, etc. And validated by Shinogi, again, very interesting molecule, is a neuropeptide Wi-Fi receptor antagonist, thus decreasing hunger and increasing satiety. That's almost the mechanism is almost same. And originally, this molecule was developed by Shinogi as an anti-obesity drug due to its anorectic effects. But unfortunately, again, this molecule was also discontinued for further development after disappointing results showing modest weight loss in phase 2 trials. And this Shinogi is they're trying to combine this valniparit and orlistat, thus exploring something like a new anti-obesity drugs. So it's also there in the pipeline. And pramlintide, simaline by AstraZeneca, amylin, a pancreatic beta cell hormone, acts as a centrally active satiety signal, reduce food intake, show gastric emptying, and reduce postprandial glucagon secretion. Approved by FDA for use both in type 1 and type 2 diabetes along with insulin. And again, another point to be added is divalinated and amylin mimetic peptide has demonstrated in animal studies reduction in food intake and body weight with enhanced metabolic activity. So another interesting information, dual amylin and calcitonin receptor agonist, DACRA, because of their mechanism of action, amylin mimetics coupled with calcitonin receptor agonist, known as dual action amylin and calcitonin receptor agonist, DACRA, are novel anti-obesity drug discovery targets of study. Again, glucagon receptor agonist, the combination of glucagon receptor agonist and GLP-1 agonist, oxytocin modeling. So, few studies shows that co-administration of GLP-1 agonist and glucagon receptor agonist noted an anorectic effect in contrast to the hyperglycemic effect of the glucagon therapy. And oxytocin modeling is a natural GLP-1 glucagon dual receptor agonist peptide produced by the endocrine enteral cells and shown to reduce body weight by almost 2 to 3 kilograms in the treatment group. Studies are still going on in animal studies. And last but not the least, to add up, we have some few anti-obesity vaccines are also there in the pipeline, like ghrelin, somatostatin, etc. I'm not going to the details. Ghrelin, as you all know, secreted by fundus cells of stomach. It's anti-ghrelin vaccination is there in the pipeline. Probably it's effective in weight loss therapy. Again, somatostatin, peptide hormone produced by hypothalamus. Animal studies shows that somatostatin vaccination has been found effective in weight loss therapy. And to conclude, this is another interesting information. Gelesis 100 by the name Plenity by Gelesis. It's actually an oral superabsorbent hydrogel. It absorbs water, expands in the stomach and small bowel, which may result in satiety, thereby leading to obesity management. It got approved by FDA in April 2019 as a medical device for the treatment of obesity. So thank you very much for your patient listening.
Wonderful talk, Dr. Rashid. Many things for me, and I'm sure that many of our audience definitely will be benefited by your wonderful talk, and especially the all talks delivered by all three wonderful speakers, Dr. Neeta ma'am, Dr. Ram Mohan, and of course, Dr. Rashid. So, if any questions?
Amit, you want to ask any questions to the speakers or concluding remarks about this important chapter of diabesity?
Since we have just a few minutes on the clock, with the permission of Arvinda, I think congratulations to all the three speakers. I just have one question to each. So hopefully that should sum it up. So Neeta, my question to you is, usually in the management of obesity, we all have seen the chronic the obesity, the more difficult to get it out. The earlier you start putting on weight and the earlier you sort of intervene, you sort of lose quicker and you maintain a little easier. So any sort of over the years of your practice, of your research, of your academic prowess, any reason for this, that more chronic the obesity, more difficult to get rid of it?
Rather than more chronic the obesity, the more number of attempts that the patient has made to lose weight and put it back on, they are the toughest ones. If a person has had obesity for a very long time and has never tried to lose weight, that person still loses weight more easily. But a person who has kept on trying to lose weight, made efforts, and then put it back on, these are the people with the worst metabolic rates. These are the people who are the slowest to respond to any kind of treatment. So that is what I would say, that relaxing, remitting kind is the worst.
Great. Thank you, Neeta. Thank you so much. Dr. Ram Mohan, one question to you, please. So you had a great talk on from guidelines to the clinical practice. How do you sort of, do the change? So out of all the obesity practical guidelines, the articles, the research work over the years that we've seen, for clinicians, for all of us here, would you want to just quote one sort of a reference trial which you in your practice have used, which really has found benefit in clinical practice? Just one trial which you really have found practically useful.
Maybe we are now using semaglutide very well. The Pioneer trial has a very good result still now and in the market. So we have a very good HbA1c reduction along with good weight loss in the diabetic patients. And so that's a very good trial where we have 1 to 7 trials with different categories. The Novo comes with the molecules where they have a very good robust clinical data behind them before coming to the market. So now the market buzz is about oral semaglutide, and I had a patient for last 3 months who had a highest weight loss of around 11 kgs. Now he is in 14 mg semaglutide, and some of our patients, maybe 10% of our patients on semaglutide are not absolutely happy with 7 mg and 14 mg, but around maybe 80% of patients are very happy with 7 mg. Arvinda sir or Rashid sir, you can give your inputs on semaglutide.
Definitely, as Dr. Rema Mohan told, semaglutide, I think it's one of the best molecules I have ever noted as an anti-obesity drug. Definitely, it's giving results in like blood sugar reduction, but also it's giving good, even as Dr. Rema Mohan pointed out, I is a patient who has some weight reduction of more than 10 kilograms. Even one patient, I got a weight reduction of nearly 12 to 13 kilograms. So definitely, semaglutide, only problem is regarding its cost. Otherwise, it's one of the best molecules right now available, not only as an anti-glycemic agent, but also as an anti-obesity agent.
In fact, my question to Dr. Rashid was exactly going to be the same. So thank you, Dr. Ram Mohan, for asking him that. I think, again, a brilliant round. I think that's a round of applause for the entire speakers, please. And again, Dr. Arvinda, again, for having executed and conducted a beautiful conference. Thank you so much, everybody. Over to you, Arvinda.
Yeah, Shweta, over to Shweta. Well, before that, I'd love to thank Dr. Amit Sharaf, Dr. Prabhat, Dr. Saurabh, Dr. Neeta Deshpande, Dr. Rama Mohan, Dr. Sabir Rashid for being a part of our conference and active participation. Thank you so much. Thank you so much.
Thank you, boss. Thank you.
Thank you, Dr.
Thank you. Thank you, sir.
Over to
Thank
Dr.
you,
Shweta.
speakers.
Yeah.
Yes. Thank you, sir. Thank you, speakers. Thank you, each and everybody. It was a wonderful sharing. And thanks for sharing even the cases also. Thank you, sir. Thanks a lot. Let's go on to the session 3. That is, I would like to introduce the rapporteur, Dr. Deepak Churasam. He is a diabetologist in Junagadh, founder of a Hope Diabetes Clinic and Research Center. He has presented many national and international scientific papers in the field of diabetes, and he has contributed as a co-author in Diabetes book. Welcome, sir. I would also like to introduce the chairpersons, Dr. Abhishek Arun, MBBS, MD, MRCP, FRCP, PhD, consultant diabetologist, and endocrine specialist tenure, Palm Hospital, Lucknow. I would like to introduce Dr. Alpana Sawani, MBBS, Diploma in Diabetology, Consultant Diabetologist, SL Rahizab Hospital, Mumbai, Director Diabetes Specialty. Welcome, ma'am. Welcome, sir. Over to you, sir.
Thank you so much, Dr. Arvinda. Thank you so much. And, congratulations to ADC organizing team as well for the morning wonderful session and lecture. I request, sir, I think you have 2 laptops or something, because background the speaker are continue, that voice is in background. Yeah, yes, thank you so much. Thank you. So our chairperson, Dr. Abhishek Arun and Dr. Alpna Somani ma'am, over to you, and please introduce our first lecturer. Thank you.
Thank you. The speaker for today is Dr. Tejas, and he's a well-known diabetologist and director, IV Diabetes Care Center from Mumbai, and also seems to be honorary diabetologist, SL Raheja Fortis Hospital. He also has diabetes care centers in Malad and Andheri, and he is visiting teaching faculty for fellowship in diabetology at DY Patil Medical College, Navi, Mumbai. He's also founder and president of United Diabetes Forum, which we all know, an organizer and scientific committee and faculty at various CID forums over the years, and speaker at various national conferences at CID, RSGI, IDECON, Diabetes India, and DIACON. And he's also a practicing diabetologist for the last 23 years. So welcome, Dr. Tejas.
Thank you. Thank you so much. Hello, can you hear me?
Yes, we can hear.
Yeah. Can I start? Should I start?
Sure, sir. You can.
Okay.
Yes, sir.
Yeah. Good afternoon, everybody. And first of all, a big thank you to my dear friend. I call him Superstar, my dear friend Dr. Arvinda. And congratulations to him for this wonderful event. Okay, let me start sharing the screen. Okay. So as we are talking today about this topic today is we are shifting from the previous sessions, and we are going to discuss today about this very, very important trial which just came out a few months back, and it is really, we can call it a fresh from the oven, because the last session on Thursday evening at the ESD concluded just yesterday, was also on the same topic, that is the delivered trial. So I'm going to take you through these important points of this trial and how the implications of this trial per se on the management of heart failure per se is what it is going to be. So we all know that SGLT2 inhibitors have become a cornerstone of therapy in the management of type 2 diabetes. From the time they were introduced, from the time we have been using it initially for the glycemic effect, and then as we came to know the pleiotropic benefits that SGLT2 inhibitors are giving us, it has come a long way in its journey. When we look at all the trials that have been there for the last decade related to SGLT2 inhibitors, one thing which has come out common, or two things which have come out common, is the impact of SGLT2 inhibitors and the benefits primarily in patients with heart failure, mainly by causing reduction in terms of hospitalization for heart failure, is something which has been common with all SGLT2 inhibitors, which has been common with all the trials which have shown the benefits. And also, of course, the impact of SGLT2 inhibitors on kidney function is again something which has been common. There are fewer treatments, we can say, options available for patients with heart failure with mildly reduced or preserved ejection fraction. If you look at the previous trials, more or less it included patients mainly with reduced ejection fractions, less than 40% ejection fraction. Gradually, we got few trials like Emperor Preserved, which showed the benefit of empagliflozin per se, again, in patients with preserved ejection fraction. There is a subset of patients that is which is now defined as somebody with a mildly reduced ejection fraction, that has an ejection fraction between 40 to 49%, and those with 50 and above is something which we call as preserved ejection fractions. So data on this subset of patient is still lacking, not enough, and that's where the that's where the DELIVER trial comes in, because it is something slightly different. The kind of population it enrolled was slightly different, and the endpoints it looked at in this population was different as compared to the previous trials. So the uncertainty remains in this kind of population. Those in patients with a higher ejection fraction, whether they also benefit with the same kind of effect like the SGLT2 inhibitors do. subset of patients where the SGLT2 inhibitors were initiated immediately during hospitalization or immediately after discharge. Again, there was not enough data to show that. If you look at the EMPULSE study, which was done with empagliflozin in patients with an acute myocardial infarction, again, it did show benefit, but there was not enough data available for patients who were hospitalized in or who were given SGLT2 inhibitors immediately after discharge. So this is where we are talking about the DELIVER trial today. Heart failure is something which has been, which we are now calling as the elephant in the room. We know that when we talk about a patient with diabetes and heart failure, there are a number of areas which come into scene. There is a cardiomyopathy. There is the problems associated with increased mortality for a patient with heart failure. But the window of opportunity that we get for using SGLT2 inhibitors comes at every stage. So when a patient is in the first 10 years of diabetes, when he's in the subclinical stage of cardiovascular disease, we have data with CANVAS, TICLAIR-TIMI, EMPA-REG, which looked at such kind of population where there were patients with prime cohort in the primary cohort as well as a patient with established cardiovascular disease, and it showed benefit in terms of reduction of hospitalization for heart failure. When we look at patients who are more chronic, between 10 to 20 years of diabetes, already in an established stage of disease, again, we have data to show that SGLT2 inhibitors show benefit there. And then we have trials like DELIVER, then EMPEROR Preserved, EMPEROR Reduced, and SOLOIST done with sotagliflozin, which again is particularly done in patients with preserved ejection fraction, mildly reduced ejection fraction, where we know that there is a cardiac involvement, but we did not have data enough to show that. The correlation between diabetes and heart failure is closely linked. There are a number of pathophysiologic abnormalities which can lead in a patient with diabetes to heart failure. There is the underlying atherosclerosis, there is coronary artery disease, there is the inflammation, the cardiomyopathy, that advanced glycation end products. There is the shift of metabolism that happens primarily, again, the decrease in anabolic function, all these, and endothelial dysfunction, all these factors together, and plus the underlying insulin resistance, which may be pushing a patient from with diabetes to a stage of chronic heart failure. The mechanism by which the SGLT2 inhibitors give their benefit, again, are still controversial. They are still talking about it because every day we are discovering newer and newer benefits with this drug. But mainly suppression of damage mediated by advanced glycation end products. There is the diuresis factor. There is a shift towards ketone body metabolism that occurs in a patient who is on SGLT2 inhibitors. There is a reduced adipose tissue inflammation, decreased oxidative stress, which plays a role. So multiple mechanisms by which an SGLT2 inhibitors per se may be giving benefit, especially in this subset of patients. So DELIVER study is a unique study. Again, it was a randomized double-blind placebo-controlled trial which looked at the hypothesis, or which was based on a hypothesis that dapagliflozin would reduce cardiovascular death or worsening heart failure in patients with heart failure or with mildly reduced ejection fraction or preserved ejection fraction. The criteria for this study was patients eligible were more than 40 years of age with an NYHA class 2 to class 4 disease. Ejection fraction had to be more than 40%. It also included patients who had a prior ejection fraction of less than 40 but had progressed to ejection fraction of more than 40, so those who had improved over a period of time. Somebody with increased or elevated pro-BNP, somebody with either ambulatory or who were hospitalized for heart failure. Patients were subjected to two groups, 10 milligrams of dapagliflozin versus placebo. It was an event-driven trial, mainly looking at more than around 1,100 estimated events. The primary endpoints for this was to look at first composite of CV death or worsening heart failure, which was defined as by urgent heart failure with hospitalization or hospitalization for heart failure. The secondary endpoints, it included total heart failure events or plus a CV death. It looked at the CANSA score also, change in the CANSA score over a period of 8 months. It looked at cardiovascular deaths and all-cause death also as the secondary endpoints. Primarily, mainly when it looked at for the primary event, it looked at the subpopulation for those who had an ejection fraction of less than 60. It looked at the total number of first and recurrent events happening in patients with an ejection fraction of less than 60. And mainly also it looked at the first and recurrent events in the full study population, those with an ejection fraction less than 60 as well as between 40 to 60 and above 60 also. The time to first event, mainly it looked at full study population, it looked at number of events happening in the full study population, and it looked at the change in the Kansas quality score also, and time to CV death. 10,000 patients were first initially assessed for eligibility. Finally, 6,200 patients were allocated in the study into two groups subjected to 10 milligrams of dapagliflozin versus placebo. The median follow-up was around 2.3 years. 14% of the patient discontinued dapagliflozin in the study, and almost similar number discontinued placebo in this study. It was a global study done at various countries, multicentric, with more than 350 sites in the country in the world were included in this data. The baseline characteristics of patients mainly were more or less similar in the two groups. Baseline ejection fraction was around 54 to 55. 70% of the patients in the DAPA group had an ejection fraction of less than 60. Those with around 18 to 20% of the patients were those where heart failure each pumping had improved from less than 40 to more than 40. There were patients without diabetes also in this study, as well as patients with diabetes. Both were included in this. When you look at the pro-BNP baseline, more or less again similar, around 700 in both the groups. Those with 40% of the patients had prior hospitalization, 42% of the patients had prior atrial fibrillation. The mean GFR was around 61. Patients were subjected to all other baseline therapies for heart failure, including loop diuretics, ACE inhibitors, ARB blockers, and 5% of the patients were on sacubitril valsartan also in the study. So when you look at the study results, the primary endpoint of CV death or worsening heart failure was reduced by approximately 18% in the dapagliflozin group with an hazard ratio of 0.82 and a confidence interval of 0.73, clearly showing a benefit in terms of the patients who were subjected to dapagliflozin even in this subgroup of population. When it looked at sub-analysis for patients with an ejection fraction of less than 60 versus full population, more or less 18% in the full population benefit seen, relative risk reduction, versus similar around 17% in the population where the ejection fraction was less than 60% again. When it looked at the worsening heart failure endpoint, which included heart failure hospitalization or an urgent heart failure visit, around 21% relative risk reduction seen in the dapagliflozin group versus placebo. In terms of cardiovascular death, around 12% reduction in the cardiovascular death, which was considered non-inferior to the placebo in terms of the entire population. When you did see the difference for subgroup of population based on the ejection fraction less than 60 versus more than 60, the primary endpoint again was more or less similar. If you see in both the groups, the worsening heart failure event again similar, around 23% risk reduction, overall at 22% for primary composite of endpoint. Hospitalization for heart failure, again similar, reduction of around 23 to 24% and a relative risk reduction of 18% seen in both the groups. Cardiovascular death was significantly reduced in the subgroup of population. If you see again here, overall a 32% relative risk reduction in meta-analysis for based on the ejection fraction less than 60 and more than 60, and all-cause death, though non-significant reduction, overall a 14% reduction seen in both the groups. So when you look at the primary endpoint in pre-specified groups mainly, based on the ejection fraction between 40 to 49, 50 to 60, and more than 60, the maximum benefit is seen in the subgroup of population between, again, less than 60, if you see here, between 50 to 69, between 50 to 60. For patients who are hospitalized just when given dapagliflozin or who were just discharged within 30 days when they were given. More or less no clinical difference seen in terms of the benefit, but both were benefited, around 18% to 22% relative risk reduction seen. For subgroup of population where the ejection fraction had improved from less than 40 to more than 40, more benefit was seen in the subpopulation where in those patients who had a prior ejection fraction less than 40, almost a 26% relative risk reduction seen. Again, depending on the age, sex, or race, nothing much difference to choose between the two subgroups. Again, based on the NYHA classification or based on patients with diabetes versus without diabetes, similar risk reduction seen in the DAPA arm, 17% versus 19%. Those with a prior pro-BNP being more than 1,000 versus less than 1,000. Again, a relative risk reduction similar seen across in both the arms. So what it tells us is that it could give benefit, or dapagliflozin more or less showed benefit in all the subpopulation, in all the subgroups, and the benefit and the safety did not much differ when it looked at various other parameters. Now coming to the secondary endpoints, again, when you look at the full population related to total heart failure events and cardiovascular death, there was a relative risk reduction again with dapagliflozin of almost 23% seen in the DAPA arm versus the placebo arm. The number of events around 815 versus 1,000 in the placebo group. Kansas City score evaluation was done for the quality of life, and there was a significant, again, reduction seen from baseline to 8 months. There was an improvement seen in the dapagliflozin arm versus placebo for all parameters when these patients were evaluated. Because when you look at the Kansas City score, mainly, again, it showed that there was an improvement of 10 plus and 15 plus score points in both the DAPA arms. When it comes to the adverse events, nothing significant increase. If you look at any side effect profile, when you look at treatment discontinuation or whether you looked at probable ketoacidosis, no increased event was seen in the dapagliflozin arm as compared to the placebo arm. So what it tells us is that overall, when they looked at the number needed to treat, it was around 32 in the dapagliflozin arm. When you look at the composite of CV death or worsening heart failure, there is a relative reduction of around 18% seen in the dapagliflozin arm. The total hospitalization and CV deaths were reduced significantly in the dapagliflozin arm as compared to the placebo arm. So it tells us that dapagliflozin could reduce the combined risk of worsening heart failure or cardiovascular death among patients with heart failure and mildly reduced ejection fraction, or even in those with a preserved ejection fraction, and even in those who had a prior reduced ejection fractions but were then improved over a period of time. So this was a subpopulation which was not yet studied, but it showed that dapagliflozin can give benefit in this subpopulation also. So when you compare it with other similar trial like the Emperor Preserve done with empagliflozin, the difference here was in terms of benefits, the similarities were there, that the relative reduction in primary endpoint is similar, 18% versus 21%. Principal effect of reduction in hospitalization and reduction in CV mortality is similar. Overall, the population were of identical age and the mean GFR was more or less similar. What was different in the DELIVER trial as compared to the Emperor Preserve, that it showed benefit in those with patients who had a initially reduced ejection fraction of less than 40 and then improved over a period of time. And therefore, it gives us clear benefit that the benefits are there across in all patients with reduced ejection fraction benefits. A meta-analysis, if you look at for these two trials, there is an overall reduction of 20% when you combine the data of Emperor Preserve and DELIVER trial, more or less similar hazard ratio if you see here. If you look at the cardiovascular death reduction, again around 12%, considered to be non-significant. And if you look at hospitalization for heart failure, again significant benefit of reduction of almost 26% when you combine the data of these two trials. What the impact does it have on treatment of heart failure? If you look at the latest 2022 AHA-ACC guidelines for patients for management of heart failure, In this category of mildly reduced and preserved ejection fraction, SGLT2s have now found a place right there up along with diuretics as a second drug of choice for both the group for mildly reduced as well as those with preserved ejection fraction. If you look at the 2022 guidelines for management in general for heart failure, again, it clearly tells us that for step 1 is to establish the diagnosis, step 2 is to titrate the therapy. We need to add drugs subsequently and give the benefit of all the drugs, where SGLT2 inhibitors become the drug of choice along with other drugs like RB, along with beta blockers and diuretics also. So depending on the patients with an ejection fraction, whether the ejection fraction is less than 40 or whether the ejection fraction is more than 40, you look at also the other parameters like the NYHA stage, and then accordingly add the drugs one by one. But basically, it tells us that SGLT2 inhibitors have now become the one of the important armamentarium for management of patients with heart failure, irrespective of.
Sir, time, please.
Yeah, last 2 slides. Have become the drug of choice now for this kind of subpopulation. So to conclude, in the largest and most inclusive trial of patients with heart failure and mildly reduced or preserved ejection fraction, treatment with dapagliflozin did reduce the risk of primary composite outcome. It reduced all components of composite, mainly heart failure events, and overall improvement in symptom burden also. Its findings were consistent across in all subgroups, especially in those with reduced ejection fraction and those who had improved. It was effective in patients with recent hospitalization and those who were given dapagliflozin immediately after discharge also. And there were no serious adverse events as such reported which lead to discontinuation of the drug. Thank you very much.
Thank you, sir, for a wonderful lecture. It was a wonderful topic. Thank you, sir. And over to the chairperson to introduce our next speaker.
Our next speaker is Dr. Praveen. He is a consultant at Dr. Mohandas Diabetes Specialty Center, Malleshwaram, Bangalore. He is a trained in Department of Endocrinology and Diabetes and Metabolism as prestigious Christian Medical College, Vellore, and completed his fellowship in diabetology. Subsequently worked under Dr. V. Mohan at Mohan's Diabetes Specialty Center, Chennai. He has got various awards and recognition. He has got Best Oral and Poster Presentation Award on metabolic characteristics in lean diabetes in Asian Indians at RSJ Hyderabad, November 2016. Also, the first prize for 3 minutes thesis presentation at CMC Vellore. Designation selected for oral poster at International Diabetes Federation, Dubai, and faculty at National Diabetes Educator Program in Type 1 Diabetes course from SPEED. Poster presentation with Esikon Trivandrum, editorial on FCPD with Professor V. Mohan, and has publications in various journals and has co-authored few chapters in RSJ textbook of diabetes, COVID-19 and diabetes from API, and reviewer of Journal of Diabetes under editor Dr. V. Mohan, and special interest young onset diabetes and diabetes technology and diabetes food. So over to Dr. Praveen.
Thank you, Abhishek, for those kind introduction. At the outset, I would like to thank Dr. Arvinda sir for this opportunity to present the talk. It's an interesting thing. I'll try to share my slides now. Today, in the era of various combinations, we have one of the oldest combinations which we use. So we'll just, for the next 10 to 15 minutes, we'll talk about the clinical application of oglibose-based fixed combination in the management of type 2 diabetes. We all know that the management of diabetes has definitely seen a paradigm shift. It's not just about controlling the glucose numbers. It is more from glucose-centric to patient-centric. And also with the newer drugs, we also have the importance of covering the complications, be it the diabetic kidney disease or atherosclerotic cardiovascular disease of the heart failure. But again, we need to individualize the treatment. So gone are the days, it's just not about metformin, sulfonylurea, or insulin. We need to have an integrative strategy. Sometimes an early combination therapy is extremely important to achieve the desired A1C. And we have a lot of trials to support that fact. So one of the biggest challenge in the Indian subset is obviously the the current situation of, if you talk about the glycemic control, on average, you will see even in our practice that the majority of the patients would not achieve the target A1C, which we call around at least 6.5 to 7%. But the average A1C is almost close to 9.5% across the globe. And one of the reasons, apart from the inertia as well as the delayed diagnosis, one of the other inertia when you start somebody on a therapy is mainly the poor compliance with medications, poor adherence, and sometimes being a chronic therapy, they think that once you take it for some time and they tend to stop it. And so poor persistence with the suggested therapy ultimately leads to poor compliance, which can increase your sugar levels. If you have some of the data which is talking about one of the reasons for the poor compliance, you have a global data on compliance, and you can see there almost the range, it ranges only around 30% for chronic conditions like diabetes and heart failure. And if you look at the Indian data, the data ranges from 16.6% to 41% for chronic conditions like diabetes. And obviously, when you have poor adherence to medications, definitely the expected benefits cannot be there. And in spite of, then obviously, even if you restart the old medication or the old dosage, the desired glycemic control won't be achieved. And obviously, we know that most of the diabetic patients do come with other comorbidities. So most of the diabetic patients do have other risks like your cardiovascular risk, hypertension, and dyslipidemia. And mainly because of the multiple pill, you do have this pill burden. And obviously, pill burden, multiple pills can be a problem, which ultimately, because of the GI disturbances or patient per se, we do have a lot of myths, right? Taking a lot of medications itself could cause the renal failure. So these are some of the myths which can be attributed, and that ultimately leads to poor compliance. So these are some of the common reasons which has been attributed for non-adherence. Obviously, in a geriatric patient, the causes are different. But even if you talk about a young patient, more than the forgetfulness, the issue is more about the side effects, some of the high drug costs. But thankfully, in the last 2 to 3 years, we have had many medicines going off patent, and most of the drugs have been affordable. And also, you have the generic medications also, at least for the people who don't adhere to their medication. So these are some of the common reasons, but sometimes the poor awareness and the perceived lack of efficacy and all these factors put together leads to non-adherence. So we have a simple case here, I think, which again shows why a 55-year-old gentleman, type 2 diabetes with high postprandial blood glucose level. And one of the reasons for poor glycemic control has been poor compliance. So this is a 55-year-old lady with diabetes and hypertension, strong family history of type 2 diabetes and cardiovascular disease on the paternal side. At diagnosis, she was on metformin thrice daily and amlodipine. 6 months later, her therapy was adjusted to adding a sulfonylurea glimepiride 1 milligram daily. By 4 years, at present, she's almost on glimepiride 2 milligram twice daily, metformin 1 gram twice, and vildagliptin 50 milligram twice daily. So this is a common scenario which we see, and this is how generally we start with one drug, then we start with add-on, we escalate based on the HbA1c and the comorbidities. But sometimes with progressive disorder like type 2 diabetes, sometimes you may require multiple drugs to address the multiple pathophysiology, and sometimes you may not get the desired glycemic control. And for blood pressure, she's already on telmisartan and cilnidipine, and other medications includes aspirin, atorvastatin, calcium, and vitamin B12. So obviously, with these number of medications, probably psychologically, patients tend to try to match the following. They tend to say, okay, 1,000, I'm taking a high dose. Can we stop something? And they go with sometimes, generally the culprit will be 1,000 milligram because of the dosage there, but they would not understand that glimepiride 2 milligrams is more potent in causing hypoglycemia. So obviously, in the current visit, she was obviously concerned about the poor glycemic control, progressive increase in the medications, and occasionally she does feel dizzy and jittery at night, probably because of hypoglycemia. And that is one of the reasons why she has skipped all the 3 medicines, that is glimepiride, metformin, vildagliptin, and also the statin. And obviously, she's worried that she takes a lot of medication. So this is one of those scenarios where you would see the fasting is almost 156 and postprandial is 280 and A1C is 8.2. And luckily, both renal and liver functions are normal, but dyslipidemia is also seen there. So obviously, these are some of the patients where you can tweak the medications, have 2 to 3 pills in the same combination, add some of the drugs which would have a cardiovascular benefit, and that would probably help in better compliance. So pill burden and non-adherence are a major roadblock in poor glycemic control, and that ultimately leads to complications as well as increase in mortality. So definitely fixed dose combination is definitely an answer when it comes to for better compliance, especially in these scenario. You do have this subset of patients where you will have multiple pills. And also if you talk about the geriatric patients, and definitely a fixed drug combination of certain drugs would definitely help in better therapy adherence as well as better clinical outcome. So this is one of the solution to improve compliance. And I know today we have a lot of polypharmacy, but sometimes it's very important to have a synergistic combination even in these fixed dose combinations. And if you talk about the guidelines, you take both the AAC guidelines as well as the Indian guidelines like the RSSDI and the ESI guidelines, and all recommend triple therapy, especially if your entry-level A1C is more than 9%. And because sometimes even with the dual therapy, the HbA1c may not be able to control. But having said that, you need to individualize the case. And with a triple drug combination, probably you would be able to bring down the A1C a little earlier. And we all know the importance of early glycemic control. We talk about hit early, hit hard. So that is where these triple therapies are an excellent options in bringing down the desired A1C. So if you look at even the RSSDI ESI guidelines, even they recommend to start with metformin. And obviously, if you have ASCVD or a heart failure, you have medications like GLP-1 and SGLT2 be your second line. But that choice is again based on the patient's comorbidities. Sometimes you may have to go with even an injectable like insulin or GLP-1 analogs if the target A1C is more than 10%. So these are some things which have to be taken into consideration. But triple therapy is also a patient-centric approach, especially if the target A1C is more than 9%. These are the advantages of the fixed drug combinations, and obviously it fixes a couple of pills which can have a synergistic combinations. We have metformin, sulfonylurea, you have metformin with the SGLT2, the DPP4. Nowadays, you have even the DPP4 with the SGLT2. And most of these combinations do have a synergistic property rather than a super additive toxicity. And ultimately, these combination helps in better adherence and better compliance in the therapy. So these are some of the drugs which have been approved for FDC. You can see metformin. These are all some of the older drugs which you have metformin plus sulfonylureas. The metformin, sulfonylurea, and voglibose is the other triple combinations. And we know that voglibose belongs to alpha-glucosidase inhibitor. And considering the high carbohydrate intake in our Indian population, this drug, in addition with metformin or sulfonylurea, definitely helps in balancing a better postprandial glucose control. So what is the role of voglibose in the combination therapy? As I mentioned, being an alpha-glucosidase inhibitor definitely controls your postprandial glycemic excursion much better. And obviously, when you talk about the other metric, what we call as the time in range, the glycemic variability is definitely lesser with this class of medications. And sometimes, rather than increasing a higher dose of sulfonylurea, which can cause weight gain or hypoglycemia, an addition of AGI definitely helps in better control of the postprandial sugar, and also the glycemic variability is also reduced with this combination. So the fixed dose combination of metformin, glimepiride, and voglibose is extremely effective in reducing the glycemic variability as well as the HbA1c, especially in the Indian diabetic patients, because obviously they do have the diet is rich in carbohydrates. And when you compare the results with the combination as well as just the combination of metformin, metformin and glimepiride, the efficacy is always there. And just a twice daily of this combination before or along with breakfast and dinner is sufficient to prevent the glycemic excursions in a day. This is the different mechanism how these molecules work. I think we all know about the metformin working on the endogenous glucose production, bringing down your insulin resistance. Glimepiride being a secretagogue, voglibose being an AGI, definitely brings down your delays the absorption of your complex carbs and thus helps in reducing the postprandial excursions. So these were some of the couple of studies which we'll run through. One is the comparison between metformin and glimepiride group combination, and other group was metformin, glimepiride, and voglibose. Almost the number were around 100, and type 2 diabetes patients between 80 to 70 years were enrolled. And the study period was almost for a randomized parallel group non-inferiority study for almost 3 months. The primary endpoints was the change in HbA1c, the fasting blood glucose, as well as the postprandial blood glucose in 3 months. You can look at the baseline HbA1c here. In fact, the metformin glimepiride had a baseline A1c of around 7.3, whereas the metformin glimepiride and voglibose combination had almost of 9.7. with a fasting of 175 and 261 and 171 and 260. And at the end of 3 months, in spite of an higher HbA1c, you can see A1c had come down to 7.8 in the triple combination drug arm when compared to metformin and glimepiride groups. Other parameters, be it the creatinine and urea, was all normal. So definitely this showed that the triple drug therapy showed significant reduction in the glucose triad levels with safety. And this other study which showed the efficacy and tolerability of the oral triple drug in the management of T2DM. Here also there was a combination of glimepiride 1 or 2 milligram with metformin and oglibos 0.2. This was almost administered for 4 months. The baseline A1C was close to 9% at the base. At the end of 4 months, the level had decreased to 6.5%. And the fasting from almost 180 had come down to 116. And the postprandial from 239 had come to 1. Almost kind of more the glycemic targets what we desire in most of our patients. And thus they concluded the fixed dose triple drug combination of oglibos, glimepiride and metformin is safe and effective in the management of type 2 diabetes who are those who are uncontrolled with the dual therapy. So to conclude, glycemic control is poor among Indians, obviously the average A1C being 8%. Various factors contribute for high prevalence of uncontrolled diabetes in India, especially the comorbidities and the non-adherence to medications, mainly due to cost, pill burden, and adverse events, mainly with looking at the comorbid conditions. Triple drug therapies, not only just when you have a lot of these medications, choosing the right triple drug is recommended by various guidelines, and choosing the right FDC, the fixed dose combination, definitely reduces the pill burden and improves the glycemic control. And if you talk about the combination of metformin, glimepiride, and oglibos, considering the high carbohydrate intake in our population, this has been found to provide a good glycemic control with a good safety as well as tolerability. Therefore, it's very important, even though the subset may be 10 to 15%, selecting the right patient, right drug, and the right dose in the right time definitely helps in improving the clinical outcome as well as preventing the complications. Thank you.
Thank you, Dr. Praveen. We'll go into the next topic now. Could you please share the slide? I'd like to, it's my pleasure to introduce Dr. Sudeep Manohar. He is an MBBS JSS from Mysore. He's an MRCP from UK and CCT in endocrinology, Newcastle. He's currently an consultant endocrinologist at Apollo Hospital, Jayanagar, and the White Lotus Clinic in Basavangudi. Welcome, Dr. Sudeep.
Thank you, ma'am. So let me share my screen. I hope I'm audible and my screen is visible.
Yes, sir. You're audible and your screen is visible, sir.
Okay, thank you. So today, again, thanks Dr. Abhi Jagdish for inviting me to talk in this great academic feast. My role over the next 10-15 minutes would be to reintroduce sitagliptin to all. My title of my talk is Role of Sitagliptin in Type 2 Diabetes Disease Continuum. Every patient matters. Sitagliptin was one of the first oral DPP-4 inhibitors in the market in many parts of the world. And I remember when it was first introduced, had a lot of anxiety, describing it, the risk of pancreatitis, nasopharyngitis. But over the years, it has become a favorite molecule among most diabetologists. So when we look at the ADA ESD guidelines, it does certainly look complex. Management of diabetes, a couple of decades ago, it used to be fairly simple: add metformin, add sulfonylurea, add an insulin. But with multitude of agents, lots of data available on each agent's efficacies, side effect profiles, cardiovascular benefits, the guidelines have become more complex, and certainly the choices of treatments has to be individualized. Not only this, even from earlier talk, Dr. Praveen was showing that multiple pharmacological agents and fixed dose combinations are essential to achieve glycemic targets. Most guidelines do recommend metformin as first line, but as soon as most people lose glucose control, what do we choose next? There are lots of choices, and we have to individualize treatments. Most patients don't have diabetes, cardiovascular disease or chronic kidney disease. So about, I would say in my clinic, 75 to 80% of patients are don't fit into the category on the left-hand side. On the right-hand side is where they fit in. And you can see DPP-4 inhibitor is a common choice of drug in whether it's cost issues or whether you don't want hypoglycemia and weight gain. DPP-4 inhibitors is a choice. If you look at the safety profile of different oral hypoglycemic agents, all the agents have, you can see the orange or the red concern mark, except for the DPP-4 inhibitor. And with sitagliptin, we know it's about cardiovascular, or I'll show you the data about its cardiovascular safety too. So it's one agent, DPP-4 inhibitors, and sitagliptin is a fairly important point is it's safe. So I'll go through some of the data about glycemic efficacy and also safety in various trials. This again, a very old one, couple of decades ago, sitagliptin compared with metformin in insulin treatment-naive type of diabetes patient. And you can see the glycemic efficacy is almost similar to metformin. So it's not a metformin, we know it's very, very effective. And it has a modest efficacy. But the key here is if you see the incidence of gastrointestinal side effects were almost very minimal with sitagliptin with no hypoglycemia. So it's very better tolerated than metformin. More or less non-inferior in terms of A1C reduction, and then with lower GI side effects. So you can certainly use sitagliptin in a newly diagnosed patient as monotherapy. And if there are patients already on metformin with loss of glucose control, this is another class of drug where sitagliptin can be added in. So it can be added to metformin, and you see a 0.6 to 0.8% reduction in A1C and fasting reduction, glucose reduction of about 20-25. When you compare it to glimepiride, as an add-on to metformin, similar reduction in glucose control over a 24-30 week period. But if you see the graph on the right, the major difference is the weight gain. There is at least about a 2 kilogram weight difference at the end of 24 weeks. Not only that, hypoglycemia, if you see, it was 7% reported in the sitagliptin group, 22% in the glimepiride group. If you look at severe hypoglycemia, none in the sitagliptin group and much higher in the glimepiride. So certainly sitagliptin is a good drug as an add-on to metformin compared to glimepiride. It can also be considered as add-on with pioglitazone too. So here, when pioglitazone and sitagliptin as a combination was used, there were better efficacy both in reduction in fasting glucose and A1C reduction by about 1%. And again, importantly, safety profile, combination of sitagliptin pioglitazone was very well tolerated with, well, again, rather no hypoglycemia, very minimal GI effects, and edema was no significantly different when sita and pio combination was used. And with the newer combination, fixed drug combinations being available, a DPP-4 SGLT2 is a very good combination, and now sitagliptin is available as a combination with dapagliflozin at a much lower cost, as we all know. So in this trial where sitagliptin with placebo was compared to a combination of dapagliflozin and sitagliptin, you can see the glycemic efficacy being much better in the sitagliptin group with A1C reduction of an additional A1C reduction of about 0.6%. Again, this combination was very well tolerated. Though the genitourinary infection was slightly higher as part of being on dapagliflozin, and no extra side effects from sitagliptin. More agents can also be added to insulin, so sitagliptin, in addition to various regimes, whether it was long-acting insulin, basal bolus, twice daily premixes, or any combination of insulin. When sitagliptin was added, the A1C reduction of about 0.6 to 1.2% was added. So when the HbA1c is higher, you see a little more than 1% drop in A1C, and at a lower A1C level, you see a modest improvement. Many of our patients are concerned about body weight. And if you look at this forest plot of a meta-analysis, when agents were used for up to 6 months, there is no significant weight change. For more than 6 months, there is probably a small weight loss visible. But we could safely say that these drugs are, especially sitagliptin, is weight neutral and can be started on with no concerns about more weight gain for our patients. So this is again in the elderly group. So in the elderly, we always are concerned about side effects. And sitagliptin is one drug where we know it's well tolerated. And is the glycemic difference efficacy any different? If you see whether patient was less than 65 or more than 65, the glycemic. So this was in a trial with more than 65-year-olds, and the glycemic efficacy was a 0.7% reduction, and the higher reduction in HbA1c was about 9%. And if you look at the side effect compared to placebo, the side effect profile is more or less similar, so it's very well tolerated. No adverse effects or hypoglycemia were reported in the elderly. So we can safely give sitagliptin in elderly patients. And in a subgroup analysis, you can see whether the patient was less than 65, 65 to 74, or more than 75 years. The glycemic efficacy was fairly similar. One of the concerns being beta cell function being lower in the elderly, but sitagliptin has shown that efficacy is more or less similar in all age groups. After the rosiglitazone episode, cardiovascular safety was taken very importantly in the diabetes world. And each drug, the FDA wanted cardiovascular safety. With sitagliptin, ECOS study was conducted. So this was it, standing for trial evaluating cardiovascular outcomes with sitagliptin in patients with type 2 diabetes and established cardiovascular disease. It was a multinational randomized double-blind placebo-controlled event-driven trial. Patients were either randomized to placebo or sitagliptin, and these patients were more than 50 with A1C of 6.5 to 8%, and treated with stable doses of 1 or 2 oral anti-hypoglycemic agents, which is either metformin, sulfonylurea, pyridoxine insulin, or insulin with metformin. And the primary endpoint was the 4-point MACE of cardiovascular death, non-fatal MI, non-fatal stroke, and hospitalization, stable angina. and secondary endpoint being 3-point MACE. And when we clearly look at the results, you can see sitagliptin, when followed up for 3 years, showed no increase in cardiovascular outcomes compared to placebo, establishing that it's cardiovascular safety. And one of the key things with there was possible increased hospitalization from heart failure with saxagliptin and sitagliptin in the TCOS trial clearly showed that there was no difference in hospitalizations from heart failure. So to summarize, I would say sitagliptin is a well-tolerated oral hypoglycemic agent with a modest glycemic efficacy. It has proven robust cardiovascular safety data from the TCOS study. It is a weight-neutral agent with no risk of hypoglycemia. It can be used as monotherapy or as an add-on to any other agent, including insulin. And it can be safely used in various patient profiles, including elderly and chronic kidney disease patients. So I would say sitagliptin is a well-established molecule, and we should all be fairly comfortable to use it in all our patients. With that, I finished. Thank you.
Thank you, sir. Thank you so much. And thanks to all the 3 speakers for the delightful speech. Thanks for the huge presentation. Thank you. We had a valuable knowledge from all the 3 speakers. Arvind, sir, over to you, sir.
Yeah, that was an excellent symposium. Thanks to Abbott for making this symposium happen. I thank Dr. Deepak, Dr. Abhishek, and Dr. Alpana, Dr. Tejas, Dr. Praveen, and Dr. Sudeep for your wonderful deliberation and being a part of our conference. Thank you so much. Thank you so much.
Thank you, sir. Thank you so much.
Thank you, sir.
Let's move on to our next presentation for the next section. Hello. Next, move on to our next session 4 on insulin workshop. I would introduce the rapporteur, Dr. Mali Parekh, MBBS, DNB, MNAMS, Fellowship in Diabetes, Postgraduate Diploma in Diabetes, PGDC, UK, PG Diploma in Diabetes, PGCC, Consultant Diabetologist, Rajkot. I would like to introduce the chairpersons of the session 4, Dr. Suresh Babu, Dr. Suresh Babu, a famous diabetologist from Tumkur, and Dr. Sonali Bojane, MBBS, Postgraduate Diploma in Diabetology, UK, Consultant Diabetologist, Postgraduate Diploma in Clinical Endocrinology and Diabetes, Royal College of Physicians, UK. Over to you, sir. Rapporteur, Dr. Mali Parekh. Ma'am, as a chairperson, I think you can take a decision, ma'am. You can introduce the speaker, ma'am.
Yes. So welcome all as we are heading towards our next session, and it is all about insulin. To discuss about insulins, various insulins, I invite Dr. Swati Srivastav, who is MD Medicine, FACE, FSCP, FRCP, FICP, trained in Endocrine Technical Department, Fellow in Diabetes Management. She is also a senior professor and a unit head, SBS Hospital, Jaipur. She's trained from CMC Bangalore. She's a member of Research Review Board, SBS Medical College, Medical Advisory Council, American College of Physicians,
India chapter, member of AAC Diabetes and Thyroid Disease State Network 2020 and 21. She is a member governing body of Rajasthan RSSDI. She's a vice chairman of Jaipur API, vice chairman of RSSDI Rajasthan District Coordinator Committee. She is a scientific coordinator for RSSDI 2019, executive committee member of Diabetes India 2019, EPICON 2022, organizing secretary, midterm IPF. She is a recipient of more than 14 awards and orations, and there are more than 40 publications in peer-reviewed journals and paper presentations in various conferences and chapters in books. So with this, I invite Dr. Swati Srivastava for her presentation.
Thank you very much, Dr. Shonali. Thank you, Dr. Shweta. At the outset, I would like to thank Dr. Arvinda for giving me this wonderful opportunity to speak in this very important conference. Let me share my screen first. Let's see. Okay. Is my screen visible? Can you see my screen?
Yes, ma'am. Your screen is visible, ma'am.
Now I'll make it to the slideshow mode. Please tell me if it is. Just a second. Yeah. Is it in the slideshow mode?
Yeah, ma'am.
Okay. So, okay, fine. So my topic today is newer insulins staying updated. So basically, this is the insulin symposium, a very important one after the very important session we had in the last session, and throughout the day, it has been really an academic feast. Thank you, Dr. Arvinda, for this excellent conference. With that, we move on to the status, the condition of the nation when it's regard to diabetes. We know diabetes is going on to become the global capital, with almost 1 in 2 people with diabetes being undiagnosed, heavily contributing to the morbidity, mortality, the expenses, and so many things with regard to diabetes itself. So diabetes itself is becoming a huge burden, not only health-wise, but also financially, and in increasing the morbidity, hospitalization, so on and so forth. What is more important in the Indian context is that, as we see, these are the list of various studies which go on to show that most of the diabetic patients that we have a higher HbA1c, as you can see. The mean HbA1c in the trials being 8.56, 8.9, 9.23, 9.2, so very high. So our HbA1cs in an average diabetic in India is around 2% higher than what the ADA recommends. So our targets are absolutely out of goal. Then we have some other problems also. We have so many patients, a huge rush of patients in the Indian setup, limited consultation time. We have a high carb diet leading to high post-prandial glucose. Our patients on multiple OADs, uncontrolled as yet, and then they want a convenience also. Looking into all this, we need to have a very strong armamentarium for controlling this disorder, which is turning into an epidemic, and insulin is one very important tool in this. Insulin has not only glucose lowering effects, it has various other pleiotropic effects also, as very well shown in this slide. So when we talk about the principles of insulin replacement, we know it's a background or basal insulin replacement and a bolus insulin replacement for the nutritional dose which is going on. So as I am going to talk about the newer insulin. So as we see the landscape, evolving landscape of the basal insulins, what we see is the first breakthrough was in 1936. When NPH insulin was discovered by Hans Christian Hegdon. And then over the period of time, a large number of insulins were made. Now, NPH insulin was made by protamination, adding a basic protein was added, and then that led to an increase in the time duration of the insulin action, and hence leading to a better compliance and a longer duration of action, which was needed for a basal insulin control. But then we had challenges with this NPH insulin. Why? Because it had insufficient basal insulin coverage,
Multiple injections were required. There was a need of resuspension, that too properly, which we know because we have used NPH in our previous days and seen how a bad resuspension can cause very real drastic effects and a significant day-to-day variability. So then what all can be done to prolong insulin action and having a good action? So number one, a basic protein can be added like the NPH does, or the solubility of the physiological pH would be reduced like in glargine. So glargine has a acidic pH and then it precipitates when it's injected into our subcutaneous tissue and slowly released, or acylation like in degludec and detamil. So this is about glargine. As this is the first generation insulin analogs, basal insulin analogs we had was glargine, and as I said, it is acidic. So it then precipitates in the subcutaneous tissue and gradually free hexamers are then, it sort of forms a depot and then free hexamers are gradually released. Then in 2005, glargine was introduced in 2000. In 2005, we had detamil. Now detamil also has a binding with the albumin and there is a slow gradual release. Now, how did these first generation insulin analogs fare when compared to NPH? It was found that, as we can see in this graph, the intra-patient variability, the coefficient of variation was very high with NPH as compared to glargine and detamil. So they definitely were better. Hypoglycemia events were much lesser with the first generation analogs, glargine and detamil, as compared to NPH. So did we reach what we want? But again, now there were challenges with this first generation basal insulin analogs also, because it was found that even they had some variability. They had nocturnal hypoglycemias. They were not truly peakless. They might be required sometimes twice a day, and the dosing used to be fixed time, reducing the compliance sometimes. So then the second generation basal insulins came on. And the second generation basal insulins, we had the insulin degludec, which is a huge polypeptide chain of multiple hexamers. Once it's injected into the subcut, it forms a depot. The phenol gets detached and then the zinc starts getting resolved. And from this depot, the monomers and dimers are released, having a prolonged, ultra long action of over 40 hours. What else was done was glargine was concentrated, and the concentrated form of glargine leading to a smaller volume of injection and a slower release was also used as glargine U300, which is also a second generation basal insulin. If we compare the action of degludec and glargine, what we see is that the onset of action with degludec is 0.5 to 1.5 hours after the injection. So it's much earlier the onset starts, the peak is not there, and it lasts for more than 42 hours as compared to glargine U100, where it lasts for around 22 to 24 hours. So an ultra long action and a rapid onset of action goes in favor of this second generation degludec basal insulin. What about the within day variability? Again, this was better with degludec. As we know, glycemic variability is a very important factor these days, especially when it comes to the long-term complications. That was much better with degludec compared to the first generation glargine U100. There is a list of trials which have been done comparing these two molecules of second generation degludec and first generation glargine U100 in the BEGIN trial, SWISH 2, DEVOTE, and so many other trials, indicating that the hypoglycemia also is lesser with degludec, and so is the severe hypoglycemia as well as the nocturnal hypoglycemia. So this is the timeline which shows that how we had NPH in 1946, and over these 75-80 years, we have had so much development, and then glargine U100, detamil, degludec, and glargine U300, and we may have more as of now. Going on to the second part of insulins, that is the nutritional insulins. What do we have here? So again, here we had the conventional rapid acting insulins. Do they meet the entire necessity? No, they also have some problems. Number one, the speed of the insulin does not probably match very well the mealtime pattern. So the timing again becomes very much of an issue, and the fear of hypoglycemia, because the onset may not be very fast, and then the duration of action is long. As you can see here, in the regular insulin, the duration of action goes on for around even up to 6 to 10 hours. So after a few hours of meal, the patient may go in for a hypoglycemic attack, and then we reduce the dose, and then the postprandial sugars go up. So this becomes difficult to manage, to balance between the hyperglycemia and the hypoglycemia. What should we do? And the answer is we have these analogs, the rapid acting analogs, aspart, lulus, and lispro, which have an early onset, 5 to 15 minutes, and peak is at around 1 to 2 hours, duration 4 to 6 hours. We have the fast-acting insulin aspart also, which has all its effects 5 minutes earlier than aspart. And so it is even still better. Now, do these the technical pharmacokinetics we talk about, does it really convert and translate into benefits as come to the outcome? Yes, studies have done. These are not just theoretical aspects, but studies have done and which show that a 2-hour PPG increase correlates, is a strong predictor with the cardiovascular events. And even the 1-hour PPG, which becomes very important when we talk about the very fast-acting aspart, the rapid-acting aspart, that controls a 1-hour PPG also, that also becomes very important. Why? Because if there is an 1-hour postprandial hyperglycemia, what we end up with is a lot of cardiovascular and endothelial issues. So do these ultra fast or fast acting insulin analogs address the unmet needs with the conventional rapid acting insulin analogs? Yes, I may say, yes, they do. And they probably mimic the physiological insulin profile much better. Now, what about the co-formulation? Like previously in the conventional insulins, we can say that we had the premix and that was very convenient. So do we have? Yes, we have a co-formulations of these analogs as well, as most of us would be knowing very well. The insulin degludec and aspart combination, which coexist in the same formulation separately. And so they do not impact each other's pharmacokinetics, pharmacodynamics. At the same time, they have distinct prandial and basal glucose lowering effects. They target the unaddressed PPG spikes, which was there with the basals, was not controlling the PPG spike. Here, this co-formulation does that also, has better HbA1c reduction with lesser hyperglycemia, which is shown in many trials, and has a better outcomes. And I may say, practically speaking, the insulin initiation and optimization becomes very difficult with this co-formulation to quite an extent. Now, having talked about these insulins and the rapid as well as the nutritional as well as the basal insulins and the analogs and the timeline, how we have progressed. Now, let's just have a few points on the inhaled insulin. Now, inhaled insulin was a very much, it was a matter of quite a discussion and talk a few years back, because it was an important discovery. This looks like an attractive alternative for systemic administration. Why? It's quicker, it's safe, especially as when we talk about the pharmacokinetic profile. And lungs have they provide an attractive alternative for systemic administration for most of the therapeutic polypeptides. We use other polypeptide also by inhaled route. Why? Because lungs have a large surface area, good vascularity, immense capacity of solute exchange, and very thin alveolar epithelium. So these, which are available insulins in a powdered form, would be a good option to give inhaled insulins. So Pfizer launched Exubra, and then it failed because Exubra was taken back because of the lack of popularity and was not used much. Why did it fail? Because to achieve the therapeutic response, a higher dose of insulin, inhaled insulin, was required as compared to the systemic counterparts. So a very bulky device needed to be given, and their dose flexibility was not possible. So then Exubra went off the market. What came was Afrezza from Mankind. Afrezza also has some pros and cons. It's a rapid-acting inhaled insulin given before each meal, and it uses the specific Technosphere technology. What is this technology? It contains a recombinant human insulin dissolved with a powder, which it's a thumb-size inhaler, and that improves the compliance and the flexibility. And when we take the insulin, then it gets very easily, it reaches the lung and then it gets absorbed. The good thing about Afrezza as compared to Exubra was Number one, the inhaler was also of a decent size, not very huge, and it could be given easily. And the residual insulin in the lung was much, much lesser as compared to what Exubera had. So it had some positive aspects with it, but then there were some problems also. Bronchospasm in asthmatic patients, COPD, cough, throat pain, irritation, hypoglycemia, a reduction in the diffusing lung capacity for carbon monoxide, DLCO, was seen. It was also a problem with smokers. So FDA approved Afrezza with caution, with risk evaluation mitigation strategy for a communication plan to inform the healthcare professionals about serious risks of acute bronchospasm associated with it. Then now we come to oral insulins. What about oral insulins? When we talk about oral insulins, we can say that they would be absorbed from the intestine, go to the liver. The liver being a very important center for glucose metabolism, one would require a lesser dose probably than what we inject in the systemic circulation. So probably we will have lesser systemic hyperinsulinemia and hence lesser hypoglycemia. So this sounds very attractive. So why don't we have an oral insulin yet? Because there are so many problems with oral insulins. The first is that the acidic environment of the stomach is not, it breaks down the oral insulin. So peptide chains have very much difficulty with the stomach gastric acidity. Then even if we make a process so as that it crosses the stomach, the intestinal absorption becomes difficult, because the mucosal lining of the intestine causes hinders in the absorption of these oral insulins. So what has been found that probably the dose required for an oral insulin would be required to take a very huge dose as compared to what would really be required because the bioavailability would be very less. So then the concerns were risen that because, as we know, that insulin has it's a growth promoting substance. So probably such huge exposing our system to such huge doses might probably be related to some carcinogenic effects. But at present, thankfully, to whatever studies have been done, no established link between oral insulin and cancer has been established as yet. But as yet, many clinical trials have been done and no oral insulin has been successful till date. Let's hope in the future more work can be done in this direction. So that is one area where probably we can think of having something in future. And the last thing which I would like to say is the hepatic directed insulin vesicles. So the hepatic directed insulin vesicles, again, this is in the future, the research is going on. So what is being targeted? The rationale is that we target the insulin delivery to the hepatocyte. Because we know that what happens is we have in a normal individual, the portal systemic insulin concentration gradient. The gradient of insulin, which is there in the portal system as compared to what is there in the systemic circulation, is around 2 to 3 times higher than what is in the peripheral circulation. But in diabetics, this gets reversed because of the insulin deficiency. So what happens is that when we give a subcutaneous insulin, we are giving an unphysiological hyperinsulinemia to the patient. And where the patient requires the higher concentration in the portal circulation, that is not being achieved. So the hepatic directed vesicles of insulin tries to attain this by adding some factors which can probably directly target the insulin reach the liver. So this is another system which is being looked into, which is being studied, but toxicity, genetic safety, we don't know as yet. Animal studies are being done, and there is probably a future to this. In future, we might have develop such molecules depending on the stability and so many other factors. So I would summarize this by saying that insulin analogs and the newer insulins have superior or equal efficacy with lower incidence of hypoglycemia. They are more expensive, no doubt, as compared to the conventional options, but in the long run, because of their beneficial effects, they may prove to be cost effective. And ongoing research on the newer modes of insulin administration technology is definitely promising. I have not talked about the modes of administration. I think there are other talks are going to be taken over that. So laughter is the best medicine unless you are a diabetic. Then insulin comes very much high on the list. Jasper Carrot has very correctly said that. So with that note, I would like to thank you all for your patient listening. Thank you.
Thank you, ma'am. Thank you so much. That quote was really wonderful. And we would appreciate the information and advice you have shared, ma'am. Thanks for your assistance, ma'am. Thank you so much. And any question from the group? Any questions?
Yeah. First of all, wonderful talk, ma'am, as usual. As you mentioned, there is a second generation basal insulin right now available. So, which one is more efficacious and glycemic variability wise, U300 or Degludec?
So I was ready for this question because this is a very important thing. There's a strong competition going on between Degludec and U300, and the US also has some but of U500 coming up, and it's there somewhere. In India, we have U300 and Degludec. So if you look into the pharmacokinetics, I think Degludec fares definitely well. It has been shown to have a good time in range. It has shown to have a good reduction in hypoglycemic events, but at the same time, I would say even U300 has had a good pharmacokinetic profile. So more or less, they do well enough. It depends more on, when you look into the studies which compare both of them, which are many. There are some studies which have been done head to head. But what happens is that the person who gets you the particular salt pinpoints that particular fraction of the pharmacokinetic which suits his salt better. So I think as a neutral person, I would say that yes, both of them have good pharmacokinetics. They are definitely better. If we compare with Glargine U100, definitely they have a much beneficial profile. So yes, amongst them, both of them are good enough. Degludec definitely has a little better edge as compared to time in range, and even they have some cardiac mortality reduction data also.
Even in type 1 patient, madam, most of they are not affordable. And most of the type 1 patient I am from Gujarat, they are on the premix insulin and twice a day. Ideally, it's not advised. And in premix insulin twice a day regimen, there is a hypo and hyperglycemia a lot of in type 1 children. So what we prefer, basal bolus is the ideal in type 1. So, and most of are not affordable. So what your treatment of choice in type 1 patient where the cost is the issue?
Yes, you are very right. In type 1 diabetics, cost is a definite issue, and because it is a therapy which is going to go on and on and on, so and starting right from such a young age, so cost becomes a very important aspect, especially for even the middle class people. Except for the upper class, I think, and the second generation becomes difficult. But yes, basal bolus is what we stress upon, and we have to counsel the patients because premix becomes easier. Cost-wise, if we see basal bolus, the ones which we have, especially in our setup, like I am from Rajasthan, here we have a free government supply of Glargine as well as the regular insulin. We don't have the analogs in free supply, but we have Glargine in free supply. But then we have some groups going on, especially even the RSSDI looks into it, and we can get some, free supply to some patients who are very poor. And a good counseling definitely goes on to it, because once a patient is on a premix, then the ups and downs are so much. As you said, the hypoglycemia, hyperglycemia, that probably the long-term outcome, we are not going to have good outcomes, and the patients are going to have nephropathy and neuropathy and other complications within a few years by the time they reach the age of 25, 30 for type 1 diabetics, I'm saying. So we have to counsel them, tell them that in the long run, this is going to be very beneficial, and to lead a good life and to have a very proper, they should preferably be on the better insulins if possible. Second generation, yes, little difficult for them since it's a very long therapy.
Yeah, in line with this discussion, I would like to ask one question. Like now, you and me and all our doctor colleagues, they know the advantages of analogs. But how should we explain it to the patient against the cost? That is something which needs to be discussed, because many a times it happens that we know the advantages, but patients are not just ready to accept or ready to against the cost. That's the only issue. So how do we explain that? Because the advantages which you have explained in terms of hypoglycemia and all, they are not going to experience it because they are already on the analogs, right?
So I think when we talk about how to convince a patient, yes, you are right, it becomes difficult, but then we have to put in some time, because again, hypoglycemic event, as you rightly said, is much more with the conventional insulins, and hypoglycemic event is one that once a patient gets an hypoglycemic event, then he gets so scared of insulin that if it's a type 2 diabetic, he will say, you give me whatever drug, but I don't want to be on insulin, because I had that one episode, or my father had an episode where he had went hypoglycemic and he was in a bad shape. So we have to counsel him that hypoglycemia is a very severe problem, and to overcome that, these insulins are definitely better. Sometimes the patient himself sees such erratic, fluctuations going on, so much variability going on, that I think at some time in such cases, when we offer him another insulin, they do become acceptable and they do take it. So especially with type 2 diabetics, what I personally do is, when I'm starting the insulin initiation after the OADs, I usually directly go on to analogs, so the patient realizes, okay, fine, this is going to cost this much, but the tablets also don't cost any lesser. So I tell him that your tablets also costing quite a bit. Your insulin, your sugars are not coming under control. So better to go on to this insulin, which is going to be very beneficial in the long run. And then I think that counseling gets a patient to start it. And once a patient starts on an analog, then I think he is very comfortable in accepting it. But yes, shifting over these patients, we tend to see very frequently, they shift back to that same one, conventional, and come back to us after 1 year, again having gone back to the previous conventional one and with hypoglycemic episodes. So that is an issue which needs counseling, and which needs to be told that hypoglycemia has to be prevented, and hence these insulins are definitely better, they score better. And of course, the glycemic control also.
Right, that was really great, because it becomes too difficult for the patients to convince and explain them the advantages what we see.
Let them do a good charting once, let them do a good charting and recording of the blood sugars, they will realize the difference. So I think that part of counseling also goes into. Dr. Arvinda?
Yeah, well, absolutely. Absolutely right, because insulin is always a challenge when you're trying to convince the patient. So in your practice, you work in a medical college, and like when you come across so many patients, do you do personally, or you got any diabetes educator nurse or something like that?
So I have both types of practice in the medical college also and in the clinic also. So yes, in the clinics, we have some attendants who takes care. So this is another very important point Dr. Arvinda has pointed out, probably indirectly, that we can have someone to counsel as well. So in a medical college, it's not that difficult, because we have residents with us, resident doctors, who do quite a lot of work on the patients. And in our individual clinics also, we can spend some time, our educator also spends some time. So then that goes on. And then making a chart, recording your values, and then coming back with the values and seeing how much difference it is. The patient definitely gets satisfied if the range is good, if the values are better and no hypoglycemic events. The patient accepts well.
So in your setting, you are using CGM, ma'am? CGM?
Yes, sometimes we are using.
And any comment on once a week in future basal insulin?
Yes, now that also is going to be, so we are going to have some newer things now, once a week also probably, and the hepatic directed vesicles also. Let's see how it comes up. A lot of things are coming up, but then they need to go through all the phases of trials, and their efficacy, what pattern they have, whether they are peakless or if they are peaks and troughs, everything has to be taken into consideration.
Future will tell us. Yeah.
Future will tell us. So the timeline which I showed is going to go longer and longer, I'm sure.
How is the acceptance of this newer insulin in your clinical practice? Because in Bangalore and all, yes, the moment you say we put an expensive insulin, or so they say, doctor, how long you want to take? Like this, they don't understand they have to take lifelong. Moment you put this, how much our rich they may be, the question they will ask always is, doctor, how much I need to take for 2 months or 3 months, then I can always come back to oral drugs. This is the common question asked. Is this the same with you or anything different?
So no, that class of people which thinks like this, I think there is no point in starting, because it's not a matter of 2 months, 3 months. Better to go with the first generation only and continue with the same. Do you not have any free supply of glargine and all in Karnataka?
Yeah, glargine in the sense, that definitely it is there. But the thing especially in the institution, like BHL or BEL, they gave a free insulin. Now, since the glargine has become as a price control drug, it is very easily accessible. That is a good thing about glargine. But only thing is, when it comes to newer molecules like basal bolus insulin, we always have a challenge. Like the cost is one thing is there. So that is one thing. What about your this one?
Yes,
actually,
yes.
Sorry. I think all over India it's the same story. How much of money people have, they don't want, they don't have that priority of spending on medications. In fact, we prescribe insulin, your insulins, and I think for my case it is like I'm known for giving expensive insulins. They don't understand the advantages behind that. So that is something which is really difficult part while prescribing your insulins.
As far as I would say in this, I prescribe degludec very frequently. So when it comes to insulin initiation, my choice for degludec and is quite often. And yes, if I feel that there is a costicity issue, then I go on to glargine. But then once I shift also to glargine U300, I explain to the patient that your vial is going to contain 450 units of glargine as opposed to the glargine which you were taking, which was containing only 300 units, and the efficacy is also going to be better. So you're going to need lesser number of vials probably. So you can just try and see. Now, once the patient tries and sees, he sees the good results. You mostly do not have a problem because a patient sees a very good result and continues. But there is a class of people who still goes on back to the previous insulins, and then they do not follow up very well, and then they come back after say 6 months, 8 months with some bad control and all this. That class is definitely there. There we cannot do anything. We should keep them on the ones which they afford only. I guess that is best for them.
Achha, that is very nice to hear from you. Basically, I wanted to ask, when you are shifting from first generation insulins to second generation insulins, so what is do you reduce the dose proactively, or do you wait for the SMBGs and then you take a decision?
So basically, I think once we start with one basal to another basal, we can go on with the same dose or reduce somewhat to 80% of the total dose. But usually what happens is, why we are shifting? We usually shift because there is some erratic, probably there is hyperglycemia, hypoglycemia, a lot of such fluctuations going on. So if we are more looking into if there is more episodes of hypoglycemia, better to reduce the dose by 20 to 25%. That is what the literature also states. Otherwise, if there is more of hyperglycemia that we are handling and we are not happy with the results of that first generation, that is why we are going. I think we can continue with the same dose, of course, with a good monitoring and a review. That has to be there. First time we do, let him come back earlier on only, so that we get the results and how he's responding to that particular molecule.
When the patient is on the premix insulin, so it is the toughest job from premix to second generation basal insulin, because premix is very, very cheaper and second generation are on the one is Alto and one is BMW. Because from premix to the second generation basal insulin is very challengeable.
But I think, premix to basal bolus itself is very challengeable, because 2 injections to 4 injections is something the patient does not accept. But then again, our counseling has to go in, as Dr. Arvinda very rightly pointed out. You're educating yourself, both of you, because his insulin is not going, his sugars are going to have a very fluctuation roller coaster, right? So we have to explain that how simpler it becomes with the basal bolus. With each meal, we can do the pre-meal and find out what dose he requires for that particular meal and avoid any hypoglycemic events as well as hyperglycemic excursions. So that is difficult, no doubt. Needs some counseling. We need to be revert back to the patient fast. That is what we have to do, and keep on advising him anytime he calls us. We have to not lose patience and explain to him. That is, I think, what I can suggest.
Regarding the side effects, like have you noticed like insulin side effects? Any difference between the regular insulin and the analog insulin?
So not really, because side effects wise, I have seen better only, like hypoglycemic events being definitely less, but not only as theoretically, but even practically, hypoglycemic events are better off, and the entire what do you say, sugars are quite smooth sailing throughout the day. Side effects wise, no, I have not much come across, because initially I think so many years back when they were newly introduced, there was a fear that probably they might have some, some things which are not said, the mitogenic possibilities may occur. But I have yet to see any such case or even hear or read from the literature. So I don't think I have come across. What about you, Dr. Arvinda? Have you come across any specific side effects with these newer insulins?
No, not really. Like newer insulins are quite accepted very well. So that is
And smooth sailing also. I think we can, once the patient starts on that, we get a little relaxed that now he's going to be okay.
Yeah,
And
that's
not
correct.
having too much of fluctuations.
Okay, now Supratik is here. Sonali, you can carry on. Thanks, Dr. Swati, for the wonderful discussion.
Thank you. Hello, Dr.
Thank you, ma'am.
Thank you,
Thank you,
Dr.
Arvinda.
Swati. It
Thank
was
you
a pleasure
so much.
listening to you. And
Thank you.
once again, good to see all of my friends on board. Thank you, Dr. Arvinda, for this.
Thank you, Dr. Arvinda. Thank you so much. Bye-bye. Bye-bye, all of you. Okay, thank you.
So we have Dr. Supratik sir here. Hello, sir. Good evening to all. And first of all, special thanks to Dr. Arvinda sir for giving this wonderful opportunity. And Dr. Supratik sir is a MBBS, MD, MRCP from UK, FRCP Edinburgh, FS and FSCP from USA, and a fellow in RSSDI. He is MS in endocrinology and diabetes, London, and STOP certified obesity consultant. He is a director, SKN Diabetes and Endocrine Center, Kolkata, and he is a consultant department of the endocrinology at Emrys Saltec at Apollo Sugar, Kolkata. And he's more than 30 international and national publications as the first author, and he's author of 5 book chapters, and he is the part of multiple phase 3-4 studies, including global diarrhea study. So without wasting much time, over to you, sir.
Thank you so much, brother, for all these kind words of introduction. And it's always a pleasure to be invited by Dr. Arvinda for this conference. It's a very unique platform where we get to speak science at the same time have a lot of fun. So I just take a minute to share my PowerPoint. Just a minute, please. So give me a shout if my presentation is being seen.
Yes, sir.
So I'm going to speak about the very basic pathophysiology of heart failure in type 2 diabetes. And this will be followed by my dear colleagues who will be speaking regarding the guidelines driving the management of heart failure, as well as what are the newer paradigms in the management of heart failure. So with this context, let's see what is happening in terms of heart failure prevalence. So if you look at the worldwide data, there are about 64 million people across the world who are suffering from heart failure. And in India, as such, there are about 10 million people with heart failure. So quite a big number we are dealing with. More importantly, 25 to 40% of the people with type 2 diabetes will develop chronic or acute heart failure. So we have to remember that type 2 diabetes is something which is very, very closely associated with heart failure. And that's why nowadays we are talking a lot more about heart failure than we used to before. Also, there's a lot of crosstalk between the heart as well as the kidney. So renal and cardiovascular disease are closely interconnected in type 2 diabetes. And somebody who has the common soil for developing diabetes will also have the same kind of pathophysiological basis of developing both the heart as well as the kidney problems. So it could be the altered energetics, it could be hypervolemia, inflammation, ischemia, sodium retention, neurohormonal activation, or RUS activation. So renal and cardiac systems should be considered together when we are talking about diabetes management.
So heart failure, CKD and type 2 diabetes are often comorbid. So we were talking about the heart failure prevalence, and if we talk about the 2017 data, there are about 64 million people across the world with heart failure. CKD, around 843 million people with CKD. Diabetes, around 463 million people with diabetes. So heart failure and CKD, this is a vicious cycle. One can worsen the other. Similarly, 24% of the patients with type 2 diabetes have heart failure as their first complication. Similarly, 58% of the people with type 2 diabetes eventually develop CKD. So we need to sort of consider all three of these together if we want to manage the comorbidities better. Cardiorenal disease is the most frequent first comorbidity in type 2 diabetes. And you can see in here, heart failure is about 24% of the comorbidity. So this is the first comorbidity that is identified in those people who are free from comorbidities in type 2 diabetes. And 24% of the people, heart failure seems to be the first comorbidity that is identified. If you look at the NYHA heart failure classification, cardiac disease, NYHA class 1 is cardiac disease, but no symptoms and no limitations in the ordinary physical activity. NYHA class 2 would be mild symptoms and slight limitations during ordinary activity. Class 3 would be significant limitations in activity due to symptoms and comfortable only at rest. And of course, 4 will be severe limitations and symptoms even when the person is at rest. What are the signs? We can have typical features of right heart failure or left heart failure signs, or a combination of both. So acute right heart failure signs would be loss of appetite, lower leg edema, or weight gain, whereas acute left heart failure would be shortness of breath during exertion, shortness of breath and coughing at night, palpitations, fatigue, and tiredness. Severe heart failure signs and symptoms would be coughing, pleural effusion, swelling in the abdomen, tiredness, shortness of breath, pulmonary edema, pumping action of the heart grows weaker, and then you have swelling in the ankles and legs. So these are the very, very basic things that we come across while doing a clinical examination for the patient. What are the risk factors? So somebody who's already having a disease that damages the heart, like for example, background of coronary heart disease, high blood pressure, valvular heart disease, infections, heart failure. Sometimes chemotherapy can cause heart failure because it goes and acts at the level of the myocardium. Pregnancy-related heart failure, increased heart rate heart failure, and sometimes unknown causes as well. Unhealthy behaviors like sedentary lifestyles. In obese women, it's seen that 50% greater risk of heart failure is there. Sodium and fluid retention, excess amounts of sodium and fluid intake. So we usually tell people who are hypertensive or with suffering from cardiac conditions to limit their salt intake, eliminate or reduce added salt, limit the fluid to about 2 liters, and of course, anyone who is an alcohol user, we need to ask them to moderate the alcohol intake. Now, coming to heart failure per se, structural or functional cardiac abnormality and results in reduced cardiac output or elevated intracardiac pressure. So less blood pumped out of the ventricles, and because of the weakened heart muscles can't squeeze at all. Or stiff heart muscles can't relax normally, and because of that, you have lesser filling of the ventricle. So these are the basic pathophysiologies underlying heart failure. Also, I wanted to emphasize that diabetes can lead to heart failure through both atherosclerotic mediated as well as atherosclerotic independent mechanism. So mediated mechanism would be somebody with type 2 diabetes who are at risk of heart failure, partially due to atherosclerotic events like myocardial infarctions, or those who are having a atherosclerotic independent pathway would be because of the direct inflammatory effect in the microvascular endothelium and also myocardium with subsequent fibrosis. Now, if you come to the etiologies of heart failure, we know that there could be three, in fact, four types. One is the reduced heart failure. One is the minimally reduced or mid-range heart failure, and the other one is the preserved heart ejection fraction heart failure. So causes of reduced ejection fraction heart failure would be ischemic heart disease, inflammatory damage or toxic damage. Normal or say mid-range would be hypertension, arrhythmia, valve disease, cardiomyopathy, and preserved ejection fraction would be obesity, diabetes, pericardial disease, and chronic kidney disease. Diabetes leads on to hyperglycemia, insulin resistance, and hyperinsulinemia. And especially in the Indian phenotype, who carries a lot more fat around the waist or visceral obesity, we know that the incidence of insulin resistance is much higher. That leads on to inflammation, increased oxidative stress, leading on to endothelial damage, dyslipidemia, cardiomyocyte hypertrophy, and left ventricular hypertrophy. This is partially because of the RUS activation that leads on to fibrosis. Again, calcium handling and fatty acid utilization seems to be on the wrong side, and formation of advanced glycated end products would also contribute to fibrosis. There is also, in addition, autonomic dysfunctions. All of these together would lead on to diabetic cardiomyopathy. The other pathway that we were talking about, because of the endothelial damage, we can have coronary artery disease leading on to ischemic cardiomyopathy, and that leads on to heart failure, and or the diabetic cardiomyopathy leading on to heart failure. So we already said that there could be two basic pathophysiology underlying heart failure in diabetes, and this is what has been explained. If you talk about the mechanism for interaction between metabolism, disturbances, and the heart, so if we start from here, it's mainly the increase in the fatty acids that leads on to substrate synthesis, leading on to accumulation of ceramide. And ceramide accumulation goes on to fibrosis, reducing inflammation and fibrosis. That leads on to cardiac stiffness. And because of the cardiac stiffness, what we see is there is reduced muscle contraction and increased fibrosis, and that eventually would lead on to myocardial dysfunction. Ceramide, on the other hand, would lead on to decreased insulin sensitivity, increase in the glucose levels, circulating glucose levels, and there is reduced glucose uptake that reduces the amount of ATP that is synthesized. So hyperglycemia, hyperinsulinemia, insulin resistance, these are the basic pathophysiology underlying type 2 diabetes. This leads on to increased free fatty acid levels, ceramides, that leads on to decreased muscle contraction, increased fibrosis, increased cardiac stiffness, leading on to myocardial dysfunction. And of course, that would lead on to cardiomyopathy in people with diabetes. So here you would not come across hypertension, dyslipidemia, etc. This is purely affecting the structure of the heart. Again, free fatty acid would, if there's accumulation of the free fatty acids, that by itself leads on to chronic sympathetic activity, leading on to hypertension, or a free fatty acid accumulation leads on to vasoconstriction, leading on to sodium reabsorption, increase in the blood pressure, and thus causing hypertension. Over on top of that, if you have insulin, which is usually involved in glucose uptake, and if that is faulty, that leads on to hyperglycemia, or if there is insulin resistance, that would increase the risk of heart failure progression, because free fatty acids that are in store would go and increase the risk of metabolic disturbance and heart failure. Now, the link between heart failure and kidney disease in type 2 diabetes is very simple. Heart failure. So if you look at the renin-angiotensin-aldosterone system activation, the sodium and water retention and vasoconstriction, this would lead on to worsening of the heart failure. And because of the heart failure, compensatory mechanisms to restore the cardiac output would be put into place. There'll be increased venous pressure, increase in the sympathetic nervous system activation. This in turn would go and lead to a kidney damage. This kidney damage will further worsen the sodium and water retention, etc. So together, there will be a cardiorenal syndrome. So there's a bidirectional interaction between the heart and the kidneys, and acute or chronic dysfunction in one organ will be influencing the dysfunction in another organ. So let's talk about the natriuretic peptide system and the RAS and sympathetic nervous system. So they act in opposite direction, and both obviously act on the heart as well as the kidney. And there's a fine balance between the natriuretic peptide system and the RAS system. So initially, if you're talking about the early heart failure, there is cardiac stretching that leads on to BNP release, and that would increase the EGFR, increase the GFR, leading on to decrease in the renin, and that would lead on to natriuresis and diuresis, reducing the blood pressure. The BNP also leads on to sympathetic nervous system activity, leading on to vasal relaxation and reduction of the blood pressure. But what happens when it becomes chronic heart failure? In chronic heart failure, there is decrease in the cardiac output that would increase the renin levels, and that would put forward the angiotensin mechanism, increase in the angiotensin 1 and 2 levels, leading on to sodium and water retention. Reduction in the cardiac output also would lead to activation of the sympathetic nerves, leading on to vasoconstriction and also increase in the blood pressure. So there's no compensatory mechanism that is seen in the early heart failure. So a chronic heart failure, once it is set into motion, is very, very difficult to handle at that. So again, going back and connecting the heart and the kidney together, there are many multiple complicated pathways that are there, putting forward, a crosstalk between the heart and the kidney. But acute heart disease or procedures like acute decompensation, ischemic insult, coronary angiography, cardiac surgery, etc., would lead on to decrease in the cardiac output, leading on to decreased perfusion, increased venous pressure, and that would be leading on to acute renal injury. Now, because of the renal injury, again, you have a worsening of the heart failure. So there would be a sympathetic activation. There will be a RAS activation, sodium and water retention, vasoconstriction, BNP release, natriuresis. All of these mechanisms come into play. And finally, there will be worsening of both the heart as well as the kidney failure. Now, what happens if you are suspecting heart failure? So you have to take a robust clinical history, as we had shown you the signs and symptoms with which the patient presents to you. In the acute settings, you would be doing NT-proBNP as a marker. So if the ECG is normal and the NT-proBNP is less than 300 or BNP is less than 100, then heart failure is unlikely. But we have to remember that the NT-proBNP levels are different for different age brackets. Similarly, if the ECG abnormality or NT-proBNP is higher than 300, then it's suspicious of heart failure. And this scenario, that would warrant an echocardiogram. In non-acute settings, again, you do a NT-proBNP or a BNP. And if the ECG abnormality or NT-proBNP is more than 125 or BNP is more than 35, get an echocardiography done. And if heart failure is confirmed, then determine the etiology and start appropriate treatment. And if it's lesser than that, then heart failure is unlikely. So it's a clinical call. First, getting a robust history, examining the patient, and then doing the basic tests at the bedside, and then the lab tests, followed by echocardiogram to diagnose heart failure. So what are the goals of therapy in heart failure? To increase survival, so reduce mortality, premature death, either by reducing two main modes, sudden cardiac death or death from progressive heart failure. Reduce hospital admissions. So we know that it's distressing to the families in terms of cost burden as well as poor prognosis, and it also reduces the quality of life. So improve symptoms of quality of life, allow people to continue to lead normal life unrestricted as much as possible. So we are advancing and we're getting to know more and more therapeutic options that are coming up. And that will be the topic of discussion for my next speaker. There will be a discussion on the paradigm shift in the heart failure management. So with this, thank you so much for your kind and patient hearing. And I stop my presentation here and back to the chair.
Thank you, sir. That was a wonderful presentation with lots of valuable knowledge. Thank you so much. Over to the chairperson. Ma'am, you can introduce the next speaker.
First of all, congratulations
we'll have
for
a
very
discussion.
fantastic presentation, Dr. Supriti. So we would have, the first question to go here is, as per the treatment, we are preparing SGLT2.
Recording stopped.
Options on board, which not only addresses the glycemia, but also addresses the heart failure risk. So we are getting to more and more about this molecule, especially SGLT2 inhibitors, which can be used across the board of diabetes management, and especially it is now part of all the various guidelines that anyone with a background of heart failure, you need to use a molecule like SGLT2 inhibitor ahead of others. And we already were pretty convinced about the use of SGLT2 inhibitors in reduced ejection heart failure patients. But now we are gathering data with initially with EMPA and then with DAPA, that it can be used in the preserved ejection heart failure or the mid-range as well. So we now have therapeutic options, not only in terms of secondary prevention, but we can use these molecules as primary prevention as well, because the studies that were done were with population who had diabetes, who didn't have diabetes, but were in the process of developing diabetes as well. So many pre-diabetic or non-diabetic patients were on board as well. So we can go and treat at the level of primary prevention of heart failure.
Yeah, so don't you think that with SGLT2 inhibitors available, we are diagnosing more and more number of patients of diabetes with heart failure?
Yeah, so I think we are now being very aggressive in terms of identifying people with heart failure. Maybe this was always there, but we are trying to understand the basic pathophysiology behind and the connection between diabetes and heart failure. This is much talked about now. So I think this is a good thing because we are identifying more number of cases who can end up in heart failure and start treating at the early stage so that they don't advance into the stage of heart failure.
Right.
So I think one comment from me. So I think today only I have one patient whose ejection fraction was around 34-40. Two different cardiologists did his echo. He was on ARNI, but he came for managing diabetes with me. So I have added SGLT2 inhibitor. So I think 5-6 days before, his echo shows his ejection fraction 60%. And his doctor was also happy, cardiologist, because he also want to add me SGLT2 inhibitor. So so how do you come across such cases where the ejection fraction is actually improved with such with SGLT2 inhibitor?
No, so I mean, now we have, say, 5 pillars to treat heart failure, and I'm sure we'll hear more about it when we hear about the management of heart failure. So obviously, we have to talk about the RUS inhibitors, as well as the ARNI being the second one. We have to talk about beta blockers. We have to talk about diuretics. Now, SGLT2 inhibitors are like the fourth pillar. And the fifth pillar is coming up with something called the Bericagat, which is just being launched in India. So this is a treatment option for heart failure. So also we are going to talk about, the aldactone-based therapies as well. So we have now all these sort of therapeutic options to treat heart failure. We need to use all of them if needed, So it's not that we want to use one and leave out on the other. So ideally, all of these should be used in the optimal amounts so that the patient gets the maximum heart failure benefit. So say, for example, as you said, if somebody is on ARNI and then you put him on a SGLT2 inhibitor and you see that there is a progressive increase in the ejection fraction, we want to ensure that the person is also getting a support of a beta blocker, getting a support of a, aldactone-based therapy. So all of these needs to be on board to ensure that we are getting the best therapeutic option for this patient.
Yes.
Hope that makes sense.
Yeah, that was wonderful explanation, I guess. I wanted to ask you regarding the diagnosis. You showed in your slides that for the diagnosis, of course, you have to go by the clinical history, but then sometimes you can order the laboratory workup in terms of proBNP. So how often the proBNP is being used in clinical practice for the diabetic population routinely? What is the clinical situation wherein you should order proBNP?
Correct. So I think NT-proBNP is an expensive test to order. So probably in routine clinical practice, it would be difficult to order NT-proBNP. However, we who practice in a semi-urban setup or an urban setup, I do it pretty frequently. If I have suspicion of heart failures, if initially by taking a robust history, I find that there are pointers towards heart failure, then I order an NT-proBNP. And as I mentioned, the number is dependent on the age as well. So we have to remember that. So if it's an older individual, higher NT-proBNP values are quite normal and within the normal range. So we have to take that into consideration. But it's a good starting point. And if we see that the numbers are high and there are symptoms, as I had shown you, then it would be a good reason to do an echocardiogram and see whether the person is actually in heart failure. And because we know that some of the therapeutic agents that we use in diabetes, like pioglitazone, if there is a heart failure that is developing, you need to stop that molecule and start them on therapies which benefit them in terms of the heart failure outcomes. So I think that's quite important information to be on board. And I actually, in my clinical practice, do it quite often, so as to say.
First of all, excellent talk as usual, Dr. Supratim sir. My question is, sir, right now in market, valsartan and sacubitril combination available. So what are your opinion in type 2 diabetic patient in heart failure, and when to ideally start in this patient?
So I think there is nothing wrong. I just had a crosstalk with one of my cardiology and nephrology colleagues day before yesterday. So they're of the opinion that so ARNI still remains expensive molecule before it goes off patent. So we are absolutely, from the paradigm study that we had, we are absolutely convinced about the potential of ARNI in heart failure management, especially in the reduced ejection heart failure patients. So anyone with reduced ejection heart failure, you need to give them ARNI, and you need to give them SGLT2 inhibitors because we have evidence for that. So one is not exclusive of the other. So all the heart failure management therapeutic options needs to be on board. Now, start with a lower dose. And remember, we always say that if the person is on a diuretic, then you need to reduce the dose of the diuretic if you're putting them on ARNI, and then gradually go up the dose. But if affordability is an issue, it's better to keep them on a lower dose twice daily rather than not give them money at all.
Okay, what that was a so excellent talk, Supratik, and very delightful discussion from Dr. Sonali and Dr. Malai. I thank you, Dr. Malai Parekh and Dr. Sonali, for wonderfully conducting this session, as well as being a part of our conference. Next, what is a there is some technical issue, Dr. Neelam has told from RX event. There is a chat in the chat box. There
Dr. Malay Parekh sir to introduce Narsingh Verma sir.
Shall I introduce, sir?
Yes, sir, you can go ahead.
So our next speaker is a towering personality we are all very much aware of. He is a professor and head of Department of Physiology and an official and head of Department of Family Medicine. And he is a fellow of Diabetes India and RSSDI. He is FRCP London and Edinburgh. He has numerous awards, international, national, and publications which run over 200. And is holding important positions in all the major scientific bodies like Association of Physiologists of India, International Society of Medical Nutrition, Indian Society of Hypertension, and UP Chata RSDI. Now let's over to the Dr. Narsingamma sir for his talk. Thank you.
Thank you. First of all, I would like to thank organizers, especially Dr. Arvind Jagdisha, for inviting me this very exciting event, which I'm witnessing. Very technocrate event, I will say. And I have been given a talk which is related to insulin, and especially in the insulin, use of insulin, the basic, yeah. Whether my slides are visible?
No, sir, it's not visible. No, sir, it's not visible. Kindly, technical team, please go ahead with the slides.
No. It's moving. It's moving. Fine. Fine. Thank you. So thank you. Thank you. First of all, sorry for this all clinical, the technical delays, glitches. First of all, I would like to thank Dr. Arvinda for inviting me to this very prestigious event. I have seen since morning I am attending it via different link, and a few topics were very good, excellent, and good discussion was going on. So I have been given the topic about insulin injection technique and adverse effects of incorrect insulin administration. Since the advent of insulin, as the insulins have advanced, the techniques have also advanced, and we have used several techniques for the delivery of insulin. But before that, I will like to talk about how many percent of individuals in diabetes are using insulin. Approximately 31% of diabetic patients are treated with insulin. Out of that, 15.4% use only insulin, and 13.6% have both OAD and insulin. So a good number of patients, around 1/3 of the diabetic population, is using insulin. So it becomes very important to note that what technological advances have occurred and how the insulin technique is important. And injection technique is critical in therapeutic success of insulin, because if the technique is not correct, then the delivery of insulin will be different. And not only that, improper use of the technique can lead to pain, and you know that this is the biggest factor by the patients. Patients say that we don't want to use insulin just because they think that it will be painful. We doctors know that it is not painful, but still, I have seen even doctors, if they are asked to do their blood sugar by glucometer, they are afraid of, and they usually think it is painful. So these things are so critical that just by saying it will not go away. So pain is a very important factor, and bleeding. Improper use of the injection of insulin can have bleeding and bruising, because once the bleeding is there beneath the skin, it will be called as bruising, and breaking and lodging under skin, that can also happen. And doses inaccuracy, poor glycemic control, because if the doses are not accurate, then the glycemic control will be a mirage. It cannot happen. So poor glycemic control will be there, and lipodystrophy. We all know that if the injections are used and they have not been used properly, that can cause lipodystrophy. And there are several reasons for it. One can be that the needles are very old. They have been used again and again, or the same site has been used and the site has not been rotated. And that is also very important. Then the practical tips to minimize pain with insulin injection. I said that pain is most important. Then what are the practical tips to minimize pain while giving insulin injections? And to minimize pain, one can have few things, and they are: injections in use should be kept at room temperature. They should not be very cold. If they are very cold, and usually what the patient do, and we don't advise them correctly, that injections should not be kept inside this phrase, and especially should not be used in cold temperature. Skin should be dry before injecting. This is also very important. Usually what happens, alcohol straps have been used, and the alcohol straps, just after using alcohol strap, injection is given. So the skin is not dry, and if it is not dry, the insulin can spill over, and the required dose may not go there. Injecting in root hairs should be avoided, because if after the time of giving injection, if somebody gives in the hair root, then what will happen? There are chances of infection, and that can have even abscess can happen. Short needles with fine gauze should be used. Today, this issue has been solved if we are using the proper needles. These proper needles are so small and they are short so that they cannot go beneath one point. So it will remain subcutaneous. It will not be muscular or it not be intravenous. It will remain subcutaneous. So the size has been capped and now we have the correct size of needles. But before that, the insulin needles were not having that cap and they were having different size. So short needles were preferred at that particular time. Insulin needle should be inserted at 90 degrees to the skin. This is very, very important. Most of the patient and some of the physician think that if they have angle, then probably the patient will experience less pain. But that is not correct. It is 90 degree because only 90 degree will enable the needle to reach the subcutaneous plane, and then the insulin will reach to the subcutaneous plane where it should be. So 90 degree angle is very, very important. The splitting of the insulin dose should be considered if large doses are required. This was true few years back because we were having insulins of 100 IU and now we have the insulins, more concentrated insulins. So the doses can be not be a problem, but still, if the doses are very high, it is better to have 2 doses rather than the single dose. A single heavy dose will have more insulin in volume, and more volume will definitely have the problems, and then that will that insulin will not pass through and absorb. So splitting of the doses is required when we are doing it in more than 40 unit or 50 unit or 60 unit. Then it is better to have the 2 split doses rather than a single dose. Insulin should be injected slowly and care should be taken and to completely depress the thumb. So insulin should not be injected at very fast rate. It should be injected slowly and care should be taken to completely depress the thumb, and complete delivery is very, very important. And if you are using pen and depressing the thumb button plunger while injecting up to the maximum so that every point of insulin should reach to the target. And it is very important because somebody releases it very early, then part of the insulin will remain inside the pen and complete delivery will not be there. So these things are very, very important, while the practical tips are very important while delivering the insulin. Then the preventing bleeding and bruising associated with insulin injections. This is very important because if somebody complains that, doctor, I'm having bleeding and I have developed bruises after the insulin injection, that is evidence that probably the patient is not correct, not using the correct technique, and the technique used is not proper and had to be educated again. And here we have to keep in mind use of needles of shorter length that I have repeated so many times, and review of the injection technique again, because there's some fault in technique. Because of that, the bleeding is there and bruising is there. Avoidance of bleeding and bruising site completely. Where the bleeding has already occurred and bruising has occurred, that site should not be used at least 4 or 5 days after giving that particular injection, and that should be avoided completely. So that will help. And one more condition can be there if somebody is having bruising and the bleeding after every injection, then repeatedly, then one can think upon some other condition, which may be because of the use of aspirin, or one can go for bleeding time and coagulation time, or PTPC, or even the INR, to find out other regions which can also be there, because sometimes it may not be because of technique, maybe something else. And right way to administer insulin. Site is very important. And when we talk about site, the patient should be educated that what are the proper site where insulin can be given. And the most proper, most prominent, and most commonly used site is the abdomen. In abdomen and thighs, they are the most commonly used site. The anterior of abdomen and anterior of thigh. Always anterior of abdomen and anterior of thigh should be the proper site. Other site can be buttocks and arms, but they are not that common. But in long-term users, the other alternative sites had to be considered, because long-term use, the even rotation of the site will not be able to perform that, because the patients having 2 or 3 injections per day, then the repetition of site can occur. Rotation of injection site is very, very important. The horizontal pattern one can use, and you can see very well here the horizontal pattern. Here you can see horizontally injections are given one after another, and then we come vertically and again then horizontally, and you have to avoid this area of umbilicus. This area had to be avoided, and even near to umbilicus injection should not be given. And then horizontally one can have this swastik like directions, and then curve pattern can also be used. Here the curve pattern has been shown. Again, injections are given here. Again, the curve like S, the horizontal S can be used, a curve pattern. Zigzag pattern can also be used, but the patient can be confused. So what I can suggest here, that crisscross and zigzag pattern can also be used. But what I suggest to my patient, that they can use the proper circle site. Circle, the large circle, then small circle, and further small circle. That is most simple one. So these are the methods. One can have the 1 injection, 2nd injection, 3rd injection, 4th injection. Similarly, 1 injection here, 2nd here, 3rd here, and 4th here. So these are the methods of rotation of injection sites. No matter how you rotate, but rotation is very, very important. Avoidance of reuse of needles and syringe. This is very, very important in country like India. This reuse phenomena is very, very common, and adverse consequences of reuse of needles and syringes are seen. This is a new needle you can see here, and this needle has been used once, and you can see the changes have occurred, and this has been used twice. You can see the changes, and this needle has been used several times. So the needles, when used several times, can have the different problems, and whenever they are used, they will have more damage. They will have more damage, and when the damage is more, definitely the patient will have more pain, and painful injection, breaking off and lodging of needles under the skin will also be there. Then the incorrect administration of insulin, either it is too little or too much or at wrong times, can result in transient and serious hypo and hyperglycemia. So this is very, very important. And there will be wide glycemic excursions, and diabetic ketoacidosis can also happen. The patient is happy that he's taking insulin, and doctor is happy that he thinks that he has advised insulin, but the glycemia has not been achieved, and patient can end up into hypo and hyperglycemia just because of incorrect administration of insulin. Injection site selection and diabetes numeracy were also concerns, and correct timing of injections and confidence in choosing correct doses, but not scale scores related to better A1C and blood glucose levels. So correct timing of injection is more important. Confidence in choosing correct doses is important. Even you have some corrections in the skills that can be taken as a factor, but this is not going to affect much. So by repeated education, one can achieve that. Then the analysis of insulin errors have been done, and in the emergency department visits of for hypoglycemia, in addition to intentional errors, the authors have also identified other insulin errors, including unintentionally took wrong insulin product. That also happens, and meal-related misadventure can happen, and the pump-related misadventure can also happen, and other problems can also happen. I will conclude within 1 minute. The variation in absorption is very important factor, and variation in insulin absorption can cause change in blood glucose levels. Insulin absorption is increased by injecting into an exercise area such as the thighs or arms where the exercise is being done. So injecting there can have the fast absorption, and high temperature due to hot shower, bath, hot water bottle, spa and sauna can have that. Messaging the area around the injection site, injecting into muscle, this causes the insulin to be absorbed more quickly and could cause blood glucose level to drop too low. Factor that can delay insulin absorption or can be delayed by overuse of the same injection site, which causes the area under the skin to become lumpy or scarred, known as the lipohypertrophy. And insulin that is cold, for example, insulin is injected immediately after taking from the place. And moreover, use of tobacco can delay the absorption of insulin. So the time does not permit me to talk much. I will stop here. And now I think I'm open for the questions. I was very short just because the time allotted was not enough to talk about much about the insulin techniques. Whatever I have done in these 12 minutes.
Very nice presentation, sir, because this is a very important actually patient needs to. In our most of the time in our busy OPD, we are not discussing all such thing with our patient, and this is a very important thing, because if in our day-to-day patient, we most of the time we see many patient, on particularly type 1 diabetic patient with lipohypertrophy, no rotation of particularly insulin site, and all the possible side effects. So that is very important. So I think all my co-chairpersons are there. So
no doubt, sir, these are very small but very important and practical points. They make a hell lot of a difference between a optimal control and a poor control. And I don't think we find so many points in a standard test book. I think if I request them, this slides should be actually be propagated among the physicians, so they are also wiser, because a lot of points I don't think people will be realizing or might not be knowing at all.
very true. And I think some companies are now providing diabetic educator services to those patients who were initiated on insulin. And in most of the time, we never discuss this with patient, and this is very basic thing. So these are very basic things. So how to rotate the insulin site, how to take insulin, when to change needles. If patient
few more things which I was not able to cover was about the storage of insulin. That is also important, but the time does not allow me to cover that. And few companies have done few programs by the name of FIT, FITTE, FIT, and FIT principles are given for that particular purpose to educate masses about the injection techniques.
Thank you, sir. Thank you for an excellent deliberation. That was a very important one. As Amitesh and Rajesh said, it was very important topic, and it is a need of the hour. So thank you, sir. We'll move on to next session by Dr. Abhishek Srivatsa. Over to Dr. Karthik, please.
Yeah, hello. Thanks, Arvind. And the next topic will be by Dr. Abhishek Srivatsa. He's an MD, PG Diploma in Endocrinology in Royal College of Physicians from Cardiff University, England. And he's the endocrine and diabetes physician and hormone clinic in Jabalpur, Madhya Pradesh. So he has a lot of credentials, and so he's received a lot of award. The recent award was in 2020 for hypogonadism. So over to Abhishek to start your topic.
Thank you. And I would like to thank Dr. Arvinda for inviting in such a nicely coordinated and highly prestigious conference. And I hope he'll call me next time in physical. Because
Seriously, because of this new regulation, this is the problem. Delegates problem.
yeah, no problem. No, but still it is actually well managed and well coordinated program. Superbly done, because you all actually face the problems of the time, but it is actually well managed. So thanks a lot. Thanks a lot, Dr. Arvinda, for inviting.
Thank
And
you.
I'll be sharing the slides soon. So the slides are visible, right?
Yeah.
Slides, yes. Okay. So good evening, everyone. And I hope in the previous link where Dr. Supratik was discussing about the pathophysiology of heart failure, I'll be quickly discussing about the guidelines, what the American Cardiological Society or American Heart Association or ESC does, gives us some recommendations, protocols as to how we should go with the management of heart failure in type 2 diabetes or even without type 2 diabetes. So quickly move on. So basically what we need to learn is how to see the recommendations as the strength or a class or a level of quality of evidences. So quickly I'll be like discussing I'll be explaining what all these recommendations does mean actually. If I talk about the class of recommendation, actually when we say that this drug is class A recommended, that means class A is highly recommended because it has actually it has been indicated, it is actually useful, it is effective or beneficial in the management of heart failure. I'm talking about heart failure, and should be performed or administered or anything else. There had been a high level of randomized control trials which had been done with this drug, and it has been highly recommended. So basically class 1 has a very strong recommendation. If I say about class 2A, say it is actually moderately recommended, but still it can be compared with class 1 strong recommendation. More or less the trials are bit not I would not say inferior, but they have not been proved to be superior than the last RCTs. So basically class 2A could be termed as a moderately recommended. If I talk about class 2B, it has a weak recommendation. There has been certain risk involved in prescribing this medication. It might not be reasonable to prescribe this medication, or the usefulness or the effectiveness has not been established fully. And class 3 actually no benefit, has a very moderate risk. It should not be prescribed. And even class 3 strong anti-recommendation, that means it should not be prescribed. It is potentially harmful for that patient. If I talk about the level or quality of evidences, basically if I say level A recommended, that means high quality evidence from one or more than one randomized control trials. Randomized control trials, it could be a meta-analysis, multicentric, randomized control trials basically. If I say level BR, that means that is also as class 2A. It has can also be compared as level BR as level A. Moderately actually non-inferior, or I would say not inferior, could not prove to be superior than level A. So the level BR actually is moderate quality evidence from one or more RCTs. Level B NR is non-randomized trials had been done on those drugs. Moderately quality evidence still there, but actually these trials have the trials which had been done on this drug had been non-randomizedly executed. And observational, albeit I'm not talking about any non-randomized, be it observational study or even registry study, could also be termed as level B NR. If I say level C, limited data, level C LD. LD is actually limited data is available, be it randomized or not randomized, observational or registry studies, and they have limited data to prove as this drug is being is beneficial actually in the treatment of heart failure. And if I could say level CEO, EO actually is expert opinion. It has been, what is the meaning of an expert opinion? The consensus of expert opinion based on clinical experience. Now, we could easily say COR and LOE are basically determined independently. What is actually, see, level of evidence can be correlated with any COR, class of recommendation. I've already explained to you what is COR, it is class of recommendation. So basically class of recommendations can be determined independently or can be given along with the level of evidences also. Let's move on quickly to the stages of the heart failure. Basically, stage A, stage B, stage C, and stage D. Stage A, actually, we all have studied empty of times what is stage A, at a risk of heart failure, stage B, pre-heart failure stage C, symptomatic heart failure, and stage D, advanced heart failure. If I talk about the classification of heart failure by left ventricular ejection fraction, basically, we actually refer the patients quickly for a 2D echo. So if I could classify heart failure by left ventricular ejection fraction, then heart failure with reduced ejection fraction is actually ejection fraction less than 40%. Heart failure with IMP ejection, IMP is moderately preserved ejection fraction. Moderately preserved ejection fraction means previous LVA was less than 40% and follow measurement of LVF more than 40%. So previously when a patient came to you with LVF less than 40%, but after the proper follow-up and the medications, the LVF had improved to more than 40%. Although it is very likely not any, there are no decisive studies which had been done where we could say, okay, that the ejection fraction of less than 40% has turned up to more than 40%. Now, HF MR ejection fraction, what is actually MR moderately reduced ejection fraction, where LVA varies between 41% to 49%. Evidence of spontaneous or provocable increased left ventricular filling pressures. Example, I'll talk about the elevated natriuretic peptide, non-invasive and invasive hemodynamic measurements. All these are diagnostic procedures. And lastly, heart failure with preserved ejection fraction, that means LVEF of more than 50%. But what we should be concerned is heart failure with reduced ejection fraction less than 40 and heart failure with preserved ejection fraction less than more than 50%. And between these two, 40 and 50 comes moderately preserved and moderately reduced ejection fraction. Now, if I could quickly classify heart failure on a diagnostic algorithm basis or based on HF and LVI base, quickly we can clearly see what I've explained it in the previous slide as LVF less than 40, 41, 49, and 40 and more than 50% slide. This is actually the same slide as the previous one. Now, to summarize, I'm not ending it right now, but to summarize in it, in actually 10 take-home messages is actually the guide. GDMT is what it is. GDMT, it is guidelines directed medical therapy for the treatment of heart failure. Now, GDMT for reduced ejection fraction includes 4 medication classes that include SGLT2 inhibitors. Why I'm talking SGLT2? Because we are actually relating heart failure with type 2 diabetes, or we could say type 2 diabetes could actually lead us to congestive heart failure. So SGLT2 inhibitors had been included in the 4 medication classes for the treatment of heart failure with reduced ejection fraction. And SGLT2 inhibitors have a class 2A recommendation. I've already told you class 1, class 2A recommendation in management of heart failure with moderately reduced ejection fraction. Now, new recommendation for heart failure with preserved ejection fraction for SGLT2. It can also be given for those patients also with preserved ejection fraction. Actually, has a class 2A recommendation. MRAs, mineral antagonist are 2Bs, and ARNIs 2B has the recommendation. So that means SGLT2 has a very strong recommendation for the treatment of for the initial management of treatment of heart failure with reduced or either preserved ejection fraction. Now, improved LVAF. What is meaning of improved left ventricular ejection fraction? Refers to heart failure with reduced ejection fraction where LVF is now more than 40%. These patients should continue the treatment of the class where we could consider those patients as heart failure with reduced ejection fraction. Do not ever be lenient on those patients where LVF was previously less than 40%, but now after proper I would request to please mute, please, actually.
Yeah, no problem.
So values. So value statement for recommendations were high quality, cost-effective studies have been published, and evidence supporting increased filling pressure is important for heart failure diagnosis if LVF is more than 40%. Now, patients with advanced heart failure who wish to prolong survival should be referred to a team specializing in heart failure, including palliative care consistent with the patient's goal of care. Stages of heart failure were revised basically to emphasize new terminologies, including those at risk for heart failure, stage A, or pre-heart failure stage B, where primary prevention is important. That is the why primary prevention is important, because we have seen, even in perspective of diabetes, a person who is at a stage of pre-diabetes has the risk of developing coronary artery disease or even micro angiopathies, as same as a patient who is suffering from type 2 diabetes since last 5 years. That is why we always recommend patients to diagnose at a pre-diabetic levels and treat them aggressively, be it at a level of HbA1c of 6.07. Legacy effects is there, and it has been proved in the UKPDS trial. Now, recommendations are provided for patients with heart failure and deficiency, anemia, hypertension, sleep disorders, type 2 diabetes, atrial fibrillation, coronary arteries, and malignancy. But of these things, two most important things which I would recommend is actually to look out for anemia and sleep disorders. Obstructive sleep apnea could also be considered as a major risk factor for the development of congestive heart failure, along with iron deficiency anemia. So two things actually we should actually put majorly in part of diagnosis is to diagnose iron deficiency anemia and diagnose obstructive sleep apnea. So causes, we all know what could be the causes of heart failure. I would not go deep into these things. Now, if we could talk something about the initial evaluation of patients with heart failure, basically, history and physical examination is of utmost importance. It has been given as a class 1 recommendation. Measure vital signs and assess the evidences of congestion, evaluate for the presence of advanced heart failure, and even in patients with cardiomyopathy, use a third generation family history to screen for inherited disease. That is of utmost importance. That is why we always say history. Even in the UG time, our seniors or professors would always emphasize on history taking and physical examination. So class 1 recommendation, history and physical examination, and laboratory and ECG study has also been given as a class 1 recommendation, where CBC, urinary albumin ratio, serum electrolyte, serum creatinine, BUN, lipid profile, LFT, iron studies, and thyroid stimulating hormone. Now, thyroid stimulating, why it has been included? Because in few recent studies, hypothyroid has also been seen to be associated with congestive heart disease or congestive heart failure. So basically, history, physical examination, ECG testing, and laboratory investigation, class 1 recommendation. Now, if for chest X-ray, patients present with dyspnea, patient presents to with the risk of heart failure, patient present with the risk of with chronic heart failure diagnosed, in patient hospitalized for heart failure, all these things, basically use of biomarkers are of utmost. What are the biomarkers? Basically, we know, we always have studied all those BNP and anti-pro-BNP profiles. So these biomarkers should always be used, be it a patient with dyspnea or at a risk or hospitalized or with diagnosed chronic heart failure. All these have strong class 1A, 1 or class 2A recommendation. Now, if I would say chest X-ray, class 1 recommended in patients with suspected or new onset heart failure or those presenting with acute decompensated heart failure, a chest X-ray should be performed to assess heart size and pulmonary congestion and to detect alternative cardiac, pulmonary, and other diseases that may cause or contribute to the patient's symptoms. So, and if I say about TT in patient with suspected or newly diagnosed heart failure, TT should be performed during initial evaluation to assess cardiac structure and cardiac functions also. If I say about cardiac CT, CMR, PET scan, class 1 recommended. In patients for whom echo is actually inadequate, alternative imaging, example CMR, cardiac, CT, radionuclide imaging or PET scan is recommended. Now, ischemic evaluation, class 2A recommended. In whom, in patient with heart failure, an evaluation of possible ischemic heart disease can be useful to identify the cause and guided management, basically. But in patients with heart failure and CAD who are candidates for coronary revascularization, non-invasive stress imaging like stress echo, single photon emission CT, CMR, or PET scan may be considered for detection of myocardial ischemia to help guide coronary revascularization, but it is actually not very highly recommended. It has a class 2B recommendation. And class 3 in those class where initial evaluation is actually not beneficial is basically those in patients with heart failure in the absence of clinical status change or treatment intervention that might have had significant effect on cardiac function, or candidacy for invasive procedure or device therapy. Routine repeat assessment of left ventricular function is actually not indicated. If I say about invasive hemodynamics, it is actually recommended as a class 2A evaluation procedures in select patients with heart failure with persistent or worsening symptom signs, diagnostic parameters, and whom hemodynamics are uncertain. Invasive hemodynamic monitoring can be useful to guide management, but all these things usually come after proper history taking and proper evaluation of that patient. Now, if I say about endomyocardial biopsy, certainly it has also been recommended as a class 2A evaluation procedure. But in patients with heart failure, endomyocardial biopsy may be useful when a specific diagnosis is suspected that would influence therapy. Basically, but for this you have to rule out or other associated diseases or other associated comorbidities. So invasive evaluations are most appropriate when they will guide management and influence therapy due to the risk of complications. Invasive procedures should not be used for the routine evaluation of heart failure. That is for sure. Now, I've already discussed about these things. Clinical assessment, basically, high heart failure risk scoring should always be done. It is actually class 2 recommended in ambulatory or hospitalized patient with heart failure. Validated multivariable risk scores can be useful to estimate subsequent risk of mortality. Now, selected multivariable risk scores to predict outcomes of heart failure, basically for acutely decompensated heart failure, ADAIR classification and regression tree model actually is most important. Then effect risk score or escape risk model and discharge score, all these actually scores are there for patients who are acutely decompensated heart failure. Now, if a patient comes to you with a chronic heart failure, then Seattle heart failure model is there, heart failure survival score is there, or corona risk score is there. All these risk scores are actually beneficial and useful for the diagnosis of heart failure. Now, recommendations for patient at risk of heart failure and pre-heart failure. As I've already explained to you, why it is important to diagnose and treat patient at a pre-heart failure stages. Now, if a patient is at a risk of heart failure, stage A, what should be done? Primary prevention. Patient with hypertension, optimal blood pressure control is required. Patient with type 2 diabetes, optimal diabetic control is required. That is why we always say optimal diabetic control is required, but do not over-treat that patient. Try to keep the HbA1c levels varying between 6.5 to 7.5%, but in bringing down the HbA1c level to 6.5 to 7.5%, optical medical therapy actually is required, wherein the treatment with SGLT2 inhibitors is actually compulsory because it has been included in the class of drugs for the treatment of heart failure. Patient with CVD, treat CVD. Patient with exposure to cardiotoxic agents, do take care of those things. So basically all these things are actually the primary preventary things. And patients with risk of heart failure, certainly natriuretic peptide screening is of utmost importance basically. And a patient is at a risk of when a patient is at a risk of heart failure, validated multivariable risk score is also actually recommended as a class 2A evaluating procedures. Now patient is at a pre-heart failure stage B. Now how should we go with that? Preventing the syndrome. Patient with LVEF of less than 40% is in a pre-heart failure stage. ACE inhibitors should always be included along with SGLT2 inhibitors. Patient with recent MI and LVEF less than 40%, ARBs should be considered over ARB should be considered over ACE inhibitors only when ACE inhibitors actually shows intolerant or some few serious side effects also are there associated with ACE inhibitors like dry cough. Persistent dry cough is actually associated with ACE inhibitors. So actually when ACE inhibitors are not well tolerated, then ARB should be considered over there. A patient with beta blockers where LVF is less than 40%, patient with LVF less than 30%, then ICD, I will be discussing about the devices in later slides. Patients with LVF of less than 30%, but more than 1 year survival or more than 40-day post MI, then ICU should be considered. And patient with non-ischemic cardiomyopathy, then genetic counseling and testing should be done, has a recommendation of class 2A. Now, treatment of heart failure with reduced ejection fraction is stages C and D. We have discussed stage A and stage B, stage C and stage D. Basically, I would be very quick if I'm not late, I see. So step 1, establish diagnosis of heart failure, address congestion, initiate guidelines directed medical therapy. Heart failure, reduce ejection fraction less than 40%. ARNIs in NYHA class 2 and 3, ACE inhibitors or ARBs or in NYHA class 2 to 4. Basically, so ARNIs, ACE inhibitors or ARBs, beta blockers, MRAs, SGLT2 inhibitors, and diuretics when the high level of congestion or edema is there, basically in step 1, basically. So all these drugs should be considered basically when LVEF is less than 40% or persistent heart failure with reduced ejection fraction is there. But when you see that LVEF is more than 40 or more than 50%, then you should actually treat the patient. You should actually customize the treatment as per the patient's requirement. All these things actually come step 3, step 4, step by step 6. I would actually, it would be very lengthy if I would discuss all those things. But 4 class of drugs: ARNIs, ACE inhibitors, ARBs, MRAs, SGLT2 inhibitors, and beta blockers are the backbone for the treatment of heart failure. And all these drugs should actually be used when you see a patient with LVEF of less than 40% or class 3, class 4 NYHA. Value statement for a device therapy. I've discussed with you the device therapy. A transvenous ICD provides high economic value in the primary prevention of sudden cardiac death. Sudden cardiac death is what we are concerned basically. So a transvenous ICD is actually beneficial and provides high economic value, particularly when the patient risk of death caused by ventricular arrhythmia is deemed high and the risk of non-arrhythmic death, either cardiac or non-cardiac, is deemed low based on the patient's burden of comorbidities and functional status. Now, for patients who have LVE of less than 35%, sinus rhythm, left bundle branch block with a QRS duration of more than 150 milliseconds, and NYHA class 2, 3 or ambulatory IV symptoms on GDMT, CRT implantation provides high economic value. Or these are being recommended as a class 2A method of treatment. Now, few additional medical therapies. After the 4 classes of drugs, 4 basic pillars for the management of heart failure, basically. Ivabradine has actually class 2A recommendations in patients with LVF less than 35% with NYHA class 2 and 3. Basically, ivabradine could be of very beneficial use. All other drugs like digoxin or vericiguat, UFA or potassium binders has class 2B recommendation, basically because they are associated with a lot of additional side effects, or we can say additional risk factors are involved in prescribing these drugs. So, but basically ivabradine actually could be given easily and safely. Additional medical therapies after the treatment of heart failure. Basically, I would not discuss all these things. Okay, now recommendations for patients with mildly reduced left ventricular ejection fraction, basically, or moderately reduced ejection fraction. Now, patient is a symptomatic heart failure with LVF varying between 41 to 49%. Diuretics, as needed, has a class 1 recommendation. SGLT2 inhibitors, certainly class 2 recommendations. ACE inhibitors, ARBs, ARNIs, MRAs, and evidence-based beta blockers are actually have put in a class 2B recommendation. That means they have been put in a negatively impacted class. But mildly reduced left ventricular ejection fraction, 2 class of drugs, SGLT2 inhibitors and diuretics, could be easily be given and have shown a beneficial effects for the treatment of heart failure. So in patient with heart failure with preserved ejection fraction, after a treatment, GDMT should be continued to prevent relapse of heart failure and LV dysfunction, even in patients who may become asymptomatic. The treatment should be continued for a longer period of time or even lifelong. Now, recommendation for patient with preserved ejection fraction, certainly same as mildly reduced ejection fraction or mildly preserved ejection fraction, diuretics as needed, and SGLT2 inhibitors should be given. Other drugs like ARNI, MRAs, and ARBs have been in a class 2B recommendation. Now, few non-pharmacological management in advanced heart failure, certainly, basically no meta-analysis. Basically, these meta-analyses were done, but they have not shown to be beneficial. Meta-analysis of 6 randomized controlled trials comparing liver and restricted fluid intake, basically no difference in mortality or heart failure hospitalization has been seen. No difference in serum sodium or creatinine level has been seen, and no difference in duration of IV diuretics has been seen. So basically, it is in class of recommendation class 2B recommended. That means should be avoided. Something about inotropic support, basically,
I think
improving
time is moving fast. Please, little bit.
Just I'll be completing. Okay, finish. I will be quick. So recommendations for managing comorbidities in patients with heart failure, certainly comorbidities, management of anemia or iron deficiency, class 2A, but there is also harm in patients with heart failure and anemia. Erythropoietin stimulating agents should not be used to improve morbidity and mortality. That is the most important concerning point. Now, management of hypertension, all patients should be managed aggressively. The blood pressure control should be there. Class 1 recommended. Management of sleep disorders, basically class 2A recommended. I've already discussed with you, but also has few harm in patient with NYHA class 2 to 4 with reduced ejection fraction and central sleep apnea. Adaptive servoventilation causes harm. Basically, should not be considered. And management of diabetes, class 1 recommended. Optimal diabetic control should actually be there. And the use of SGLT2 inhibitors is strongly recommended for the treatment of those patients who has type 2 diabetes. So the goals of care for all patients with heart failure, palliative and supportive care, including high quality communication, conveyance of prognosis, and clarifying goals of care, decision-making, symptom management, and caregiver support should be provided to improve quality of life and relieve suffering. And for patients with heart failure being considered for or treated with life-extending therapies, the option for discontinuation should be anticipated and discussed through the continuum of care, including at the time of initiation, and reassessed with changing medical conditions and shifting goals of care. Basically, I'll only read class 1 recommendation where it is highly recommended. So thank you. I'll be quick. Stop share. Yeah.
Yeah. So Dr. Abhishek, that was a very extensive and elaborate discussion on
detailed discussion
heart failure.
of
So you almost taught us
Sorry
how to treat.
for being so. I hope I'm not boring.
You taught us how to become cardiologists now.
Yes. Like,
and
it's
also
a thorough and detailed discussion, I think. So I think, and apart from just the medication, what other parameters said, like salt restriction and correction of anemia, that were also very important part. Most of the time we neglect. So I think the session is now. We should conclude the session, and thank you, Dr. Arvinda, for this nice conference. But everyone, as per everyone request, I think next year it will be physical only.
Yes, definitely it will be physical. We want to be physical because otherwise virtual is nothing. Hopefully the things are settled next year. I hope so. So when things are settled, we can definitely do it. Thanks, Dr. Karthik Munichudappa, Dr. Amitesh Agarwal, Dr. Rajesh, Dr. Abhishek Srivatsav, Dr. Supratik for valuable deliberation and being a part of our conference. Thank you so much.
Thank you. Thank you, Arvind. Thanks a lot.
Thank you, Arvind, for having us here.
Thank you.
Thank you so much.
Over to Dr. Shweta.
Yes, sir. Thank you, sir. So let's start our session 6. I would like to introduce Chairperson, Dr. Babu Rajendra Naik, MBBS MD, Diploma Diabetology, Master's Diabetology, FIAMS, CMD, Chief Diabetologist at Sri Tulsi Girish Diabetes Hospital, Vijaypur, Bagalkot, Goa. And I would like to introduce the another chairperson, Dr. Surjit Kumar Patra, MBBS MD, FDIAB, Fellowship in Diabetes, Director and Consultant Diabetologist, Dr. Surjit Patra Diabetes Clinic, Bhubaneswar. Thank you, sir. Over to you. Over to the chairperson to.
Thank you, Dr. Arvind, for giving us an opportunity to be the the part of this academic extravaganza. Till now, all the sessions have been running in a very meticulous way. Let me congratulate all the team at the outset. And as a part of my job, let me introduce today's speaker, Dr. Bala Murugan. He has been a consultant diabetes for the past 2 decades and is now a chief diabetologist. He started the COVID Diabetes Specialty Center or hospital in 1995, and today it is a full-fledged diabetes specialty, giving total care under one roof. Sir has conducted more than 1,000 diabetes patient awareness programs, more than 500 CMEs, giving lectures to medical professionals, and he has been a principal investigator in more than 15 phase 3 and 50 phase 4 clinical trials. In 2015, he conducted a Cupid in which 50 resource persons from all over the country participated along the 500 delegates, and it's been continuing every year. Over to Dr. Bala, sir, and kindly give us some insights about the GLP.
Yeah, thank you, Chair. As well as on the outset, I'd like to thank Dr. Aravinda for this opportunity, as well as the Novo Nordisk to take part with you in this wonderful meeting so far. And I'll try to share my slides now.
Talk on secondary driver of diabetes, renal disease, and cardiovascular disease.
On this one. Can you share the slide for me, RX events?
Yes,
sir. Not. Can you just share the slides?
Yes, sir.
Yeah, please. Yeah, good evening. And the scope of my talk is to address the syndemic of diabesity with the world's first peptide in a pill, the oral semaglutide. Can I have the next slide? Can I have the control of the slides? Yeah. I'm done. Moving? Moving? Hold on. Is it okay? Not moving. Moving. Is it moving now? Not moving. Oh, go back. Can we go back? I think, Let me just try to move this. Not moving. Go back. Yeah, next. Yeah, we'll start with the purpose of the GLP-1 in the body. When the glucagon-like polypeptide is an endogenous incretin hormone secreted in the gut in response to food intake. You take food and the carbohydrate gets converted into glucose. The native GLP-1 is secreted from the gut. Whether you give the native GLP-1 or GLP-1 receptor agonist, how does it function? And it acts on the pancreas to increase the insulin secretion as well as to decrease the glucagon secretion. On the other hand, it acts on the liver to reduce the hepatic glucose production, and in the stomach, it delays the gastric emptying, and it acts on the brain hypothalamic center to increase the satiety as well as decrease the food intake, and
effects on the heart also. It has got a beneficial effects on the cardiovascular system. So the GLP-1 receptor agonists are the glucose-lowering drugs that stimulate the GLP-1 receptors and increase the insulin secretion in a glucose-dependent manner. Can you have the next slide? Go back. Yeah. So when you find the GLP-1 receptor agonist, when you try to compare the various oral drugs and insulin, the GLP-1 receptor agonist, you can see it's clearly obvious in terms of when you look at the physiological action, when you look at the glucose control, the A1C is very much better. The efficacy is definitely high, and even only just inferior to insulin. On the other hand, if you look at the hypoglycemic risk and weight reduction, and it has got a favorable benefit. When you look at all the other drugs, the GLP-1 receptor agonist, efficacy-wise is fine, and less hypoglycemia and less weight gain. They have got a beneficial effect on the weight loss and as well as the cardiovascular benefits. Next slide. Next. So the cardiometabolic benefits of the GLP-1 receptor agonist, you can understand that it's got a multitude of pharmacological effects and cardiovascular benefits. So different action, again, looking at the pancreas, improving the beta cell function, increase the insulin biosynthesis, and increase the glucose-dependent insulin secretion. On the other hand, decreasing the glucose-dependent glucagon secretion. On the other hand, if you look at the heart, there's a reduction in the cardiovascular risk, decreased fatty acid metabolism, increased cardiac function, improved cardiac function, and decreased systolic blood pressure and reduction in inflammation. On the other hand, acting on the brain reduces the body weight, reduction in the food intake, as well as improving the satiety. As well as we already discussed, the stomach lymphosis, it delays the gastric emptying or slows down the gastric emptying, and acting at the kidneys, increase the natriuresis and decrease the risk of worsening of kidney function, and the liver, reduction in the endogenous glucose production, increase hepatic insulin sensitivity is a very, very important factor, as well as decrease de novo lipogenesis, decrease lipotoxicity, and decrease steatosis. So when you look at the meta-analysis of the trials of the GLP-1 receptor agonists, including the semaglutide in type 2 diabetes, we have learned that there is a reduction in the risk of major adverse cardiovascular events, decrease the risk of myocardial infarction, decrease the risk of stroke, decrease the risk of death from cardiovascular causes, decrease the risk of hospitalization due to heart failure, as well as a reduction in the risk of adverse kidney outcomes. Next slide. So what is the European Society of Cardiology giving the guidelines for diabetes, pre-diabetes, and cardiovascular disease therapy for type 2 diabetic patient who already metformin? So it says that whenever there is an ASCVD or a very high risk cardiovascular risk, target organ damage, or multiple risk factors, the SGLT2 or GLP-1 receptor monotherapy to be considered. The A1C is above target. Even a patient on metformin, if the ANC above target, they're also GLP-1 and receptor agonists as well as the GLT2 when the GFR is adequate. Next slide. So the GLP-1 receptor agonists or SGLT2s are recommended in patients on metformin with ASCVD or very high cardiovascular risk, irrespective of HbA1c. It's very, very important. And you can see left hand side, you can see that it's coming even ahead of the metformin also. Next slide. Again, the ADA 2022 standard of care is also endorsed whenever the pharmacological treatment of hyperglycemia, there is the first. Can I have the next slide? So you can see the first line therapy depends on the comorbidities, patient-centered factors, including cost and access consideration. Management name generally includes metformin and comprehensive lifestyle. On the other hand, the ASCVD indications of high risk of heart failure, here the recommendation is independently of the baseline A1C, the individualized A1C target on metformin use. You can see the ASCVD are indicated as high risk. The GLP-1 receptor agonists are predominantly used. On the other hand, whenever there is a compelling indication to minimize the hypoglycemia, there is also the GLP-1 receptor agonist come. Again, there's a minimizing weight gain. They're also and promoting the weight loss. The GLP-1 receptor agonists are ahead in the list. Next slide. So the recommendation from ESC, ADA endorsed it. And what are we coming to the main? The oral semaglutide, a game changer. Not only a game changer, a life changer. Next slide. And you see the foundation stone for the oral GLP-1 receptor agonist semaglutide. How it was made possible. There are three things they were done. One, there's an amino acid substitution at position 8 protects against the DPP4 mediated. The C18 fatty diacid phase addition of this one slows degradation of and reduces the renal clearance and prolongs the half-life. And you see that addition of the amino acid substitution at position 34 prevents C18 fatty acid binding at wrong side. You can understand that the semaglutide has 94% homology with the human GLP-1. Next slide. Next slide. I'm just going to tell about how this is very, very important thing. Everyone should know that how oral semaglutide should be administered. The dosing instructions are designed to optimize absorption and be simple for patients. Take when you wake on empty stomach, wake up and take your semaglutide tablet straight away with the half a glass of water, max to max 120 ml. Then wait at least 30 minutes before eating, drinking, or taking any other oral medication. It's very, very important, simple. Next slide. When you start on always when you start on the treatment, it's the 3, 7, and 14. Just start with the 3 milligram start with, then for a month. Then if the patient tolerates, switch on to 7 milligram. Then increase to 14 milligram if the further glycemic control is needed. Next slide. This is how the dose escalation has to be done. How to start and how to take. Next slide. And the clinical efficacy saga of the oral semaglutide, we learned from what is called as pioneer trials, the peptide innovation for early diabetes treatment. Next slide. So this is again overview of the pioneer program. We have a number of trials starting pioneer 1 to 10. The pioneer 1 versus a placebo with the diet and exercise, and the 2, 3, 4, pioneer 2 with versus SGLT2. Again 3 versus DPP4. And the pioneer 4 was the GLP-1 receptor agonist and placebo. And you can see the 5 and 6 with a special population with renal impairment, as well as the 6 with the cardiovascular safety. In fact, the pioneer 6 had 2001 Indian subjects, and the pioneer 7 was one with the flexible dose adjustments versus DPP4 inhibitor with the extension. And pioneer 8, there's an add-on to insulin, and in which almost 51 Indian subjects were involved. And again, there were special trials in the special population Japanese, pioneer 9 and 10, versus GLP-1 receptor agonist, as well as with the GLP-1 receptor agonist, one OAD, sulfonylurea and thiazole, and other OADs. This is the overview of the pioneer programs. Next slide. And see, what are the results of the pioneer programs here? Pioneer 1 to 5 and 7, 8. Okay. You look at the change in HbA1c and body weight. First slide shows that change in A1c. Looking at the pioneer 1, 2, 3, 4, 5, 7, and 8, by and large, you can see the semaglutide 14 milligram shown approximately around 1 to 1.5% reduction in the A1C. On the other hand, if you look at the body weight also at the various pioneer program, they range between around 3.5 to 5 kilograms. So the oral semaglutide reduced A1C in a clinically relevant and dose-dependent manner. These reductions were up to 1.5% and sustained weight loss up to 5 kgs. This is a very, very important point. 1.5% reduction in A1C and 5 kgs weight loss. Next slide. So the efficacy of oral semaglutide according to the baseline A1C, you don't understand. Whenever the A1C is very high, any diabetic drug is going to act in a better manner. So the oral semaglutide, when you look at the A1C, different A1C levels, more than 9% is very, very significant. You can see around 2 to 2.6%. The up to 2.6% reduction in the A1C in different pioneer trial programs, whenever the A1C is more than 9%. Next slide. So semaglutide reduction on the body weight, none other obesity in patients with the type 2 diabetes is associated with higher cardiovascular risk. Compared with people without obesity, those with obesity and type 2 diabetes have an increased risk of stroke 33% and 49% increase in coronary heart disease, as well as 71% in all-cause mortality. 90% of the people with type 2 diabetes are almost obese or overweight. Next slide. Next slide, please. Yeah. So the proportion of the patients achieving the body weight loss of more than 5%, you can see almost across the Pioneer 1 to Pioneer 8 program, almost you can see around 40 to 50% of the people with the semaglutide in the various studies, almost a significantly greater number of patients achieved weight loss more than 5% with oral semaglutide 14 milligram compared to placebo and compared to. It's very, very interesting. Next slide. Again, this is what I said. 1 in 2 patients achieved more than 5% weight loss, and the reduction is up to 5 kg across the clinical trials. Next slide. So we saw about A1C, we saw about the weight loss, and this again looking at the oral semaglutide reduces the waist circumferences approximately around 4 to 4.6 centimeters. It's also quite convincing. Next slide. So again, looking at the blood pressure, we saw A1C, we saw the weight, we saw now we are waist circumference. Now coming to the blood pressure, almost the people with the hypertension and people with diabetes, so the increased risk of cardiovascular complication, and definitely we'll all understand that whenever there is a decrease in systolic blood pressure of 5 millimeter, they can cause reduction 13% of stroke, 7% IHP, 14% heart failure, and 5% death related to diabetes. So when you reduce the blood pressure, definitely it improves the cardiovascular outcome. Next slide. So the oral semaglutide reduces systolic blood pressure and almost up to 1 to 6 millimeters in various clinical trials. This can have the following benefits in terms of complicated related to death and deaths related to diabetes and reduction in MI as well as microvascular complications. Next slide. Again, looking at the blood profile, also lipid profile, there's a dyslipidemia, again causes more cardiovascular complication and almost history of CVD, 6 times more likely to patients with people with diabetes and hypertension and dyslipidemia versus type 2 diabetes alone. And almost 97% of the people with diabetes have dyslipidemia. In people with type 2 diabetes, dyslipidemia versus without, the risk of cardiovascular events increases in people with the dyslipidemia. Next slide. Again, looking at the LDL cholesterol and triglyceride, also there is a reduction in both LDL cholesterol as well as triglyceride. Now we are looking in the recent research also, we are looking in the triglyceride, an additional risk factor. Whenever the LDL cholesterol is controlled, we need to take care of the triglyceride also to address the residual risk in terms of cardiovascular events. Next slide. And again, looking at the inflammation, today we're talking about the inflammation. Diabetes is an inflammatory disease as well as cardiovascular disease as an inflammatory disease. The GLP-1 receptor agonists reduce the coronary artery inflammation and reduce the oxidative stress and a reduction in the damage to the arterial walls and drives, and which are the drivers of the atherosclerosis. Next slide. Looking at the hsCRP levels, there is a oral semaglutide, both 7 and 14 in various trials have shown that the reduction in almost 25 to 35 milligrams of the 35 to 35 hsCRP and the high sensitivity CRP levels, which are the independent risk factor for cardiovascular disease from the baseline. Next slide. Again, I said about the various CVOTs, the semaglutide, that's increase the number of free years of the new recurrent major cardiovascular event in people with type 2 diabetes, high cardiovascular risk. Almost the reduction is mean absolute risk by 6%, and the dial model is extremely validated, compelling risk-adjusted model for lifetime predictions. So there is an increase in the mean of almost 1.7 cardiovascular disease-free life years with some oral semaglutide. Next slide. Again, the oral semaglutide results, you can look into various cardiovascular outcome trials. Almost the times for the first occurrence of the CV death, non-fatal MI or non-fatal stroke, the hazard ratio is 0.79. It means there is a reduction in 21%, even though p-value was not significant. And there is definitely a significant MACE reduction in this group. Almost 21% non-significant reduction versus placebo. We look at the Pioneer 6 overall summary, it has achieved a 21% non-significant reduction of the cardiovascular events. Next slide. When you combine the Pioneer 6 and Pioneer Sustain 6, if you can combine and see, and both the trials have showed that almost they have got a similar criteria for enrollment, and only the duration of the trial and number of events were different. Almost we can Sustain 6. It is almost time and duration driven. Here mainly looking at the events driven trial, and the number almost the treatment was 104 weeks. Here almost they looked at the 122 events here in Pioneer 6. They tried to come back. The numbers were also similar. And what was the results of these two? The 26% reduced risk of MACE in Sustain 6 compared to 21% reduction in the risk in the the pioneer 6. Okay, next slide. Almost, the look at the cumulative incidence of stroke over time. It is almost risk reduction by 32% with oral semaglutide compared to the placebo. Next slide. And when you combine the Pioneer 6 and Sustain 6, the pooled analysis, we look at the EGFR fall. There also you can see find the overall the EGFR reduction was not almost significant. It has reduced the EGFR reduction. The renal functions were by and large preserved, and the combined Sustain 6 and Pioneer 6 showed there is a slowdown of the reduction in the EGFR compared to the placebo. Next slide. It is done with the various EGFR 30 to 60 and less than 60 EGFR. Look at the Pioneer summary, a trial of the Pioneer summaries. The A1C, the oral semaglutide superior versus EMFA, sitagliptin and liraglutide. The weight almost superior with weight reduction superior with liraglutide, sitagliptin and EMFA. And the cardiovascular safety significant confirmed for oral semaglutide in Pioneer 6, showing a 21% non-significant reduction in MACE in favor of oral semaglutide compared with the placebo. Overall, the oral semaglutide was well tolerated with a safety profile consistent with the GLP-1 receptor agonist class. The most common adverse events, we all know that mild to moderate nausea. So the efficacy was established and given early in the therapy as well as late in therapy and regardless of the renal or hepatic impairment. And use the patient with severe hepatic impairment, we should be cautious to use this. Next slide. And addressing the cardiovascular risk factor, how does this oral semaglutide address? One by reduction A1C by 1.5% at most, reduction in the body weight by up to 5 kilos, and reduction in the systolic blood pressure to max 6 millimeters, and reduction in LDL triglyceride and total cholesterol, and also reducing the waist circumference. Next slide. Summarize, the GLP-1 receptor agonists are among the most effective. Can you put the next slide also? The GLP-1 receptor agonists are among most effective medication for type 2 diabetes. They have been shown to reduce A1C, body weight, composite outcomes, and even pill burden. The oral semaglutide is a scientific breakthrough in innovation to bring efficacy of GLP-1 receptor agonists in a convenient oral formulation. Across global pioneer trials, oral semaglutide proven its efficacy and achieved A1C reduction up to 1.5% and weight reduction up to 5 kgs. The oral semaglutide has been found to reduce A1C more than HGLD and DPP-4 when added to one oral drugs, reduce the A1C when added to insulin therapy. Again, the oral semaglutide resulted in A1C of almost 2.6%. The oral semaglutide has proven cardiovascular safety in Pioneer 6 with a strong potential for CV death reduction, all-cause death reduction, and a larger SOUL trial to evaluate the long-term cardiovascular benefit of oral semaglutide is ongoing. You can expect the results. The efficacy of oral semaglutide was established when given early in therapy, late in therapy, and regardless of renal or hepatic impairment. Next slide. So I'll stop here. Thank you once again, Dr. Aravinda and the chair and the NOVA for the opportunity. And I can take up the questions also now.
Thank you, Dr. Balamurugan sir, for your nice and comprehensive coverage of every aspect of oral semaglutide. Okay. For the benefit of our audience or for the benefit of our delegates, the questions we will take now or we will take at the end. Dr. Aravinda sir, shall we take at the end?
Possible? Can we do it now?
Sir, Arvind sir is in the another all.
Okay.
Yeah, you can take up the question now.
Okay, so we can take one or two quick questions on semaglutide now. Okay. So, Dr. Balamurugan sir, for the benefit of our audience, or benefit of our delegates who are listening to this session throughout India and outside also. For example, in a type 2 diabetes patient, we are prescribing this oral semaglutide. So this should be early morning empty stomach with half glass of water. But for example, if the person is also having comorbidity of hypothyroidism and we are prescribing levothyroxine, so what should be the approach or what should be the process to follow where we both this oral semaglutide and oral levothyroxine both should be given early morning empty stomach. So what should be the sequence and how to approach this situation?
Yeah, if at all, there should be otherwise, we can take the thyroxine in the morning and you can give a long gap, at least 4 to 6 hours of gap before the meal. and you can give your the oral semaglutide again given like that. Yeah, the idea is when it's an empty stomach with a limited quantity of water, it facilitates the absorption, the maximum absorption data are there. You may want to give in both, preferably not to combine both and give, and preferably try to give a gap of 4 to 6 hours.
Okay, okay. Thank you, Dr. Balamurugan sir. Now we will come to the next session. Okay, and this session is on the science behind obesity. And for this, we have our eminent speaker, Dr. Rajiv Kovil. Dr. Rajiv Kovil, medical director and consultant diabetologist of Dr. Kovil's.
Shurjit, let's start.
Yes, yes. Dr. Rajiv Kovil doesn't need any introduction. We all know him. So directly, let's go to the session, the science behind obesity. Over to you, Dr. Rajiv Kovil.
Can I get this screen sharing rights, please?
You can share from your laptop.
I know, but
yeah,
you are sharing. Thank you so much. So thank you, Arvinda. Thank you so much. He's our Talaiva. So a good topic from him, and would like to thank also Novo Nordisk for bringing me here. So I'm going to talk a little bit about science behind obesity, and it's quite a tough topic to actually speak. Next slide, please. Yeah, so again, thank you, Novo Nordisk, for funding this talk. Next slide, please. So if you look at the overview of weight regulation, this is the overview of my agenda. We're going to speak about physiology of weight regulation, which is what we need to know, etiopathogenesis of obesity, benefits of weight loss, and the concept of weight regain. Next slide, please. So if you look at energy balance equation, we need to closely kind of balance both these things, our intake and expenditure. Our intake is obviously surrounded by our hunger, satiety, a lot of external factors, circumstances, emotions, and nutrient absorption, while expenditure looks at metabolic rate, thermogenesis, exercise, and again, need as well. Next slide. Now, body weight is determined by the balance between food, energy intake, and also your basal or your resting metabolic rate, which is the energy expenditure. And this is what we need to balance over a period of time in order to prevent obesity. Next slide. So energy balance is the energy intake minus energy expenditure. Next slide. Next slide. So so you need to balance all these. No, go back, please. Yeah. You need to balance food, that is your energy intake, with your energy expenditure. Now, what is basal metabolic rate? Refers to the rate required to sustain all essential physiological processes. If you look at diet-induced thermogenesis, it refers to the heat production in response to food. And example, an amount of energy required for the digestion, absorption, and transport and storage of ingested nutrients. When we look at non-exercise activity thermogenesis, refers to what I'm doing right now, which I'm just sitting around, fidgeting, even unconscious movements like moving your legs, moving your hands, posture, balance, all that come into NEAT. Exercise-induced thermogenesis includes exercise, what we do as a structured action or a bus. Also doing household chores and commuting are considered as exercise-induced thermogenesis. So both these, if it gets balanced, you're not going to put on weight. Next slide, please. And a lot of, as we have in diabetes, that multiple hormones act on multiple glands to involved in our glucose homeostasis. Similarly, in our weight regulation, a lot of hormones act peripherally as well as centrally. And they are very much involved in the appetite regulation. If you look, hypothalamus seems to be the kingpin, and we have peripheral, if I could say that these are peripheral areas or peripheral of the center, which is the hypothalamus, and these are people on the ground, and the kingpin being the brain and the hypothalamus. Peripheral, you have the gastrointestinal tract, you have the beta cells of the pancreas, you have adipocytes, we have visceral adipocytes, and you have ectopic fat deposition across in our body. We now know that 1 gram of extra fat or 1 gram of fat in the liver, in the pancreas is enough to reduce the compensatory hypersecretion of insulin and progress towards diabetes. Similarly, there are a lot of functional tissues in our portal vasculature as well. So all these include our peripheral areas, which is connected to our central, which is hypothalamus. So a lot of signalings come from our peripheral and as well as from the center. So endocrine hormones as well as a lot of neural pathways are there in appetite regulation. And leptin, since its discovery, we have realized that leptin is a very important adipokine. It's made from the adipocyte, and it controls a lot of our behavior. And you would be surprised that most of the people who have excess BMI or are overweight have some form of leptin resistance. So as insulin resistance seems to be the pathophysiological core defect in people with overweight type 2 diabetes, leptin resistance seems to be a core defect in many people with obesity as well. Next slide, please. So as I was saying, keep clicking. A lot of peripheral signals modulate energy expenditure via the hypothalamus and via also by the hindbrain. As you can see, the brainstem areas are also there. Now, it's important to realize that these peptides in our GI systems, which could be PYY, GLP-1, oxyntomodulin, ghrelin, they give a lot of feedback to our arcuate nucleus, which is in the hypothalamus. And this has a lot of second order neurons, which actually stimulated by certain neuropeptides as well as hunger and appetite stimulating modulators. And these are for satiety or hunger. And the hunger signals, as you can see, are in green, and the other, the satiety signals are in pink, as you can see. So there is a complete, so the hypothalamus gets central as well as peripheral stimuli. The peripheral comes from the gut, comes from the beta cells of the pancreas, comes from the portal circulation, and so it could be related to the nutrient ingestion. It could be related to the nutrient store one has in adipocytes, and it also gets stimulation from the neural pathway, and the hindbrain also gets stimulus from the neural pathway. So the hypothalamus needs to then kind of integrate endocrine as well as peripheral hormonal as well as neural pathway to then come to a balance that what is required for the person. And this is something which gets altered either genetically, environmentally, emotionally, which leads to obesity. Next slide, please. Next slide, yeah. So I've always believed, and it's thanks to this particular topic, that the brain has a huge role in controlling appetite. As you can see, homeostatic eating means eating for hunger. Please click again, please. Next slide. So GLP, you have hedonic eating, which is for eating for pleasure. Next slide. And the dopamine controls wanting, opioid and cannabinoid receptors control liking, and the pleasure associated with food. Next slide. And executive functions, there's sets deciding to eat. This is a behavioral therapy. So you have eating for hunger, which is the basic need. You have eating for pleasure, which is the hedonic, called as hedonic eating. And executive function, deciding to eat. Those are our thoughts, feelings, behavior, which is probably related to past behavior, circumstances, emotions, so many other things. This is where behavioral therapy comes in terms of executing the function. Next slide, please. If you look, let's look at the etiopathogenesis of obesity. Next slide. Next slide. So as I said that there needs to be a complete balance between energy intake and energy expenditure. We have fat depots which are created in our adipose tissue. Our pancreatic beta cells plays a huge role in that. Gut, along with the gut-derived hormones, genetics, and certain medications, they all need to act on the arcuate nucleus and the hindbrain of the brain to control this homeostasis or this metabolic homeostasis. Next slide. And next slide. So inherent factors predisposing to obesity, we have a lot of genetic genes in the hypothalamus, leptin, melanocortin pathways. You have a lot of single nucleotide polymorphism predisposing to obesity. And there's a very high heritability of body weight. Next slide, please. There are more than 300 SNPs and more than 250 loci are associated with obesity traits. Next slide, please. CNS expression, hypothalamic control of energy intake, you have 97 loci regulating total BMI. Next slide. Genes for fat distribution, 41 loci for waist-hip ratio. So the distribution of fat is something which is controlled by the hypothalamus. A lot of studies of late have looked at insulin resistance and how that contributes to an autonomic dysfunction, which leads to abnormal distribution of fat, and that leads to visceral obesity. So probably the brain insulin resistance comes very, very early, and that's why the hypothesis of Dr. Yagnik's, where maternal nutrition needs to be very, very good, because brain insulin resistance, many of our kids are born with. Next slide, please. So more than 100 genes and genetic loci are associated with obesity, and genes associated with BMI are enriched for the expression in the brain as well as in the central nervous system, as you can see. Next slide, please. A lot of environmental factors, which we obviously socio-cultural factors govern India. We have 365 festivals per year, tradition, beliefs, peer pressure, socio-economic, food environment, available of inexpensive, highly palatable food over the last 3 to 4 decades has also contributed a lot. Next slide, please. So obesity, we know that it drives a lot of non-communicable disorders, whether it's cardiovascular disease, asthma, non-alcoholic fatty liver disease, which is probably the harbinger of metabolic syndrome, and probably type 2 diabetes starts with or pre-diabetes starts with non-alcoholic fatty liver disease, and a lot of adipokines has been kind of incriminated in it. We know that adiponectin helps in NAFLD. Resistin works against NAFLD. A newer adipokine like Vistafin has been seen that which can probably help obesity and better disposition of glucose and reduce NAFLD. But the hepatokine Phetuin A has been described as one agent which kind of does a lot of crosstalk between organs, especially crosstalk between fat depots in various organs. So whether it's a fatty kidney, fatty pancreas, or the perivascular adipose tissue, and contributes to the beta cell failure and also to obesity as such. Apart from these problems, gallstones, infertility, cancers, obstructive sleep apneas, thrombosis, gout, a lot of complications are related to obesity. The American Medical Association has termed obesity as a disorder. We are working on a white paper to recognize obesity as a disease and disorder in India as well. Next slide, please. Next slide. So let's look at the benefit of weight loss and the concept of weight regain. Next slide. So obviously we know that weight loss can improve a lot of these non-communicable parameters across, and it could be one-stop solution to everything. The newer ADA ESD consensus, which came out at the ASD this year, 2 days back, also speaks about obesity and weight loss in a much more affirmative way than it has ever spoken. And the guidelines today tell us that 5 to 10% weight loss is something that we should chase in our people with type 2 diabetes, apart from the HbA1c target of below 7%. Next slide, please. So greater weight loss further improves obesity-related complications. As you can see, that 3 to 10% can help us in preventing diabetes. 10 to 15% from Roy Taylor's data and further data tells us can help us in remitting diabetes. You can see that a lot of non-communicable disorders, whether it's osteoarthritis, GERD, PCOS, sleep apnea, hypertension, dyslipidemia, can all come to a decent remission with 10% to 15% of weight loss. So weight seems to be the driving factor of many of these non-communicable disorders, including cancer. Next slide, please. So maintenance of weight loss has always been challenging, and this data looks at multiple ways of weight loss, and even we know that even weight loss through the knife also has been challenging. There is difficulty in maintaining weight loss, and remission in weight loss following surgeries are also very, very high. And here you can see that majority of the time the weight comes up to where it was in the next 3 to 4, 5 years after the active treatment has been stopped. Next slide. The physiological changes after diet-induced weight loss, very provocative statement I had read while I was reading the Surmount study, where we all know that it was 22% weight loss with in overweight people, and in 95% remission in people with pre-diabetes. But weight loss after a period of time or after the active treatment has been stopped, there seems to be some kind of compensatory mechanism which comes into place, and that's what we are talking about. And there's a plateauing of weight loss, and in future one will not be surprised to see that many often that you may require pharmacotherapy for just maintenance of weight loss. And you can see there are a lot of physiological changes after diet-induced weight loss. We have reduced energy expenditure, reduced fat oxidation, reduced thyroid hormones, increased cortisol. And the expected effect is increased energy storage. You also have some amount of altered neural activation and an increase in GIP and a reduction in leptin, and an increase in ghrelin. And ghrelin we know is a hunger hormone, and an increase in food intake. Next slide, please. So there are a lot of metabolic adaptations that resist weight loss. These are changes in hormone levels, reduce satiety hormones, increase hunger hormones, and reduce energy expenditure, which again results in a lot of weight regain. There's a lot of compensatory mechanism which comes in after weight loss. Next slide, please. So this is the contestants from the Biggest Loser competition who lost close to almost 30 to 40% weight while being in the show for 30 weeks. They were into a study, and these were patients. These were people, volunteers who had previously participated in the Biggest Loser competition, and they were put on a 6-year to see how they do and how their resting energy expenditure is, how their metabolic adaptation calculated as the difference between the measured resting expenditure and the resting expenditure predicted from a linear regression analysis of baseline. Next slide. As you can see that at baseline, their body weight went down by 58 kilos, but at the end of 6 years, there was a 41 kilo weight regain. The resting metabolic rate did go down by 610 kilocalories per day. It remained like that, but the metabolic adaptation occurred, because of which they required more, they became more hungry. In spite of a lesser metabolic rate, the metabolic adaptation occurred and they continued to remain more hungry. And that is why there was a rebound weight gain. Next slide, please. So in summary, I would say that energy balance is regulated by the brain through various sources of input. Maintenance of weight loss is challenging due to the metabolic adaptations. A lot of adaptations that resist weight loss, changes in hormone levels and metabolism. The brain controls the appetite by regulating three types of eating: homeostatic, hedonic eating, which is usually related to past behavior, and executive function, which can be kind of tweaked by behavioral therapy. In short 15 minutes, I hope I have done justice to this topic. I hand it back to Dr. Patra to take it forward. Thank you so much, Dr. Patra and Dr. Arvind.
Thank you. Thank you, Dr. Rajiv, for your comprehensive coverage on this aspect of obesity. So one important point you mentioned about the leptin resistance, and that is one of the key things. So insulin resistance in type 2, which what you mentioned, leptin resistance in obesity. So kindly throw some light on this aspect, whether any pharmacotherapy or any method to reduce that leptin resistance to get benefit on obesity.
So a lot of pharmacotherapy has been there which looked at leptin, and the main therapy used to be sibutramine, also looked at how it could help in leptin resistance and improve leptin levels, and leptin is a satiety hormone, and it would reduce your appetite, and how it could be. And there have been a lot of ways that leptin analogs and all have been tried, but none to the benefit per se as such, So in spite of all this, we do not have weight loss therapy, and probably GLP-1s and GLP-1 analogs and probably twin GLP and GIP looks to be the future for obesity management as of now.
Thank you, Dr. Rajiv. So we will move to the next session.
Thank you so much.
BS MRCP UK, CCST Internal Medicine from London. He is consultant diabetologist and endocrinologist from Sri Ramakrishna Hospital, Coimbatore, and he is an honorary consultant in Derriford Hospital, Plymouth. He has a lot of affiliation and a lot of publications in national and international journals and in various position papers and publications. So over to you, Dr. Suresh, for your deliberation on assessment and diagnosis of obesity.
Good evening, everyone. Am I audible and visible?
Yes.
And can you let me to share the screen? I don't. You don't mind that I do that. Control of everything in life, but I think it'd be better that if I can control, that'll be wonderful. Thank you so much. Inhibitors, incretins, and SGLT2. So we know how the science has been evolving with each sort of, I wouldn't say molecule alone, but the science will evolve with the challenges currently. I mean, current challenges for a diabetic or a non-diabetic is the obesity. And my view is the obesity has to be dealt as a multidisciplinary team. Thank you, Novo, for sponsoring this. As I said, that I think it needs a lot of initiative to spread the science to the medical fraternity. Now, the objective of this talk, and we got a previous speaker speaking about obesity in a different context, with Rajiv speaking about more of the causes and other things, which is so exciting. And it's been there for a while, but it's just getting evolved now, and people are looking at it in a big way when these kind of molecules, GIP and GLP, are coming in a combination with subcutaneous, the injectable semaglutide with coming with weight loss, and gerelins are coming up, and few other things with tirzepatide and other things coming up. So it is a lot of excitement into the area. So now, how to diagnose obesity? Because we need to classify that way now with not only type 1 and type 2, but a lot of other ways to classify now. Like that, I think the obesity has to be classified to do some intervention and to identify who are the people that needs attention, if you like, and also moving forward with the therapeutic strategy. So with that, I think BMI is the short way that people do it, and for many, many years. And there are a lot of challenges to BMI. I'll come to that with one slide explaining everything. And then the Edmonton score I will discuss about, and then the practical case scenarios, if I may. So initiating obesity management with your patient, how do you do it? And what are the challenges? Now, you have to diagnose first, and then discuss the possibilities and avenues, not going straight to the treatment. Because yes, so I mean, I get you must get in your clinic as well. I get people saying that I don't want to lose weight, I want to look like what I am, and I want to be slightly plumpier, sort of thing. So you need to discuss to find out whether they got a mindset of losing weight, and then go for the treatment after that. That is the step, the major step. So we'll go for diagnosing. As I mentioned, BMI is the way that has been done, and we know all how to calculate weight by height, and it is an objective measure that can be used to diagnose obesity. It's an easy measure in the clinic so that we can see the difference. But the only challenge is that what you see as a BMI over the online and textbook along with BMI, because the waist circumference for a man and a woman more than 80 and 90, it's very, very simple to do it. This is the IDF criteria, and also you can do a body fat percentage. And there are a lot of other ways just to going into BMD screening and CT and other things when you go into the research way of doing it. So when it's underweight, the BMI should be less than 18.5, as I mentioned. For Asians, anything about 18 or 19 area territory is considering to be area where you need attention. So the normal weight is around 18 to 22 of BMI, and overweight is more than 23, and then we got a grading of obesity after that. So with only BMI, we cannot ignore obesity. If you go into the morbid and you got a normal body index, normal BMI, and normal weight for obesity, there is an emerging concept in Asian population where there is a normal weight obesity, which is the normal BMI, but there is a high fat percentage. So hope you understand, the weight of the patient is normal, the BMI is normal, but the fat percentage is high. That's an emerging concept in Asians. Sarcopenia, inflammation. We can get a thin Asians. Actually, I worked in East London, where the area where you can get a Caucasian coming with a severe high BMI, but they will be metabolically healthy. But on the other hand, there will be a thin Bangladeshi coming with a small tummy, where the insulin resistance is very high, and the HbA1c will be 13, and the patient has sarcopenia with the muscle loss, and is extremely, would have done 1 or 2 cardiac procedures already. So those are the people that is metabolically unhealthy but normal weight, and these we need to address. But at-risk patients are very, very clear cut. We know how to do classify them. So now going into the obesity mortality paradox. So obese BMI with metabolically unhealthy, no brainer. We got excess visceral fat, muscle loss, hyperinsulinemia, diabetes, and a whole lot of things like that. But when you have a normal BMI and metabolically unhealthy, you got a sarcopenia. We discussed sarcopenia recently in a big way. That reduced fitness, insulin resistance, and diabetes and inflammation will be there. But when you get a normal BMI and metabolically healthy individual, you will have the muscle strength will be extremely good. But on the other hand, with the obese BMI with metabolically healthy, you got a visceral fat, increased muscle, but increased fitness, and the patient can be extremely fit. So these are the things that I was mentioning early when I started my lecture. What are the challenges with the BMI assessment? It doesn't measure the total body fat. It does not assess the present concomitant comorbid condition. So you can just only say yes or no, but you can't go into the details of the patient, like the changes in BMI or waist circumference doesn't need to reflect the overall health. If the BMI is improving, doesn't mean that everything is improving. But BMI alone is a very, very insufficient guide to make a clinical decision. But the evidence suggesting that the several factors, including cardiorespiratory fitness, may be substantially modify the mortality risk with the higher BMI. So that's all the area that we should think, rather than just going blindly with the BMI. We need to move away or move along with BMI for the right assessment. You go into UpToDate or any other area where you can see there is quite a lot of obesity classification but complementing BMI with a simple disease-related functional, it definitely will improve the therapeutic intervention, and also places in Europe, another area where the government holds all the therapeutic interventions. We need to classify them and then see who are the eligible people, and we can do same in India, but India, it has to come from patient's pocket. So we can provide the classification, but at the end of the day, patient has to offer. So this is the Edmonton classification I was mentioning: stage 0, stage 1, stage 2, stage 3, and stage 4. Stage 4 is an end stage, almost completely gone sort of area where the medical, mental, and functional aspects are all completely affected. But stage 0 is where everything is being normal, and in between we got a preclinical comorbid and end organ damage. So if you can remember this vaguely, and then we can come to the functional aspect and the way practically, pragmatically, how you can move forward. But what is the use of EOSS? As I mentioned, there are plenty of classifications available, but if you look at it, the Edmondson system independently predicted increased mortality even after the adjustment of contemporary method of classification of obesity. So here, when you use this one, you can clearly identify people who are at risk, and then we can directly go and just give the intervention to them. And that is one of the benefits actually we got here. The Edmonton strategy, obesity was really helpful in that way, in providing the better support for the therapeutic management. So here, when you go across the BMI category with NANSS 1988 to 94, you can classify like this: 50 million overweight is 42 with a stage 2, but 28% is stage 0. So like that, I think I won't go into the details, but you can see when you classify like this, that is published in 2011 actually, we can classify these people easily, and then we can go for a therapeutic intervention. So EOSS stage 0, no risk factors. Primordial, we need to go for a primordial, like what you go for the general public, and you just apply lifestyle modification. But number 1 with the risk factor, primary and behavioral therapy, you can go, and 2 where you can go for a medical management. But 3 and 4 is the severe category, where in terms of 4, it is extremely high obesity, where you go for surgical intervention until now. But there are medical treatments are on our way, where there are some extremely good results of 10 to 15% of weight loss happening with some molecules. Then we can try these molecules first before going to surgical management, as surgery has got its own challenges. So with that, I think I'll go for 3 case scenarios where we're going to face up in our clinic. This is like a case 1 where a 24-year-old physically active female. You can consider probably she's the one finished the college and joining work with the BMI of 32, but she's got no demonstrable risk factors, no functional limitations or mental health issues. With 32, probably she might have some PCOS, but PCOS can affect the periods and affecting also the hormonal things, with the male hormone going up and female hormone coming down, and also a lot of challenges with the periods. So with that, I think that is the one challenge we got. Oh, sorry. So we got a class 2 obesity of stage 0. So we can focus on prevention of further weight gain. We don't want her to gain more weight, and health benefits has to be discussed with the patient, and based on what she wants, we can go in for intervention. But you can always say that that aggressive obesity treatment is marginal, but we can always try with technology and other things coming into play. We can do a lot of intervention that way. So the case 2 is a 32-year-old male with BMI of 36. We got all the package of hypertension, sleep apnea, depression, you got joint pains, everything will be there. In this case, where you can classify stage 3 and class 3 and stage 2 obesity, where there is a extremely good evidence to show there is a huge benefit when sleep apnea improves. It is a complex thing where the diabetes and other things will improve in a better way. It is like a metabolic link with all these diseases like a package. So that brings us to the case 3, where a 63-year-old male with a BMI of 54, that is huge, disabling arthritis in a wheelchair, and we are talking about hypoventilation, fibromyalgia, and general anxiety disorder. Obviously, we classify as a class 3, almost stage 4 obesity. We really need obesity treatment very aggressively. I would go for surgical management in this case. So that brings almost a conclusion of my talk. But what I've discussed in last 15 minutes or so is about how to assess the obesity. We all know we are dealing with the pandemic of obesity, but we need to assess so that you can manage them and streamline them with the volume of population what we got in our country. Especially we have to streamline and classify it. Now people are focusing on obesity. This science will evolve, but that BMI won't be enough. We need to do further. But EO Edmonton score is one of the ways that I've showed where a lot of the things are applicable. A lot of classifications are available online, but I think it with just a very simple one, so we can assess and do the functional assessment, and also we can do a clinical intervention. The treatment of obesity should be patient-centric instead of algorithmic approach. But I just conclude and say this is an area where it is very, very exciting. Science is evolving. Again, I want to say where the multiple therapeutic interventions are going to be coming into play with the days of just Orlistat was the only drug available. But there are a lot of exciting molecules are going to come in the pipeline, number one. And number two, here the lot of digital and artificial intelligence are there for here to stay. I would say that we have to get into a technology thing, because the service and technology is going to be the future. So people have to go into just an app will cause app fatigue, but just going along with it, some sort of service along with the technology that will be leading to artificial intelligence is the way forward. And that is also happening as we speak. So when you go to this ADA, there's only two things. One is about the new GLP and GIP, all the weight loss molecules along with the technology. So I stop there. If there is any further questions, I'm happy to answer. Thank you.
Thank you, Dr. Suresh, for your nice coverage on this assessment and diagnosis of obesity. And you mentioned very rightly that more than BMI, we should in our clinical practice, we should consider this waist circumference as one of our clinical assessment parameter. Very rightly mentioned. And that's all for this session on this GLP-1 symposium. One thing I would like to emphasize here for all our delegates and audience, that type 2 diabetes management is incomplete without management of obesity. So you need to take care of weight and obesity, and that will be the complete management of type 2 diabetes. So type 2 diabetes management is incomplete without management of obesity. So that's all from this session. Thank you. And over to you, Dr. Ravinda, sir.
Thank you, Dr. Babu Naik, Dr. Surajit Kumar Patra, Dr. Balamurugan sir, Dr. Rajiv Kovil, and Dr. Suresh for a wonderful deliberation and for being a part of our conference. Thank you so much for your valuable time. Thank you. So over to Dr. Shweta for further proceeding.
Thank you, sir. Thank you, speakers. It was a wonderful delegate speech. Let's move on to our next session, session 7. Let me introduce the chairperson, Dr. Suresh Purohit, MBBS, DMM, MBA, IIT B Diabetes Care Physician, Accredited Diabetologist, RSSDI 1996 MBA, FMB, and Entrepreneurship IIT Bonn Consultant. And I would like to introduce the next chairperson, Dr. Ashish Gautam, Professor of Medicine, MD, FICP, FRCP, Edinburgh, FACP, the head of the Medicine Department, RD Medical College. Thank you, sir. Over to you, sir. I would request the chairperson to go ahead with the session. Please introduce the speaker.
Thank you. Thank you for your nice introduction. This is Dr. Ashish Gautam. And let me introduce the next speaker for this session, Dr. Irian Winsko. She's a board member, International Diabetes Federation from the Europe. And she is also is associate professor at the National Medical Academy of the Postgraduate Education. And she is supervisor of the international PhD students. A very big CV, as I see. So without getting delay for in explaining the CV, I request our next speaker to please proceed for her lecture. So I request Dr. Irian for his lecture.
Thank you so much for kind words, dear.
I'm sorry, as your CV is quite big, it will take at least 15 minutes.
It's okay. It's too much.
I regret. I regret for it.
Not possible. It's maybe included in my 15 minutes if we use it. Thank you so much.
My pleasure.
Of all, hello, everybody. I'm very happy to be with you, and thank you. My big thanks to Dr. Aravinda, who invited me, and my congratulations to you and to your team for this great scientific fest. Thank you so much. I hope we see soon face-to-face meeting in Lisbon. Let me share my screen. Now this. I cannot. Why? Just a moment. Yeah, I find, don't worry. Did you see? No. Great. Today we will speak about management in diabetes. I'm very happy that you put this in education session. It's very, very important, as now I know. Before I not thinking about this subject, but now a person who live in this war in Ukraine, I understand how it's very important to educate our patient when something happens, and not if, when. And of course, you see that it's a humanitarian crisis is major of global health challenge represents. And chronic disease have historically been given low priority in this area. This is understandable. And everything what I will speak, I will through my heart, through my experience in practical. And we know that diabetes in disaster, in crisis context, the majority of people have extremely limited access to resource. The complication of diabetes are a heavy burden on individuals and their families, as well as on the health system. These factors, combined with stress and psychological challenges associated with the crisis, to cause additional suffering for people with diabetes. And this rise to issue for people with diabetes crisis, they need to better management to avoid excess patient mortality. The logistical challenge on insurance and continuous supplies of treatments, especially in insulin. And what very important thing, the emergency diabetes care should be prioritized in humanitarian crisis. And if you see that it's maybe very helpful for add this to educational talk, there we have Boston Declaration that was led by some organization in Harvard University 2019 that understand it is very big problem now in the world. It's not only war, it's also natural disaster. We must prepare. And the main thing that they major targets, this is universal health access to insulin and other essential medicine, and diagnostic for glycemic and blood pressure control and humanitarian crisis. I can underline that not only check blood pressure, blood level, but also blood pressure, because due to stress, it could be higher and bad consequences. Establishment of a unified set of clinical and operational guidelines for diabetes in humanitarian crisis. And Action WHO that also must respond, and they recommend to make strengthen and design of and implementation of policy and guidelines for healthcare system. And you see, we can find some documents, not too much, but anyway, and WHO and you see IDF also response for this very important topic like diabetes and disaster. But I also want to promote this, our colleagues, documents our colleagues, diabetes care and disaster from Pacific region, who update this is recommendation, but this is of course it's big part of COVID-19, about COVID-19, but anyway it's a lot of another things which very useful for diabetes and disaster. And you see that we must prepare before happens, and this is include update list in all the time what we need. Planning, we must plan in this situation. Response during disaster. For example, Ukraine, we was not preparing, but thank you for our health minister and team that quickly responds, and then we together make a lot. And there was not terrible situation with insulin and another supplies. And you can find in this topic, in these documents, a lot of topic which are really very important. And what my underline, every doctor must prepare how we can exchange insulin which we have, and how I want to share our experience. Like Ukraine, we before our doctor must prescribe brand name, and after this happens, ministry exchanges rules, and doctor can prescribe like short insulin, prolonged insulin, or combined insulin and analog. This is helpful because we use what we have, but thanks God we have not many people exchange insulin. We have even Toger or something very expensive also. And what we can deliver like information that for people with diabetes during disaster, stress can cause a rise in your blood sugar. Erratic meal times can cause change in your blood sugar, but it's a lot of simple things which we know. But in disaster time, it's another case. It's very, very important case. And drink plenty of fluids, especially water, wear protective clothing, and struggle shoes. You know, we have bad immune system, and we can very quickly take some disease like flu and something like this, but it will be many consequences during this time. Check your feet daily for irritation, infection. Never go without shoes. This is must be rules in disaster. And food recommendation. I think it's not too much recommend. We can do this because we don't know which food we have. But anyway, we need underline the food and water supply may be limited and or contaminated. And this do not eat food you think may be contaminated and maybe necessary to boil water for 10 minutes before use. And this is it's a lot of important things, but not necessarily make too complicated. Make simple that of course we need carbohydrate, and this is also very important. And last, but from my side, it's maybe first, carry a fast source of sugar with you at all the time. This is rules, not go out without sugar. And I have my bag rucksack, which I have 1 kilograms sugar, because we don't know what happens next minutes. And thinking about if it's sick day during disaster, it could be more insulin, and do not let yourself get dehydrated. Drink plenty of water, and this is also take many insulin. Sorry. And rest. Check your blood sugar. And rest, it maybe sometimes is not possible, but for example, from beginning, we can rest only in day. We cannot not rest in night because it's like bombing and we're afraid. And this we get like all the time in stress. And what I find even for myself, the test urine for ketone, I have before I not thinking that it's very important because stable life and something like that. But now I understand that I must have this because it's not predictable, and this is more chance have ketoacidosis if it's before, and this is you must check this and know about this. You need may need more than your usual amount of insulin on sick day. This is also important to know. And please pay attention for this for you, like doctor, because if you not know, nobody can help our person. People with type 1 diabetes may develop diabetes ketoacidosis during disaster. I say to you that it's more chance. And also with type 2 diabetes may develop severe hyperglycemic state with or without ketoacidosis. And also it's possible to find some people who don't know about diabetes, but now they have ketoacidosis. It's also possible. And if you look, I find to you this diabetes in childhood, adolescence. You can find this recommendation in this excellent resource about diabetes care in use in under-resourced setting, the Life for Child program. There is protocol for DECA treatment. Some another case which ordinarily use. Insulin storage. This is also important and not necessarily afraid that insulin will be on high temperature. It's a lot of experimental research that show that even 25, 37 temperature is possible use. And also not necessarily take away insulin if it's like stop ending of the data using, because it's have better insulin even without like ordinary we have, but have this insulin. Also ensure insulin is not directly against the ice, brick or frozen vegetables, as we sometimes use it for make low temperature. And the diabetics preparing plan, it must be development. This is, you can read more about this. And now we have Alliance of the Diabetes in Disasters, prepare a lot of documents. And if you see diabetes kit, as I say, that is what need information and very important ketone strips, as I say, And my attention, please, if even person have pump treatment, maybe tomorrow it does not work. And this case, they must have some additionals like syringe, ordinary insulin, which we can use without, if something happens with pump, it's need battery, it is a lot. This is what happens with me. I only change because I have not supply for this. And remember another thing, another disease like mental health is also a lot of people in stress and depression can up, and this is also need try to manage this. And the dialysis, this is must prepare. For example, in our case in Ukraine, we try to send people to another country who can help to them, because maybe in this area not possible. And you can find, and not necessarily develop something creative, use your time, go to internet and find diabetes care plan, emergency action plan. It's everything. Only you can change something for your case, but it's a lot of good resource. And this is opportunity I want to share that. First of all, thank you very much to all of country, to all of you who support Ukraine. And together we, with IDF and Directly Relief, it's partner of the IDF partner who deliver this is humanitarian help. Thank you so much for your help to us. And but in same times, I might pay attention that you must know that yes, we can in our control this territory, and our control it's okay now. It's not a terrible situation, but in occupation territory, people without any help, without any, and people died. And this is Russian cannot give possibility to even deliver humanitarian help to different organization like Red Cross or something like that. This is terrible, and people without any help. And please stay with Ukraine. Please don't be tired from this. We need your help. Thank you so much. And this also welcome to IDF World Diabetes Congress. Welcome. Thank you so much for your attention and patience.
Thank you, Doctor. We can understand the pain the doctors of the Ukraine are suffering after COVID, after this war, the way the people are suffering, and especially the diabetic patients and the patients who are chronically ill, how they are getting problems in these situations. And thanks for all your this guidelines you have given in the preparation, how to prepare ourselves for the disaster management in the cases of the diabetes. We are very thankful to you. And for the I request for the next speaker, kindly send.
I have one comment to make, Doctor.
Sure.
Yeah, so thank you very much, Dr. Irina, and we acknowledge your efforts to continue helping the diabetic patient during this emergency and disaster situation, which is really courageous. And I want to acknowledge all the doctors and paramedic teams, those who are working with patients, and even your patients, those who are listening and taking care as per your instructions, and whatever is available you are doing. Thank you, thank you, thank you very much.
Thank you.
Thank you, ma'am. Thank you so much. And over to the chairperson. Kindly. Hello, sir.
If you could please put the introduction of the next speaker.
Yes, sir. Kindly introduce the next speaker.
I cannot see the.
Yes, sir. Just a second. Yes, sir. Over to you, sir.
For our next session, I invite Dr. Dharmendra Panchal. Is a consultant physician, diabetes and obesity and endocrinology, diabetologist, diabecare at Sabarmati, Ahmedabad, is an assistant professor and endocrine at Dr. M.K. Shah Medical College, consultant at Ahmedabad. As invited speaker at the various national and international conferences, is the founder of Diabetes Digital Clinics, is a member of the so many reputed societies of the India, including RSDI, is regional faculty for the certificate course in evidence-based diabetes management at the PHFI. So he has a lot of publications in the various national journals and the textbook, and probably the CV itself shows that he's a great academician. So I request Dr. Dharmendra Panchal to please proceed for his presentation for the today.
Thank you. Thanks a lot, respected chairpersons, and my heartfelt thanks to Dr. Arvinda for giving me this opportunity to speak over this platform. After a fantastic session of Iriana, I am giving the responsibility, I was given the responsibility to speak for self-monitoring of blood glucose, one of the important parameter for diabetes education. To take forward, we all know that diabetes is booming like anything, and it's increasing all the way across the globe. And if you talk about Southeast Asia region, we are going to increase by 68%. And if we talk about diabetes management, so optimization of diabetes management requires people with type 2 diabetes to understand the relationship between their lifestyle, food intake, therapeutic intervention, and current blood glucose values. We all know that it requires balance of education, diet, exercise, drugs, and monitoring. After having the decades of new interventions of drugs, since ancient time, diet and exercise has been followed. Nowadays, education is bombarding. We can have at one click all the information, and still we are struggling to get the target for our people living with diabetes. Maybe this monitoring is one of the neglected part, and that's why SMBGs must be the integrated personalized diabetes management part. It was nicely quoted by Dr. Sanjay Kalra sir that this cycle of integrated personalized diabetes management, 6-step, including first step, education and selection of structure SMBG regimen. Step 2, initiation of this structure SMBG regimen. Step 3, data upload and documentation. Step 4, data analysis. Step 5, personalized management. And step C, to reevaluate, see the treatment efficacy assessment, and we should just recycle this cycle till we get our goal for diabetes management. And for these, the key pillars are 5 E's, that is education, enthusiasm, expertise, engagement, and of course, empathy. And if we are able to integrate SMBG in diabetes management, we will be able to get the target for our people living with diabetes. Though various guidelines in India is recommending SMBG, including ICMR also, and the recommendations are all people with diabetes to achieve their better control of diabetes must do self-monitoring of blood glucose. Otherwise, all people with diabetes on insulin, those with brittle diabetes, those who are prone to have ketosis or recurrent hypoglycemia or history of recurrent hypoglycemia unawareness, or whenever we need the tight control in a situation like acute illness, some complications, or pregnancy, SMBG is recommended. But this is important. All the guidelines emphasize that frequency of SMBG must be individualized. And these are the various pattern of structure SMBG programs. Likewise, the upper one, that is a staggered profile. On one day, we are advising pre-breakfast, post-breakfast. Other day, pre-lunch, post-lunch. Other day, pre-dinner, post-dinner. This sort of other structure SMBG program for intensive 7-point SMBG program may be advised, like pre and postprandial blood glucose measurement, 3 meals per day, before and after, and 1 on bedtime. If we want to have more accurate assessment of glucose profile, for the evaluation postprandial of glycemic excursion or overnight glycemic evaluation, pre and post breakfast evaluation for the breakfast for the whole week may be advised, or else pre and post prandial blood glucose measurement for 1 meal on 2 consecutive days or overnight is advised. So depending on the patient, we must choose a applicable structural SMBG program for our patient. Nowadays, SMBG systems are becoming more and more modernized. Current SMBG systems, they are small, easy to use, requires very small blood samples, provide the reading within seconds, and in addition, their usability and more importantly, their glucose measurement accuracy has also greatly improved. If we talk about modern SMBG system, they have integrated with connectivity. They are connected to some mobile application which is there with the patient, which is there with the healthcare provider, which is there with the parents of the patient even, or guardian, so that they may also and they will also evaluate, and if required, timely intervention can be taken. Many SMBG system, they are integrated with the digital diaries in the way that all the profile will be recorded. It with the diaries or application will be able to again put it into the graphical manner and more detailed analysis in pictorial view we can have. Few SMBG system again have calibrated insulin dose calculator based on the insulin carb ratios or their food activity, their physical activity, and that system may guide a person living with diabetes for some accurate dose for the bolus injection even. Many SMBG system, or most of they are having again associated with some alerts or reminders which can suggest whenever they are high or low blood glucose values, and it can remind the patients as well as guardians as well as healthcare professional to take care of it and intervention. This is one of the example of modern SMBG system. It is with AccuCheck, and you can see the 7-point SMBG, and it can be plotted on the graph. You can download it. Again, if you over the day 7-point SMBG values, and we can clearly see that a person is struggling with postprandial hyperglycemia, and intervention targeting the postprandial hyperglycemia may be able to get the flat glycemic profile. So we have we can utilize modern SMBG system as accurately as continuous glucose monitoring system even. But what's the current situation? According to 2008 study carried out by SMBG International Working Group, only 0.2% of the people with diabetes in India are performing SMBG. Though if we talk about recent data by ICMR, which are yet to publish, this has markedly increased to 20.8% of people with diabetes in urban India and 14.5% of those in rural India. And that's really good for us and people with diabetes. And still we say SMBG use in India is low, maybe first and foremost because of cost. But again, nowadays, low cost SMBG systems are available. Another is 80% of the people with diabetes in India have to pay out of their own pocket. There is a lack of reimbursement system, which includes SMBG and their test strips. One more thing, healthcare professional, maybe they are too busy or don't have sufficient time to go through the laborious sheets of the paper produced by people with diabetes. And also, most importantly, for perfect or for good glycemic management, people with diabetes should be empowered, and maybe people with diabetes are not empowered to use the data to make the adjustment for the diet, physical activity, medication. They have to rely on the advice of healthcare professional or the diabetes care team. So this were the barriers, and which maybe with current modern system we can overcome also. And one major barrier in India is there is a large lobby which is against scientific and modern allopathic system called alternative system or integrated or many other pathies, and peoples are every time confused what to do. So solution is awareness, awareness, and awareness. So increasing awareness for the need of performing structural monitoring of blood glucose is required, and more importantly, people must be empowered to do the actions as per their SMBG reading, and this will help to propagate SMBG in developing countries like India. To summarize my talk, I would like to say that SMBG is a must integral part of the diabetes management, but it must be personalized, individualized. Modern SMBG system far better than previous one, and as good as I would say continuous glucose monitoring system. But people with diabetes should be motivated for performing more and more SMBG to achieve their targets, and they must be empowered to use modern SMBG systems. So here I would like to again thank you and would like to conclude my talk. Would hand over to the chairperson for further. Thank you.
Thank you, Dr. Dhamin. Very well advocated regarding the SMBG. Definitely, most of the part of the Indian people who are living from the rural background or are not from the very affluent society who cannot afford CGMS and AGPs, SMBG or treatment line is entirely dependent on the SMBG recordings. So I thank you all. Thank you for your good, very presentation. For our next, is there any question in the chat box
or any comment? Or yes, I think Iana.
Yeah, I think your very great presentations, very interesting for me. But how you think, how we can motivate to make even simple way to control diabetes? Because I think it's your presentation show that it without monitoring glucose we cannot have good result. This is, but how we can motivate, because it's a lot of we try, but somebody like resistance. How we can motivate? What do you think? Thank you.
See, motivation, intervention for the two aspect we are doing. First, in general, into the societies, in general, whenever in societies or any of our peer groups, if anybody is there, we must, are you checking at your glucose at your home or not? And second is the reward system, which we must include in our diabetes care practice, and which we have started to rewarding a person who is carrying out their blood glucose monitoring regularly with something. Either anything, a simple flower or bouquet also will suffice. That motivates them. And it's like, eyes don't see what brain doesn't know. When they realize, when they monitor, when they see their glucose values, either they are improving or not improving, they will take the action accordingly. But if a person is not checking, then they are just staying like that, oh, whatever is there, it's going on good. So intervention at both at large level, community level, as well as one-to-one to the patients, or one-to-one to the person level, that is required. And that's what we must, just try to do more and more to encourage the people to do more SMBGs.
I can share my opinion, because I find from my life, it was my mom who said me, please, you must buy trips, less clothes. And this is work, because now I understand how it's very important that save this good condition. And another way I make like pharmacoeconomic research, that finally, if I account how much we need because we pay this for this test strips and glucometer, is not terrible. But you must investment in your health. This is my point, which is not from start. Thank you so much for your presentation. Very a lot of great points. Thank you.
Thank you. Thanks a lot for your opinion and your participation. Thank you.
Thank you. For our next session, I request Dr. Bhavartini. She is State Coordinator IMA Diabetes Course, and she's an IMA National and State Award for the academic contributions. She is governing council member of the RSSDI in the DEPSI, the faculty in the Diabetes Training Program in DPH Tamil Nadu, the Best Teacher Award by the State IMA. She has several publications, 21 presentations, 29 papers nationally and internationally, and participated in the 7 clinical trials as of now. She is founder and ex-committee member of the Tamil Nadu RSSDI, DFSI, and the DIPSI, and the past API Secretary, Erode Chapter. She is advocate of the advocate board member from the COVID and the diabetes guidelines, Tamil Nadu government. So I request Dr. Bhavartini to please go ahead for her session. Thank you.
Can you please allow me to share my screen? Very good evening, one and all. At the outset, I thank Dr. Aravinda for giving me this wonderful opportunity. My topic is what are the challenges we face when we teach our diabetic patients. So when you say diabetes, we see to first diet, more exercise, then drugs, then we monitor. For a table, the very important thing is the tabletop, that is education. Without education, all these will go waste. But when we start educating, what are the problems we are facing? Who are the partners in our promotion for this education? Of course, the governments should stand first, and then the parents and the teachers in the school, medias which are focusing wrong, and the social organizations, medical and paramedics, and healthy patient-to-patient conversation, what he has enjoyed. If we take the thrifty genes, we are all thrifty genes. We were hunters and gatherers looking for a single food a day. And whenever we get it, we can store it for those days when food were not available. But the same has become deleterious now. We are getting food continuously and we are storing and storing, getting into all the problems of metabolic syndrome, dyslipidemia, obesity, and all this. And still our genes have not changed. We were walking with 4 legs. Now we are walking with 2 legs, but with a Coke in the hand, and continuously eating something that is not walking, but moving on wheels. Wherever you go, you have plenty of fast foods and vehicles to carry you wherever you want. We are not working even 1/100th of what our ancestors worked. We have some festival or function like birthdays, marriages, anniversaries, religious festivals, promotions, achievements, condolences, retirement party, unnecessary get-togethers with gala dinners, meetings, conferences, welcome and send-off parties, treats, eat-outs, and tours. If you don't have anything, we can create some occasion. Like this, we are celebrating each and every day without working much. And if you go to the alternative treatment, we say diabetes is controllable, but they advise wrongly that diabetes can be cured. Not only that, they say anything can be taken, including sweets. They mislead the patient. And we educate so many things in the school, but not the health education. Healthy kids only can learn better and will form a good nation. Of course, we say when we eat, it should be in a right time, right proportion, and a right quantity, whether it is followed. If you go to a school, you can see so many fast foods in the canteen, and our children are rushing to get all this. Nobody is having healthy food. On one side, we are shouting for healthy food. On the other side, see what they are promoting. So this should start from school. You should educate them to take more of vegetables and all what we prescribe for the patients or educate. It should start from the school, and you should educate them that like how they brush. We teach the children to go to toilet, take bath, eat, sleep, watch movie, all that. We should first and foremost, we should teach them about regular exercises. It should also become a part of the life. Those days, it was a multiple members in the family. It was not a single child like this, which is better more and given more and more. Whatever advice we give, it is not taken care like this. Children where there were many children in the family. And to the patient, if we say not to take sugar, they just mistake it's only the white sugar, and they go in for the and cane sugar juice like this, some other thing they create themselves alternatively and use it in the diet. And if you see the medias and newspapers, they give so many offers for fast foods. So people are naturally attracted by all this. Whole family, they give combo offers. They don't listen to it. Nobody can control that taste. All these, they need not go and get it. It's all delivered at the doorstep by all this Swiggy, Zomato, Uber, Amazon, all that. And how can we talk about health education to eat properly? You can see plenty of food like that, nothing healthy. Even we are not able to promote in our own conferences. And if you take a job, they'll not be eating throughout the day, concentrating fully in their work. But at the end of the day, they eat together whatever they can. It should not be like that. Again, the patients, instead of taking 3 meals in the morning, afternoon, and night, you split and take for 6 times. They mistake it for taking 6 times the same meal. They increase what they have been taking already. And you should remember whatever you food take, it's just 90 seconds of taste in the tongue. So you want just 90 seconds of taste or 90 years of healthy life. Think about it. And if you ask them to take rice, it should be in a proper form, just steamed rice or whole grain means just it should be whole grain bread, all that. It should not be biryani, cakes, cookies, deep fried fish, all that. It should be in a proper way cooked. It should be steamed. And see, is in 60s and all, we didn't have any diabetes, and our ancestors are still healthy. It's because they have been working all the time. We don't even work 1/100th of what they work. And even for washing and doing all this, everything is mechanized. We have machines for everything. We need not even get up and go. We can control everything with a remote. See, no washing the vessels, no sweeping, and no grinding the floor. And chutneys can be made with mixies, grinders, washing clothes, everything, cooking range. Everything is ready with a cooking range. We need not struggle for cooking. And those days we used to long distance to get the water even. Now just opening the tap, we get water. Our days, we are tuned for a life like that. But now we have changed everything, westernized. And if you don't have all these machines, they readily provide with loans with a very easy installment payments. And we say that sitting is not good. Our people are many a time sitting either in front of the TV or computers or laptops or iPads, WhatsApp. So not only that, they keep eating something when they listen to all this. And our technology was so big those days. Man was so thin because he was working. Now the television has become thin, but the man has become like this because of his lifestyle. And even in villages, people are not allowed to work. They have share autos, mini buses, leaving them at their doorstep. If they are affordable, of course, they go by either two-wheelers or AC cars. Nobody is willing to work. Even the fitness centers, see, nobody walks in the steps. Everybody uses the escalator. Even our American Diabetes Association meet, see, all are coming by this, not step. And how can we promote here? See, there are golden management quote. When something is free, you are the product. Netflix doesn't cost $4.99. It costs your time. And Coke doesn't cost just 30. It costs your whole health. Social media isn't free. It costs you your focus. There is always a hidden cost Remember that it is you are caught. And we say that sitting is new smoking. Just sitting for an hour takes away 11 seconds of life, like smoking. See, in the offices, any organization, all are sitting with a mobile phone. They don't even get up from this place to this. They convey everything through the phone. And not that they don't forget to take all their snacks or drinks, what they want. All these people, policemen, musicians, companies, conferences, meetings, movies, everywhere, they are constantly slipping, not just sitting. They eat something continuously along with that. See, this boy's mom, she's very particular about health. I asked him to go out and play. He is bringing the laptop and sitting outside and playing with the laptop. Movies, we have big malls with the 3 or 4 or 5 theaters with more food outlets. So you can, when you get some relaxation time, you don't go visit your relatives or do some gardening or other hobbies. Instead, you go sit in the movies, move from theater to theater with much snacks throughout the day. See, all these, when we were children, I am 60 now. When we were children, we used to run about. We have all these plays, mass drills, and even at home, we used to help our parents. At construction also, we used to help them, then come to school. Our education was just part of life, not the whole thing. And we used to swim, we used to do skipping, go by cycle. All these has gone. All these were plays what we had. We used to go out and play in the ground with our friends, and whatever functions we have in the school, we have mass drills, mass exercises, so many competitions and dances. All these has gone. And now even yoga was a part of education, and we were given pass only if we pass out all this. Now they have taken up all this sports activities for other periods like chemistry, physics, or other things. Though don't allow them to play at home or in the school. Everywhere they are sitting and reading. They had a get together like this. All the children, they used to play with that, so that they communicate with each other, and they were brought up well. All these were the olden games. I think people like me will remember all this. Now all children are, the moment she is born, when she knows to see something, she's put on in front of the iPad or television or in the laptop. Even the unaffordable, they get a single phone and they are watching all together. They are watching the thing. And our God is not sitting down. He's sitting at a mountain top. He is there. He wants us to walk above and then see him. But now we have this cable cars and winches to go up. And we used to kneel down, bend, and do all these exercises. All these has gone. And our temples, if you see, it's so big. The corridors were so long. We need to go around the temple when we visit the temple. But now all these has gone. We used to put sit-ups for our God, which is a very good exercise. What they called is a super brain yoga in US. This we have been practicing long back, which involves all the muscles. And our Tamil Nadu culture is we used to put kolam every day. And especially for the festivals, we used to bend down, put this kolam for an hour or half an hour at least, where the ladies didn't have any joint problem. But now all these columns are available in plastic readily. Just paste it in front of your house. Any function or festival, we had these dance programs where we physically were involved. But now we have all these, that is the cell phones, radios, and TVs. The cell phones giving us so many opportunities to talk, and the radios asking us to listen always, hear that, and the TVs asking us to watch that together always. And we now are a single children. During pregnancy, it's very important. They do need to do some work and have a very good meal plan. But here also, they celebrate pregnancy throughout, and they make the even normal girl to become a gestational diabetic. We all know that all diseases starts in utero. She is made GDM and all diseases are that. When I start advising all my patients, all these what I have said, they say, our Buddha, Yesu, our Gandhi or Nehru, they have talked adequately all this, and we have not listened to all this. You want me to listen to you? They used to ask me. That is the scenario here. Remember, you have to listen to your soul, not your mind. Your mind always catches for something which is wrong, which is going to cost your health. So we have so many challenges in our diabetes education. It is up to us to decide what to eat, what not eat. So we need adequate educators, like treating the patient. We also should concentrate on educators. All our nurses, dietitian staffs should be educated, and the media should promote health, not destroy the kids by its attractive advertisements. And all these medias which are giving wrong information should be supervised. Health education should start from childhood and should be inculcated in the child. Whatever is taught at 5 years will be retained till 50 years. And remember, fast food kills us fast, and it should be discouraged, not promoted. And physically fit who are following all what we advise should be awarded or given priority in promotion or anywhere. Other things, health should be promoted by the government. Otherwise, it should be a only the nation can become wealthy and happy. By this, I once again thank Dr. Aravinda for giving me this wonderful opportunity. Thank you. Thank you all.
Thank you, ma'am. It was a wonderful session. Thank you for asking us to cut down our lifestyle modifications and to adapt to the traditional modifications. It was really a golden word regarding the challenges in diabetic education. And I would appreciate the information and advice that you shared to us, ma'am. Thank you so much. And any questions in the panel? Any more questions in the panel?
Thank you, Dr. Bhavatini. It was an excellent illustrated presentation. Definitely, the diabetes education is a real challenge for the Indian context, because the real teacher for a diabetic patient nowadays is his neighbor. People grasp the bad news, the myths about the diabetes very well, rather than the instructions given by the doctor. And especially the kids, the way the people are going on, the media, the social medias, Facebooks, and all these offers, they are really ruining our physical health as well as mental health. So definitely your instructions and all your comments you have given is very well taken. I especially thank to all the speakers for this session, for their sparing their time for this session. So thank you all. Over to the event.
Thanks, Dr. Aravinda, for giving me this unique honor of the Pagoda oration. Thank you very much.
Thank you, Professor Mohan, sir. It was a wonderful oration. No one can deliver better than you. I think there are no questions allowed as per the orations, as per the customary. It was a wonderful talk. What Dr. Chandini, what to say?
Thank you to our chair.
So thank you, Dr. Suresh Purohit, Dr. Ashish Gautam, Dr. Irina, Dr. Dharmendra Panchal, Dr. Bhavatarini for your time and participation in your conference. Over to Dr. Shweta for next session, please.
Thank you, Dr. Aravinda.
Sir, if anybody has any discussion to be made, we can discuss.
Thank you, speakers. It was really awesome presentation for all the three speakers, and thank you for taking out the time from being a busy schedule to provide such a valuable information. Thank you all the speakers. And let's move on to our next session. I would like to introduce the chairperson, Dr. Sudhir Chandraja, Associate Professor, Department of Medicine, Darbhanga Medical College, Bihar, MBBS, Calcutta Medical College, MD Medicine. And I would like to introduce the other chairperson, Dr. Surekha Shetty, Associate Professor at Karnataka Institute of Endocrinology and Research, MD in Internal Medicine, MSc Endocrinology. Over to you, chairpersons. Thank you.
Good evening, everybody. And thanks, Aravinda, for giving me opportunity in this grand conference. Our first talk of the session is managing steroid-induced diabetes. All of us know that a steroid is an important part of medical therapeutics, and it can produce hyperglycemia as such and can aggravate hyperglycemia of diabetes mellitus. So it is a very vital topic, and to talk on this wonderful topic, very clinically relevant topic, we have got a famous diabetologist Dr. Anjali Bhatt, MBBS, MD, PDFD, D, Endo, MSc Endo, founder and chief consultant, Endo Clinic Pune, passionate about patient care research, teaching, forming curricula for various courses and community-based activities. She is MD in medicine from Mahatma Gandhi Institute of Medical Sciences, Wardha, stood second in university, trained in prestigious Department of Endocrine at CMC Vellore, contributed for many publications in journal, as well as books, and invited for talks in many conferences. Passionate about watercolor, paintings, writing, reading, traveling, music, and motherhood. Multifaceted personality indeed. She is a visiting consultant at Symbiosis Medical College for Women and Symbiosis University Hospital. Dr. Anjali Bhatt, the stage is yours.
Thank you so much, Jasar, for the wonderful words. And thank you, Arvinda Boss, for inviting me to talk on this clinically very relevant topic. Without delaying, let's go ahead. Just want to confirm if my slides and audio is properly seen. Is it all right?
Yes, ma'am, it's all right.
Sure. Thank you. So let's move ahead with the agenda. I would like to talk about steroid-induced diabetes in these headings and subheadings. We'll first see what is the relationship between steroid and diabetes, what is the mechanism of action, and what are the clinically relevant points that we would like to know from the steroid-related point of view and the patient-related point of view. Then what are the typical characteristics of steroid-induced hyperglycemia, which will help us not only to diagnose that this particular character of hyperglycemia is possibly related to steroid, and secondly, how we will manage it choosing the right anti-diabetes therapy, which will help us to combat the exact characteristic of hyperglycemia that is induced by steroids. And then coming to how management of steroid-induced diabetes can be done from diagnosis to tapering of the steroid along with tapering of anti-diabetes medications. So first is why diabetes is caused or hyperglycemia is caused by steroids. We all know what is the mechanism of action of glucocorticoids or corticosteroids, what is commonly called. They are products that cause energy anabolism and tissue catabolism. So practically they increase the level of the energy metabolites in the blood and taking it away from the tissue. So they increase lipolysis, they increase proteolysis, they reduce, increase the hepatic glucose production, that is gluconeogenesis, and they increase insulin resistance. And the resultant is increase glucose level in the blood, but reduction of the tissue at protein, mainly protein, and the muscle level. And they can increase or reduce insulin secretion depending on the patient's baseline pancreatic capacity. So if the patient is on verge of insulin deficiency at the baseline, the insulin secretion can reduce, further contributing to hyperglycemia or what we call as diabetes. Now, what is the relationship? What all we can have in the clinical practice? We can have a patient who is using steroids chronically and has resulted into diabetes. Use of steroids in a person with pre-existing diabetes, worsening the hyperglycemia level, or we can have endogenous Cushing's patient who require management of diabetes. Now, 20 to 50% of patients on steroid develop a de novo hyperglycemia, which means that by flipping of coin, you can tell that the patient that is started on steroid can develop hyperglycemia. So practically every patient who is started on steroid, diabetes or hyperglycemia must come into consideration when we are dealing with such a patient. So how to predict this, if it is so common, how to predict who will possibly develop diabetes with steroid or not? The patient-related factors that increase chances of someone developing diabetes when started on steroids: pre-diabetes at baseline, older age, obesity, past history of gestational diabetes, family history of diabetes, and some contribution from the disease for which steroids are indicated are important. So if you find any of this character while steroid is started, this will be more from the patients who are starting, doctors who are starting the steroids. So if any one of this is found as a risk factor in a given particular patient, the patient should be considered as high risk for diabetes and necessary precautions need to be taken. From the steroid related point of view, we are going to see this in details, but the dose, type of steroid, duration of the treatment, and whether the steroids are given continuously or intermittently will affect the type of hyperglycemia as well as the intensity of hyperglycemia. Coming to a very important point, what is the disease in consideration when the steroids are given has a very important implication on what kind of therapy we will start and how we will taper it. Now, the most common things are rheumatology and dermatology. These are people who are on steroid for a long period of time, and they may be on steroid intermittently during the exacerbation of their the baseline disease. If the baseline disease is a very short term where steroid is given for 5 to 7 days or for a couple of weeks, then the hyperglycemia pattern is going to be different. And the diseases like this, the hyperglycemia pattern is going to be different. Secondly, if the patient is coming to you for diabetes management, if the glucose pattern looks like something that can be contributed by steroids, many of times patients will not tell you that they are also taking steroids for rheumatological or dermatological problem. So it's very important that we try to understand the pattern of hyperglycemia due to steroid and suspect the steroid which the patient may not come forth with. Another is renal, especially the post-transplant rejection, and then the respiratory like chronic obstructive pulmonary disorders. So we must remember that if the patient comes up with symptoms related to these diseases, steroid must be considered. Now, a very important point, the potency of the steroid will decide the effect of their effect on hyperglycemia. So it's important to remember the potencies of the steroid. If we compare prednisolone 5 mg with other like hydrocortisone, the equivalent dose is 20 mg. In dexamethasone, which is another commonly used, is 0.75. Remember, this is an anti-inflammatory action that is compared, not the hyperglycemic action. But theoretically, we consider that possibly the hyperglycemic action will also depend on the potency of steroid and specifically the duration of action. Like prednisolone is acting for 16 to 36 hours, but the dexamethasone long acting might affect up to 2 to 3 days. So when co-administration of drugs with steroid is also important. Theoretically, any administration can cause hyperglycemia, but most commonly it is found with systemic administration, that is oral or injectable. Medications that can prolong half-life of steroid should be considered, like cytochrome P450 modifiers, and there might be some drugs that have steroid-like action, like megestrol and medroxyprogesterone. So these are certain clinical pointers that need to be remembered when we are dealing with these patients. And it's important not to forget the alternative medicines nowadays have been shown to have some steroid effect, or for that matter, addition of the allopathic steroid itself. So Ayurvedic medications, the churnas and the kalpas and powders given by quacks can many times contain steroid and need to be talked about when we are dealing with a particular characteristic of hyperglycemia. Coming to what is this particular characteristic of steroid hyperglycemia. Now, steroid preparations, including prednisolone and dexamethasone, all steroid preparations for that matter, follow a circadian rhythm, depending on their duration of action and potency. They are likely to mimic the endogenous steroid pattern, which means that there is a prominent postprandial insulin resistance, especially starting in the early morning or late morning, peaking during the late afternoon, and then coming down by the evening in terms of short-acting steroids, and in the midnight in cases of long-acting steroids. So this is the typical characteristic of a steroid-induced hyperglycemia. If you are using a short-acting hydrocortisone, only a mild mid-morning increase. If you're giving it twice, a 2 peak similar. If you're giving intermediate acting like prednisolone, methylprednisolone, this will be the pattern. Peaking in the late afternoon and then weaning off in the early or late evening. If you're giving it twice, again, this might be 2 peaks. And a long-acting dexamethasone might increase the blood glucose throughout the day, but it will cause a reduction or tapering of its effect in the early dawn phase or the late night phase after an overnight fast. So typical rises within 4 to 8 hours after oral administration, slightly early with an IV dose. So if we consider most commonly prescribed steroid, that is prednisolone, what we are trying to see is a characteristic hyperglycemia happening during the daytime, that is post lunch and pre-dinner, and then we need to avoid nocturnal hypoglycemia. So we cannot give a drug that will act constantly for a 24 hours because it will cause hypoglycemia in the night. Dexamethasone hyperglycemia can last for more than 24 hours, but sometimes if the metabolism is faster, there is a slight decline during an overnight fast. So what we need to do is we need to cover the daytime hyperglycemia and avoid a nighttime hypoglycemia. How do we monitor? Almost every patient needs to be monitored for steroid-induced hyperglycemia. But if the patients that we have seen in earlier slides are found to have high risk, HbA1c checking before starting steroid becomes important. After the steroids are started, we generally ask the patient to check blood glucose at least once a day to start with, either at post-lunch or pre-dinner time. And if it is more than 200, we need to increase the frequency, start the treatment accordingly. If it is consistently below 180 for 3-4 days, then the patient can reduce or cease the monitoring. Now, after monitoring, if you find that the blood glucose is going up, we need to start the treatment. And we need to start the treatment to match the exact characteristic of steroid hyperglycemia curve. And if we are starting insulin, NPH is found to be one of the insulin that exactly matches, the action of NPH exactly matches the action of hyperglycemic action of steroid. So NPH is probably the first line therapy for management of steroid-induced hyperglycemia. If the hyperglycemia is mild and you think that the patient can be managed on oral hypoglycemic agent, then a short-acting sulfonylurea like gliclazide is useful. Now, the dose of gliclazide is somewhere around 40 mg for every 5 milligram of prednisolone or equivalent steroid, as we have seen, taken at the same time as the steroid. If the steroid is given after meal, the gliclazide needs to be taken before meal. That is the only difference. There is little evidence for other oral anti-diabetes medication as being useful for steroid-induced diabetes. But as such, there is no contraindication for continuing the oral anti-diabetes medication if the patient is already on other oral anti-diabetes medication. And gliclazide can be added on if the baseline oral anti-diabetes therapy is not enough. Now, coming to the insulin treatment algorithm, as we have seen, if the blood glucose is less than 200, if we decide to start oral anti-diabetes medication, patient controls well, no issues. But if the preprandial blood glucose is higher than 200, it is better to start with insulin. Either we can start with NPH just before breakfast in milder hyperglycemias as 0.04 units per kg, and in severe hyperglycemias more than 300 as 0.08 units per kg. Or if the patient is very obese, we can even start 1 unit per kg. If the patient is very obese and you think that only prandial will not be enough, we can straight away start with both basal as well as meal-related insulin. It's very important to note here that the proportion of basal and meal-related insulin is very different when we are dealing with steroid-induced hyperglycemia compared to the general type 2 diabetes. In steroid-induced hyperglycemia, we require more of a prandial insulin, 70% of a prandial insulin, and only 30% of the basal insulin. This ratio is quite opposite when we are dealing with non-steroid-induced hyperglycemia. And then, of course, we ask the patient to keep monitoring, and depending on the response, we need to manage the insulin therapy. The patients who already are on insulin or basal bolus therapy will require up titration. So if the patient is only on basal insulin, an up titration by 10 to 20% is required. If the patient is already on rapid acting insulin, then we need to scale to correct the preprandial and spontaneous hyperglycemia. Now, if the patient is already on insulin, we add on 0.04 units per kg if the prandial blood glucose is 200 to 300 preprandial. And if it is more than 300, we add on to 0.08 units per kg. So if patient is 50 kgs, patient is already taking 10 units, you add 3 to 4 units to the preprandial insulin depending on the preprandial glucose value. Now, here I would like to say that the pre-mixed insulins that come in proportion of 30% of basal, 30% of prandial and 70% of basal are a big no-no for steroid-induced diabetes management. So pre-mixed insulin should not be recommended in patients who have steroid-induced diabetes. Now, similar approach is also there for in-hospital patients, especially if the patients are requiring round-the-clock steroid. For example, hydrocortisone 3 times a day or dexamethasone every day. Then a basal bolus therapy is going to be the best approach to manage steroid-induced hyperglycemia. Coming to how to taper the anti-diabetes therapy. Generally, glucose levels drop to normal in previously non-diabetic individuals within 24 hours of tapering the steroid if the steroid is given for a short period of time. But it may take several weeks if the steroid is given for a long time or a very high dose of steroid is given acutely, especially in patients on chemotherapy or post-transplant, post-renal transplant patients. But in others, where the steroid is given for an intermediate period of time for, let's say, 4 to 8 weeks, and then weekly reduction is done, which is very common, weekly reduction of 5 mg of prednisolone or equivalent of other steroids, roughly requires reduction in the dose of daily insulin by 25%. So 5 mg of prednisolone reduction, you change the dose or reduce the dose by 20 to 25%, or reduction in the dose of glycoside by 40 milligram, and then keep monitoring and taper it accordingly. Now, there are some patients who may not have, who may not reach the non-diabetic stage even after tapering of steroid completely. Now, a long-term use of glucocorticoids has shown to cause a long-term persistent, or for that matter, permanent effect on pancreatic function. And these patients are likely to develop type diabetes, which will persist even after stopping of steroid. And it may persist, especially in patients who we have seen as high risk at the baseline, like patients with pre-diabetes, high risk of a previous history of gestational diabetes, family history of diabetes, or extremely obese patients. Coming to the summary of steroid-induced diabetes, we have seen that steroid and diabetes have a very important relation to each other. Characteristics of steroid-induced hyperglycemia we saw, and management of steroid-induced diabetes we saw. So remember just 3 diagrams from this presentation. One is in which patients to suspect steroid-induced hyperglycemia if the patient comes up straight away with the steroid history, or we suspect that this particular characteristic can be because of steroid-induced diabetes. Then we have seen different types of steroids and how characteristic their hyperglycemia would be, and depending on that, how to manage this patient through either insulin therapy or oral anti-diabetes medications, and then how to taper them when the steroid therapy is tapered. With that, I would like to thank Arvinda sir again once more for involving me to his super duper conference, and I'll be happy to take if there are any questions. Hope I have stick to the time.
You're spot on, Dr. Anjali, you're spot on.
Dr. Sureka Sethi, kindly summarize and invite.
It was indeed a pleasure listening to you.
Mm.
And I think the last slide summarized whatever you wanted to say, the pathophysiology and the way that steroids affect our blood glucose levels, and how we should utilize anti-diabetic drugs to address the specific hyperglycemia in each of these patients. And this becomes very important, I think, because many of the clinicians who start on steroids sometimes end up telling our patients that anyway, it's a short-term effect, so don't bother. I have seen quite a few of my patients who had optic neuritis and have been started on steroids and have been told not to monitor the sugars.
I have seen patients like that coming back after 2 years with diabetes.
Yes.
2 years back, steroid was given, blood glucose was never checked, the hyperglycemia persisted, and now they have developed full frank diabetes. You are absolutely right, madam.
Dr. Anjali Bhatt, excellent lecture. One question I would like you to answer. Which of these steroids induce hyperglycemia lower than their comparable molecules? I mean, which steroid causes least hyperglycemia comparatively?
Sir, the longer duration of action steroids suppress the metabolism or modify the metabolism, I would say, modify the metabolism in a non-circadian manner. So we do not have answer to the question whether one molecule is better in terms of hyperglycemia, but from the point of view of suppressing the endogenous steroid, the long-acting steroids like dexamethasone are worse compared to the intermediate acting like prednisolone. But from the hyperglycemia point of view, we don't know. What has
Deflazacort any advantage over other
no,
molecules?
sir. No. Deflazacort also causes hyperglycemia in the same
And
manner.
as far as the long-acting steroids are concerned, do you feel that instead of first-liner isofen insulin, we can go for longer-acting insulin?
Yes, sir. In dexamethasone use, even basal bolus therapy would be better than just NPH. But now I don't know, tertiary care center where I am working, I find very few patients who are on dexamethasone, very few. The most common use is prednisolone. And that is why I talked about that. But you are right, if you are giving a 24 hours action steroid, then a 24 hours covering anti-diabetes therapy would be required.
Any more questions?
Thanks, Dr. Anjali, for the wonderful deliberation.
Thank you.
Excellent. Excellent talk.
Thanks, Dr. Sudhir and Surekha for the wonderful discussion. We can move on to next session. Over to Dr. Surekha.
Yes. I think I would like to first thank Dr. Arvind for bringing in so many diabetes care professionals on one platform and seeing the enthusiastic participation. Cheers to you. This session especially is important because this is often neglected by many clinicians, that the hyperglycemia in the specific situation could be important for the diabetic patient. So I think highlighting them is a very important aspect. So let's move on to the second topic. To address the perioperative management of hyperglycemia, we have our second speaker. Could we have the slide, please? So to address the perioperative management of hyperglycemia, we have with us Dr. Could you highlight the slide on Dr. Puneet Saxena?
Previous one.
Ma'am, he hasn't joined yet.
Oh, okay. So shall we move ahead with the
Good evening, Arvind sir. Good evening, RX team. I am here.
Oh, Dr. Puneet is there. Yeah, Dr. Puneet is there.
Welcome.
Okay.
No, here, Dr. Puneet, I am Dr. Swaraj here.
Dr. Puneet is there? Okay. Dr. Swaraj, yeah, you can go ahead with Dr. Swaraj talk, Dr. Surekha.
Yes. So welcome, Dr. Swaraj. And I think just to introduce our speaker briefly, Dr. Swaraj is working in Kalburgi, and he has done his fellowship from diabetes and endocrinology from Manipal Hospital, Bangalore, and has also done senior residency in endocrinology from St. John's Hospital, Bangalore. Currently works as Associate Professor, Department of Medicine, Yammar Medical College, Kalburgi, and is also Chief of Anugraha Diabetes and Endocrinology Center at Kalburgi. He has been awarded with RSSDA Karnataka Bangalore Best Paper for Diabetes Remission, a remote possibility, and has also presented two cases on ketosis-prone diabetes. I'd like to hand over the dais to Dr. Swaraj Wadenkari for his talk on metabolic control in the surgical patients.
Thank you, ma'am. Thank you for a kind introduction. At the same time, before I begin, I think I will have to thank Dr. Arvind Jagdish sir for giving me this opportunity to share my little bit of experience, whatever I have in treating patients with diabetes perioperatively. The topic given to me was importance of metabolic control before surgery. So basically, in terms of metabolism, I have considered only diabetes and hypertension as the main source of information that I'm going to be giving for the next 15 minutes. So I have skipped the hypothyroidism, and all other endocrine causes because of want of time, because each of that topic in itself can be considered as a topic in itself. One second, some issue with okay, thank you. So we all know we are living in this world of pandemic of diabetes. Long before COVID came, diabetes was giving its signs and symptoms of pandemic to everybody, but nobody was there to listen to it. But now with the pandemic of COVID, we are probably seeing the end of it. We should not forget that COVID has added more number of diabetics to this. Why? Because these are the people who were diagnosed for the first time when they were admitted with COVID, and they were given steroid, and things have got worsened badly for them. Dr. Anjali has already spoken with respect to steroid and diabetes. So with respect to the idea of data, there are around 700 million people by the year 2045. If I talk about Indian studies, okay, my slide isn't moving. So if I talk about Indian data, the data stands around roughly around 8 crore people. It's around 80 million people with diabetes are living in India. So out of which around close to 40 million people are unaware of their diabetes. So of these 40 million people, there will be around roughly around, let us say, 10% who are going for surgery for any time, maybe an elective or an emergency. So this 4 million people will be at risk of a number of things that I'm going to discuss. So it becomes imperative for us to understand why diabetes, treatment of diabetes perioperatively becomes an important aspect. Poor rates of diagnosis and glycemic control in India are roughly around 80 million people, of which 40 million people are unaware. Of this, 10% go to surgery, so it's around, let's say, around 4 million people are going for a surgery. Then this diabetes becomes an important part that we have to address. So why should we be worried with respect to diabetes during surgery? Okay, patient has surgery, patient has diabetes, they will go for surgery. What is the big deal? Just like a normal illness, but that doesn't happen that way. So we'll have to consider so many things. So what happens in a person with diabetes? What are the things that we should be worried about? So surgical procedures may increase the result of they alter the number of metabolic perturbations that can alter the normal glucose homeostasis. Hyperglycemia is a risk factor for postoperative sepsis, endothelial dysfunction, cerebral ischemia, impaired wound healing, and some acute emergencies can be precipitated either intraoperatively or postoperatively, like DKA and HHS, if glycemic control is not maintained properly. So recent evidence suggests that the careful management of glucose in patients undergoing major surgeries will minimize this negative sequelae and promote a better health outcome. Complications of non-healing wounds are more prevalent in diabetics and with impaired healing because of higher glycemic levels. If they are not well maintained, leads to the morbidity as well as more of financial stress to the patient due to the increased number of hospital stays. So metabolic response to surgery and anesthesia, trauma associated with surgery results in increased production of stress hormones, the magnitude of which depends on the severity of the surgery and any associated post-operative complications. We all know in stress, the catecholamines and the cortisol levels are increased drastically, and which is one of the reasons why the insulin sensitivity is decreased. So the heightened sympathetic activity reduces insulin secretion, while simultaneously the growth hormone and glucagon secretions are increased, which again causes hyperglycemia. Normal metabolic patterns which change during surgery include a trigger of gluconeogenesis, glycogenolysis, proteolysis, lipolysis, and ketogenesis, ultimately resulting in hyperglycemia and ketosis. So all this stress of surgery and probably few of the anesthetic agents which are used for anesthesia are in fact, if I can use the term, diabetogenic. So diabetogenic, either they may increase the level of glucose in a given patient. They may be either non-diabetic, or if they may be freshly diagnosed, or they may have what is called as stress-induced hyperglycemia. So this is the basic pathophysiology of the metabolic response in a
normal patient, but which is increased in a patient who is having diabetes. So the same thing, more or less, how hyperglycemia happens. Various organs which are involved coming to the pancreas, reduce insulin production, reduce the uptake of free fatty acids and insulin-stimulated glucose uptake, leading to in the adipose tissue, there is increased lipolysis and increased fatty acid production that leads to increase in gluconeogenesis, glycogenolysis, and increase in glucose output, causes hyperglycemia. This hyperglycemia causes mitochondrial injury, endothelial dysfunction, immune dysregulation, and superoxide generation. These are all damaging to the microvascular structure of the vessels. So, how do we manage how do we preoperatively manage patients? What are the key things that we have to consider? Verify target blood glucose concentration with frequent checking of sugars. Use insulin therapy. Simple answer. If anybody asks, I am going for a surgery, what should a patient with diabetes do? The simplest of answer can be, depending on the level of glucose control, insulin, insulin, insulin. There is no other thing that we are supposed to consider, irrespective of what the patient is taking earlier. Perioperatively, if we have to give one drug, the drug of choice perioperatively for a patient with diabetes is insulin. So, insulin therapy is the mainstay of the glycemic control in the perioperative period. Discontinue bigonides, I'll talk about this later. Consider cancelling non-emergency procedures. For example, if a patient has come to you with a fasting of 220 and a BP of 350, he's had a long-standing hernia which is present. Currently, there's no obstruction. So, this patient can be started on insulin roughly around 4 to 6 weeks. And then once the glycemic control is under good control, that is when probably you can plan a surgery. So, if you take a patient who is having sugars of 400 or 500, the chances of decay are much higher. So, what is the goal? To reduce the patient mortality and morbidity, avoid extremes of glycemic control, avoid hyper as well as hypo, maintain good acid base and electrolyte and fluid balance, prevent ketoacidosis, and try to maintain the blood glucose of less than 180 milligram per deciliter. If possible, get an HbA1c. Nowadays, HbA1c is available from a point of control to the Barrett D10 machine, which checks by HPLC method. Most of the labs are having this, and the reports are also available in 2 to 3 hours. So I don't think so. Getting a HbA1c done in either in a tertiary care or in a primary care is of a worry. So if possible, all surgical patients should have a preoperative hemoglobin tested. An HbA1c of less than 7 indicates a good glycemic control. If glycemic levels are grossly uncontrolled, it is better to postpone elective procedures until glycemic control is obtained. And then again, the drug of choice would be insulin, and oral anti-diabetic drugs are better withheld for at least 24 hours prior to surgery. And if emergency, this need not be considered. When the surgical candidates begins to fast to the surgeries, it is essential that we stop the prandial or the mealtime insulin, because the patient isn't taking orally, but we can continue with the basal. So, for example, if the patient is starting fasting at 6 a.m. in the morning, next morning, the previous day's basal, either glargine or etimir or degludec, whichever the patient is taking, patient should be given the same dose of the long-acting. Whereas on the day of surgery, you can skip the short-acting. Patient with blood glucose concentrations greater than 180 while awaiting elective surgery should receive IV infusion to maintain it below 150. So again, this 150, you can, there's a rough calculation that, for example, if a patient sugar is 250, we can start with an infusion of around 2.5 ml per hour. That is 50 units of short-acting insulin in 50 ml of normal saline, and start at 2.5 ml. And then based on the glycemic readings or the glucometer readings every hour, we can decrease the dose. Once the patient is anesthetized, it is recommended that blood glucose be managed as if the patients were in a critical care unit. So the target is to maintain the blood glucose less than 140, or in a younger patients without any much of comorbidities, or less than 180 with patients who are with multiple comorbidities or in an age group of more than 70. Patients with abnormal renal or liver function should be identified preoperatively, since there's a greater risk of hypoglycemia in these patients. So monitoring of sugars perioperatively is a very important thing, and this does not cost much in terms of labor, in terms of cost. Most of the nurses are trained how to check glucometer readings. So check hourly. If a patient who is NPO diabetic and has underwent a surgery, at least for the first 10 to 12 hours, every hourly checking of sugars should be mandatory. So again, this was Mayo Clinic. When sir suggested me that I'm going to talk on it, I went back because the data on this is comes in flashes and goes. So what are the different types of things that we are supposed to be doing? Perioperative evaluation and management of endocrine disorders. This was a thematic review in the Mayo Clinics. So what do they practice there? Perioperative management of non-insulin diabetic medicines. Most of the medicines are withheld. DPP-4 inhibitors, they say take. But I would rather suggest that the previous day of surgery, you can take all the medicines if it is elective. Previous day of surgery, you can take all the medicines that you're taking, but on the day of surgery, most of the drugs are withheld. So one of the things that we should consider, especially in patients who are taking SGLT2 inhibitors, is a euglycemic decay, which the anesthetist, the surgeon, and the intensivist, and the treating physician, all of us should be aware about. So, if the patient is on sulfonylureas, so then considering stopping sulfonylureas is a better option, and then restarting when the patient is taking normal diet. For example, if a lady has underwent hysterectomy, so we usually, the surgical protocol suggests that after 48 hours, she will be given normal diet. So stop at least a day before surgery. So sulfonylurea, stop at least a day before the surgery, and then restart after roughly around 72 hours. So this should be our plan of action. Only thing what we should be considered, what we should be aware of is euglycemic decay when a patient who is on SGLT2 inhibitors. This especially happens when a patient is in comes for an emergency surgery. So with respect to type 1 diabetes, long-acting insulin, evening before surgery, normal dose. But if you know the patient and you've been following them for a pretty long time and they are having hypoglycemia early morning, then you can reduce the dose by around 50%. If intermediate insulin, around decrease the normal dose, consider reduction by around 70 to 80% if the patient is going for a surgery. And on the morning of surgery, if the patient is on long-acting, you can give 50% of the dose. The insulin pump, normal basal rate, and withholding the short-acting boluses, and the pump will be around going at the same speed. Regular human insulin or the rapid-acting analogs, you can give the normal dose the previous day of the surgery. You have to withhold it on the day of the surgery. More or less the same thing that a patient either with type 1 or type 2, we go with the same protocol. So again, another guideline from the British Association of Anesthesists. So more or less, most of the countries follow the same thing. No emergency, stop all the drugs. Whereas if it is an elective ambulatory surgery, you can consider bigonides and DPP-4 inhibitors, but all other drugs should be discontinued. Coming to the second topic, which I tried to summarize with respect to hypertension, we know that roughly around 1.3 billion adults aged 30 to 80 years worldwide have hypertension. 46% of the patients with hypertension are unaware that they have hypertension. Is a major cause of premature death worldwide. Diagnosis, we all know about this diagnosis. Preoperative implications. So just like diabetes, why preoperative hypertension management is very, very important. Yeah, we all know hypertension is usually asymptomatic and may be picked up on a routine blood pressure screening during the clinical assessment for a planned surgery or an emergency surgery. Preoperative investigations or raised blood pressure should be aimed at identifying and assessing renal, cardiac, and the cerebrovascular system. So hypertension and diabetes are usually associated. They already, most of the time, they come together. So people with type 2 diabetes are approximately 2.5 times more likely to develop hypertension. So if the blood pressure is more than 180, 110, the guidelines suggest that the surgery should be ideally delayed, allowing antihypertensive medicines to be initiated. So coming to the elderly, hypertension is common among the in the elder age group, having a prevalence around 60% in people who are more than 60 years. Who, by definition, who are old? The European guidelines suggest that if you are more than 65, you are old, and if you are more than 80, you are very old. So there has previously been concern that antihypertensive therapy in elderly patients may increase mortality and morbidity if they have peripheral arterial disease or heart failure. So these things also need to be considered, so especially in a patient with diabetic and hypertension. It would be ideal to get a 2D echo done before you are planning an elective surgery. Most of the evidence from RCTs demonstrate that antihypertensive therapy in old and very old individuals significantly reduces the cardiovascular morbidity, and all-cause mortality. The NICE guidelines advises people who are more than 80 to have a blood pressure of less than 150 to 90. So how do we pick up the choice? Either for example, let us say the patient has come with an elective procedure and patient BP was checked and it is 160 by 110. So this is the first time you confirm the blood pressure. Sometimes there is white coat hypertension that needs to be taken care of. So you confirm that. Either you may go for a 24-hour ambulatory home recording, or you can recheck in the office again. And if you find that persistently the BP is on the higher side, and if the patient is more than 60 years of age, then I would like to consider CCBs, or the calcium channel blockers, are the first choice of drug, and then probably consider adding a ARB or a ACE inhibitor or a diuretics. So this is a sequence of events in which we proceed. So monitoring, use clinic BP to monitor treatment, measure standing or sitting with the people with type 2 diabetes. Postural hypertension is very, very important. Again, especially when we are dealing with elderly individuals, monitor home. Nowadays, we have automatic home BP readings. Ambulatory BP is different and home BP is different. Ambulatory is wherein the device checks the blood pressure by itself, whereas home BP is you have to educate the patient and tell them that you have to check every 1 or 2 hours depending on the patient's reading. So ACE inhibitors or ARBs hold. So how do we plan for an elective? The patient is on ACE inhibitors or ARBs, hold 24 hours pre-operatively and restart within 48 hours of the surgery. Then if the patient is on thiazide or CCB, no evidence to stop loop diuretics, consider patient to patient. For example, if a patient is elderly, the risk of hyponatremia is much higher, then I think stopping diuretics prior to surgery makes good clinical practice. So preoperative blood pressure values may be used to define perioperative blood pressure targets. Preoperative hypotension may be associated with increased risk. Just as hypertension is associated with its own set of morbidities, hypertension can also cause increased risk of, there is actually increased mortality in people who are having preoperative hypertension. Perioperative risk stratification for patients with hypertension is multifactorial and involves patient, anesthetic, and surgical factors. Demonstration of an association between preoperative hypertension and increased mortality have implications on perioperative care and risk stratification. Recent community guidelines in Britain have introduced more aggressive treatment targets, meaning more patients will be on antihypertensive medication, some of which may be a single pill combination therapy. Guidance exists to help decision making, but ultimately decision should be made on case-to-case basis. One size doesn't fit all. For example, if a patient is taking a younger patient, 40-year-old, coming to you for an elective procedure, then ARBs can be continued till the previous day of surgery. But an elderly individual coming with diabetes and hypertension, for example, if he has had an MI and is undergoing an angiography, then stopping metformin and ACE or ARBs will make more sense than rather continuing them. And this varies from one case to another. Everybody will not fit into this simple set of presentation. You must consider each patient's overall cardiac risk and make decisions based on this rather than based on isolated blood pressure readings. So I think I have done. I think I've done justice to the time. Thank you, sir.
Thank you so much, sir, for your excellent presentation. I think one of the biggest dilemmas that we all will have is what happens when we stop the pre-existing medications, both in case of diabetes and hypertension, especially a patient who is on a higher dose of sulfonylureas. If you stop it 24 hours before the surgery, are we not pushing the patient sugars go up? And starting corrective insulin dosage may not reach the targets. So this is something that we need to be careful about. And how do you address this in your clinical practice?
If a patient is on, let us say, 4 milligram of glimepiride, and if he is planned for an elective surgery, let us say a hysterectomy is planned and the patient is on 4 milligrams of glimepiride, I would rather switch or rather stop the drug and then put on IV insulin on an infusion, calculate the dose, and then probably plan her for 24 hours of additional hospital stay is required so that we can calculate that additional dose. And anyways, 3 days when she will be starting to take orally. So the dose of or the effect of glimepiride will be there for at least 48 hours even after stopping the drug. So that will not push the patient towards any other associated complication or morbidities. That's what I understand and that's what I practice.
May I ask a question, please?
Sir, please, sir.
As you have rightly said, insulin is the only option when we go for surgery. But for a surgery requiring just say 10 to 15 minutes, like cataract surgery and all, what do you advocate? Do you advocate in advance to switch over to insulin, or maybe just on the day of insulin, on the day of operation, we should be just cautious and manage with insulin, and that's all?
Sir, cataract surgery in 95 to 98% of the time, it is an elective surgery, sir. So make sure that the glycemic control, and most of the ophthalmologists, they are very scared to operate in a patient with diabetes. So if the sugars are more than 200, they usually do not touch such patients. Some daring ophthalmologists do surgeries.
Well controlled on oral hypoglycemic.
Then continue the same set of drugs. No need to change, sir, because they'll not be NPO. They'll not be missing their meals. They'll not be put into IV drugs. There will not be much of sedation. So I don't think so changing anything is required. But since it is an elective procedure, make sure that the glycemic control is good before we take up for, because endophthalmitis it is like the patient will pay with their eyes.
Dreaded complication.
That endophthalmitis is much higher in patients who are having diabetes than compared to non-diabetics. So that is why the glycemic control before surgery becomes that much more important.
Thank you.
Thank you, sir.
Thank you, Dr. Swaraj. That was a very crisp and very apt talk. Very much needed. Like you're concentrating on diabetes and hypertension, it was a much needed control. As you rightly said, ophthalmologists are always upright, and other aspect also is that surgeons are always daring. They go with surgery and end up with so much of complications. And
yes.
then they refer to us for management.
Yeah, the problem is, for example, if there is a hernia, they repair the hernia and post-operatively they forget the patient. That is where it comes to us. So that thing is scary.
Thank you, Dr. Swaraj. Thank you for
Thank you, sir. Thank you, sir, for considering me. Thank you, sir.
But we can go to next session, Dr. Sudhir.
Oh, yes. Now, another very important topic in the series, managing in-hospital hyperglycemia. We have learned quite a bit of lessons during Corona period in particular. And for this, we are going to invite Dr. Puneet Saxena. Kindly put on the introductory slide of Dr. Puneet Saxena, please. Dr. Puneet Saxena is Senior Professor of Medicine and Unit Head SMS Medical College and Hospital, Jaipur, MD FICP, FRSSDI, FRCPE, Consultant Physician and Diabetologist at ASA Clinic, Jaipur, Secretary, Jaipur API, Vice Chairman, RSSDI, Raj Chapter, Vice Chairman, Raj API, Organizing Secretary, Epicon 2022, Jaipur, a big feather in his cap, an active pillar of Epicon, a renowned diabetologist. Now the stage is yours, Dr. Puneet Saxena, to talk on this very important topic, managing in-hospital hyperglycemia. Please, sir.
Good evening, everybody, and thank you for the nice introduction, Dr. Sudhir Chandra Jha. And I thank Arvinda that he is organizing such nice programs time and again, and he keeps on inviting us for the same. And thank you very much for the memento which we have received in advance. So it's a nice program, nice to learn that the program runs from day morning to night uninterrupted. And with so much of enthusiasm, it's you behind this all this program and your team. So thank you very much once again. And I've been asked to speak on management of hyperglycemia in hospitalized patients. So it's a very important topic because the numbers of diabetes is going up every day, and you see that the hospitalization happens because. Can you hear me? Yeah. So the hospitalization keeps on increasing. So this is the data which I have taken from one of the journals. So hyperglycemia is a common comorbidity in both medical. That almost 40% of them, they have poor glycemic control, or they are hyperglycemic, whether they are known diabetics or they are newly diagnosed diabetic, and only almost 60% of them, they are normoglycemic. So the recognition and diagnosis of hyperglycemia and diabetes in hospital setting is very important because we know that there are adverse outcomes as far as the morbidity, mortality is concerned. If there is hyperglycemia which is uncontrolled, then all the outcomes they are adverse. So assess the patient for history of diabetes, test blood glucose using laboratory method at least once on admission, independent of the prior diagnosis of diabetes. And patient without history of diabetes, if the blood glucose is less than 140, then monitor with POC testing for 24 to 40 times because you may detect newly diagnosed diabetes or maybe a stress-induced diabetes in that phase. And if the blood glucose is more than 140, then obviously ongoing POC testing has to be there. And patient receiving therapy also with hyperglycemia like corticosteroids, then you have to monitor them with POC testing irrespective of the blood glucose which you detect at the time of admission. And it has to continue for some period of time or at least till the steroids and the diabetogenic drugs, they are being given. And then obviously patient with known diabetes or with hyperglycemia, they need to be monitored and you need to do the blood glucose depending upon the seriousness of the illness of the patient and the blood glucose which is being detected. And you need to test SBA1C if no HbA1c value available from past 2 to 3 months to judge that what is the glycemic control in the recent past, and accordingly you can take decisions for the management. So recognition and diagnosis of hyperglycemia and diabetes in the hospital setting, you can see what I have said here is given in the form of a flow chart over here, and it's almost the same thing. So I'm not going to discuss this, and we move to the next. So A1C, right? We need to test A1C, but then we need to be cautious that it helps in the differentiation of newly diagnosed diabetes from stress hyperglycemia, which is very important. Then assess glycemic control prior to admission and facilitate decision of an optimal regimen at the time of discharge, not only the hospitalization, but at the time of discharge. But we need to be cautious because the values may be altered because of the several conditions, like hemoglobinopathies or high dose salicylates or hemodialysis in particular, because many of the hospitalized patients will have kidney failure or may be undergoing hemodialysis and transfusions. So analysis should be performed in a proper manner of HbA1c so that you don't confuse. And then glycemic goals for non-critically ill patients. So the hospitalized patients, basically those who show hyperglycemia, they fall into two categories. One, those who are in the general wards or maybe in the rooms, and those who are non-critically ill. And then you have a second subset where the patients are in an ICU setting and they are suffering from critical illnesses. So first we talk about the non-critically ill patient. So inpatient glycemic management, the hospital hyperglycemia is taken as any blood glucose more than 140. And stress hyperglycemia is any blood glucose of more than 140, but HbA1c of less than 6.5. And if the A1C value of more than 6.5, then it is suggestive of prior history of diabetes, and hypoglycemia is any blood glucose of less than 70. And if it falls to less than 40, then it falls under the severe hypoglycemia. So the targets in the non-critical care setting, maintain fasting and preprandial blood glucose of less than 140, modify therapy when the blood glucose falls to less than 100 to avoid the risk of hypoglycemia, and at any cost, maintain random blood glucose less than 180, and more stringent targets may be appropriate in a stable patient with previous diet glycemic control. However, less stringent targets may be appropriate in terminally ill patients or in whom there are severe comorbidities, or if there is brittle diabetes where frequent episodes of hypos are present. So achieving glycemic goals in the non-critically ill patient while minimizing hypoglycemic risk should be the target, and the POC testing is the preferred method for guiding ongoing glycemic management of individual patients. Use blood glucose monitoring devices with demonstrated accuracy in acutely ill patients, and timing of glucose measure should match patient's nutritional intake and medication. And the recommended schedules for POC testing, and every 4 to 6 hours in patients who are nil by mouth or receiving continuous enteral feeding.
So achieving glycemic goals in the non-critically ill patients, we continue that role of medical nutrition therapy, because what happens is the moment patient is hospitalized, his condition is that the meal pattern goes erratic. The total intake, the caloric intake also becomes erratic, and medical nutrition therapy at that point of time becomes very important in the glycemic management program of all hospitalized patients with diabetes. So providing meals with a consistent amount of carbohydrate can be useful in coordinating doses of rapid acting insulin to carbohydrate. And to show this, you can see here some of the data were drawn from a study which was done in 2010, that the glycemic measures in patients assigned to consistent carbohydrate or liberal diets in the hospital. So if the diet has been consistent, then you can see the capillary blood glucose, which has been monitored, is well controlled, and even the peaks or the excursions which happen after the meal does not happen. And not only that, the hypos, they are reduced as compared to the liberal diet. So we come to the pharmacological treatment of hyperglycemia in non-ICU setting. Then obviously the anti-hyperglycemic therapy. Most of the patients who are admitted to the hospital in a non-critical setting, they are on OADs, and they are not recommended to continue in the hospital setting, barring a few patients who are old patients and they don't have too much of hyperglycemia, and there you can manage them with the oral, you can continue them with the oral anti-diabetic agents if the blood glucose is under control. But the rest of the patients, or you can say majority of the patients, they need to be switched to insulin. And if the patient is not critical, then subcutaneous insulin is recommended for most medical and surgical patients. Then continuous IV infusion can be given in the selected medical and surgical patients, even in the general ward and in non-critical patients. And obviously in the critical patients, the continuous IV infusion is the mode of choice for controlling hyperglycemia. So insulin therapy preferred regardless of type of diabetes, whether it's type 1, type 2, or type 3, and discontinued non-insulin agents and hospital admission of most patients with type 2 diabetes with acute illnesses. Obviously, type 1, there's no choice. You have to continue with them. And for the secondary diabetes, obviously, the insulin would be the drug of choice. So use scheduled subcutaneous insulin with basal, nutritional, and correction components, and modify insulin dose in patients treated with insulin before admission to reduce risk for hypoglycemia and hyperglycemia. Avoid prolonged therapy with the sliding insulin alone. It's a thing of past, and this mode should not be used or should be discouraged. And nowadays, most of the secondary and the tertiary centers, we will find that we are not using sliding scale these days. So non-insulin therapies in the hospital, if you see, then time action profile of the oral agents can delay in delayed achievement of target glucose ranges in the hospitalized patients, so they should be discouraged. And sulfonylureas are the mainstay of therapy for the Indian population, and we find that when the patients are coming to the hospital, they are on sulfonylureas. But sulfonylureas, they should be stopped because they will not serve the purpose, and they can cause prolonged or severe hypoglycemia also. And metformin is contraindicated, obviously. So in patients, especially with renal dysfunction, and where the contrast based investigation like CT or MR are being done, and in any state associated with poor tissue perfusion where the lactate is already high, so sepsis, CHF, renal failure, even liver failure. So it is not, or even COPD, then where the carbon dioxide or CO2 narcosis is present. So there you have to withdraw metformin also. Then thiazole pioglitazone is associated with edema and CHF, and the action of pioglitazone is very long-standing. So the insulin sensitization persists for a few days, even if you discontinue pioglitazone. So that benefit you can draw, but then it has to be stopped barring few conditions. Alpha glucosidase inhibitor are weak glucosidase, and they don't play any role in the hospitalized patients. And the GLP-1 receptor agonists, they can cause nausea and exert a greater effect on the postprandial glucose. However, but obviously they should also be withdrawn, barring few cold patients where the hyperglycemia is not too much and the comorbid illnesses are mild and well controlled. So insulin therapy is the preferred approach for all these kind of patients. And here I would like to add, even if somebody is on SGLT2 inhibitor, they also should be withdrawn in the patients who are ill, who are not eating, or who are insulinopenic, or who are under acute stress of acute illness and showing hyperglycemia. So the options for this subcutaneous insulin, basal insulin, control blood glucose in the fasting state, determine glargine lactate, you can use, or even degludec, you can use any. Then nutritional insulin blunts the rise in blood glucose following nutritional intake, that is IV dextrose, internal parenteral nutrition, and you can use the analogs where you can use gas for aspartic-glycine or Lispro, or you can use short-acting like regular insulin, and then obviously the correction insulin, which corrects hyperglycemia due to mismatch of nutritional intake and or illness-related factors and scheduled insulin administration. So initiating insulin therapy in hospital, obtain patient weight in kg, or you can judge, calculate total daily dose as 0.2 to 0.4 units per kg per day and choose the dosing schedule. So give 50 to 60% of total daily dose as basal insulin and give 40 to 50% of the rest of the insulin as nutritional insulin, and use correction insulin for basal glucose, blood glucose above the goal, and adjust according to the results of bedside glucose monitoring and adjust dose for NGO status or changes in the clinical status. So insulin therapy in patients with type 2 diabetes is continued non-insulin agents. Insulin naive patients dose 0.3 to 0.5 per kg, and lower doses in the elderly patients and those who are having renal failure, very cautious. And if the renal failure is severe, can obviously can skip the use of basal insulin, and you can right away start with the half dose of regular insulin in the split dose. And then previous insulin therapy, if somebody is there, then reduce the outpatient insulin dose by 20%. Half of the total daily dose as basal insulin given at the same time of the day, and the rest of the half can be equally divided into 3 doses, and which can be given pre-meal in the non-critical patients. So if you see the pharmacokinetics of insulin preparation, that can give us the flexibility of which one to use and when. And we all know about this, so I'm not going into details that how long the short acting will act, how long. So this again is the representation of the same. So there we have, I'm trying to quote you a trial where the sliding scale has been compared with the basal bolus regimen. This was the RABBIT-2 trial in where type 2 diabetic patient where these two therapies were compared, and you can see the difference between the two therapies. In this diagram, you can see the blue colored bars. They are representing the sliding scale regular insulin usage, whereas the yellow ones, they are the basal bolus regime. And if you see that the blood glucose control over the days of hospitalization, so within up to 10 days, it was much better with the basal bolus regime as compared to the sliding scale regime. And if you see that you can adjust the dose of the basal bolus by looking for the fasting state where you can reduce the or increase the dose of basal insulin, and in this trial it was glargine, and you can use the glargine by the blood glucose falls by 7 to 70. And this again is a very good diagram which shows the comparison. You can see here on the left hand side that the sliding scale, the blood glucose control cannot be achieved, and you can see the peak on the day 4 of the glucose where the blood glucose is maintained to more than 250. Whereas if you shift the same patient to the basal bolus regime, then the blood glucose is very well controlled, and you can see on the right hand side of the line, dotted line, that how the blood glucose values are falling. And with the sliding scale, persistent hyperglycemia of more than 250 was commonly seen. And this thing we encounter in day-to-day usage also, where we find that sliding scale insulin led to very erratic control of blood glucose, and persistent hyperglycemia is very often encountered with same. So glycemic variability in a non-critical care patient with type 2 diabetes, and here is a comparison of basal bolus with basal plus, and you can see that the mean glycemic excursion, mean average, you can see, and in the surgical patients, the image was almost same with basal bolus or basal plus regime, whereas in the medical patients, the basal bolus therapy was faring much better. Then hypoglycemia and complications in care patient with diabetes with different strategies. You will see here that the basal bolus and the basal plus, they are faring almost same, but the mortality was higher, slightly higher at the basal plus regime as compared to the basal. And these are the risk factors for the hypoglycemia. For less than 60, when the insulin dosage is high, that is total daily dose is more than 0.5 units per kg, then a previous insulin usage and insulin regimen, where the basal bolus versus SSI was compared. Strategies for reducing risk for hypoglycemia and non-criticals, and by avoidance of sliding scale alone, use caution in prescribing oral anti-hyperglycemic agents.
Hello. I think Dr. Saxena has got disconnected.
Yes, sir.
Okay, you can conclude, sir. You can conclude that's a particular session, sir.
So this was a wonderful session. Hyperglycemia in a special situation. Unfortunately, we could not complete Dr. Puneet Saxena's deliberations, and we'll be concluding this session. We'll be thanking again. I personally thank my friend Dr. Arvind Jagdisha for the wonderful conference he has managed, and so many people and so much interest. Whole day deliberations is going on. Congratulations, Dr. Arvinda. We may proceed for next session.
So we have come to the end of the session, sir, in Hall B, Basaveshwara Hall. So I thank Dr. Sudhir Chandraja, Dr. Surekha Shetty, Dr. Anjali Bhatt, Dr. Puneet Saxena, and Dr. Swaraj for the wonderful deliberation and taking your time out of your busy schedules and being a part of our conference. I wholeheartedly thank you for your valuable
All
time.
tiredness gone by seeing your handsome face.
For the opportunity.
Thank you, sir. We conclude the session tomorrow morning. We'll join at 9 to 10 is the postgraduate session. We have an interesting for the postgraduate different theme symposium. It will be a competitive session for with prizes for. So they'll be joining at 9 to 10. From 10 to 6, once again we have this continuous session going on with a different interesting topic. Please do join for those sessions, sir. Thank you so much. I thank Dr. Shweta for successfully coordinating this session today and the RX events for the first day successful events. Thank you so much. we are ending this session in Hall B. Last session is going on in Hall A. Kindly join in Hall A, please. Thank you so much.